हम्म,
सर इससे आगे इससे पीछे ये स्लाइड से इधर ये
पॉइंटर पॉइंटर कौन सा
ये
है? ओके, एंड
इसके ऊपर इससे होगा।
ये आगे करेंगे. ओके.
Very good morning. After a tiring scientific program yesterday, now we are again starting today's scientific program, and we invite a senior physician from Jamshedpur, Dr. N.C. Singhal sir. So over to you, sir.
Thank you, sir. Thank you, chairpersons, and very limited audience. I wish some more of you are there. But anyway, we can't waste time because there's a big program. So what I'm going to speak to you today is about, it's hepatology and cardiology. And the topic is regarding the cirrhosis of liver and cardiac dysfunction. Okay, so portal hypertension and cardiac dysfunction. Now, the general physicians may have seen a lot of patients moving around cirrhotic livers, CLD with ascites. But patient is quite comfortable. He is moving around, and little do we think that this person may have some intrinsic heart disease. So even I did not know, but when I went into the study of this subject, I found that there are a lot of evidence about the involvement of heart in chronic liver disease. Now this is the outline of my subject. Now coming to the introduction, what is portal hypertension? You see, liver is there, portal vein is there, spleen is there. So portal hypertension is elevated pressure in the portal vein, and portal vein is that vessel which links the blood flow from the GI tract and spleen to the liver. Normally, the pressure difference is hardly between 5 to 10 millimeter mercury. But when there is intrinsic liver disease, there is back pressure and the portal vein pressure rises. Now, if the pressure is more than 10 millimeter mercury, we label it as portal hypertension. Now, portal hypertension results from dysregulation of the liver sinusoidal endothelial cells and hepatic stellate cells in chronic liver disorder, which increases intrahepatic vascular resistance. Cirrhotic cardiomyopathy represents the clinical manifestation associated with circulatory system disorder resulting from portal hypertension. And this is the primary factor contributing to hyperdynamic circulation resulting from the overactivity of the neurohumeral axis. Epidemiology, experts have noted a rising incidence of cardiovascular disease in patients with liver cirrhosis. Prevalence of cirrhotic cardiomyopathy, you can just see, it's 44 to 68% of patients with cirrhosis depending upon the criteria. Though it varies greatly by reference criteria, it is prevalent and requires therapeutic attention. A retrospective analysis of nearly 1,000 patients revealed a significant prevalence of cirrhotic cardiomyopathy in 58.3% of patients with portal hypertension identified as the sole independent risk factor for CCM. Now, this is the history. As you see on the extreme left, the studies have shown that in 1953, the first evidence came in which the hemodynamic disturbances were seen in patients with malnutrition and cirrhosis secondary to chronic alcohol use. Now again in 58, another study described non-invasive and invasive hemodynamic parameters in patients with cirrhosis, including warm skin, bounding pulses, elevated cardiac output, and low vascular resistance. Again in 69, further studies, they did invasive hemodynamics in patients with cirrhosis. An abnormal response of left ventricular end diastolic pressure and mean pulmonary artery pressure was seen. Again in 96, there was another study. They labeled the term as cirrhotic cardiomyopathy, describing the ventricular abnormalities seen in patients with cirrhosis when subjected to physiological stress. And the first set in 2005, the first set of diagnostic criteria for cirrhotic cardiomyopathy were released following the World Congress of Gastroenterology in Montreal, outlining criteria for systolic and diastolic dysfunction. And finally, in 2020, revised criteria proposed by the Cirrhotic Cardiomyopathy Consortium, considering advancements in echocardiography and updated echocardiography guidelines. Now, I am not going to waste time on classification of portal hypertension. We have the prehepatic, intrahepatic, posthepatic. Prehepatic involves the portal vein. The hepatic involves the sinusoidal, pre-sinusoidal, post-sinusoidal, and then the hepatic veins, inferior vena cava. The most common is the Budd-Chiari syndrome, congestive hepatopathy. Classification of cirrhotic cardiomyopathy, you have the early stage and late stage. In stage A and stage B, the different areas, high risk for, in section stage A, you have high risk for heart failure without structural heart disease or symptoms. And stage B, one step ahead, structural heart disease without signs of symptoms of heart failure. In stage C, you have structural heart disease with prior or current symptoms of heart failure, and stage D, you have the refractory heart failure requiring specialized interventions. Now, this is the pathophysiology of cirrhotic cardiomyopathy. On the left, you see the liver, there is portal hypertension, there is hyperdynamic circulation, there is a neurohumeral axis activation leading to cirrhotic cardiomyopathy, which can be diagnosed by echo abnormalities and by ECG. ECG shows a prolonged QTc interval, and echo shows a diastolic dysfunction, systolic dysfunction, or with preserved increased left ventricular function with stroke volume. This is more or less what I have spoken to you earlier. This is the pathogenesis, again cirrhosis, portal hypertension, ultimately with various pathological abnormalities, you get a diastolic dysfunction and a systolic dysfunction. Now, what are the risk factors? It can be coronary artery disease, systemic inflammation, oxidative stress, insulin resistance, all leading to, and also MASLD. These are all the drivers of CV mortality in patients with cirrhosis and CAD. Diagnosis, the most important is the echocardiography, in which you find the systolic dysfunction, diastolic dysfunction. Electrocardiography, you have the prolonged QT interval, you have the MRI, cardiac MRI, which shows a hyperdynamic left function, left ventricular function, and stress testing. Then you have the BNP, NT, pro-BNP levels, they have increased values. You have the troponin, elevated values associated, and then you have another marker, which is the galectin-3, which shows elevated values. Transthoracic echocardiography is the primary imaging modality recommended by the 2019 CCM diagnostic criteria, in which the left ventricular ejection fraction less than 50%. This occurs in the cirrhotic cardiomyopathy, and there is also a term known as the GLS, which is less than 18. Sumit is sitting there, he must be knowing about all these. So, these are echocardiographic findings. Then you have on the right, you have the left ventricular volume index, velocity, average E by E, two-dimensional echocardiography, LVEF less than 50%, speckle tracking echocardiography is another method, and then you have the Doppler echocardiography, and you have the standard two-dimensional echocardiography. And patients with cirrhosis, especially in advanced stages, you have the stress echocardiography. Patients with early diastolic dysfunction may have similar hemodynamics, and this may become abnormal on exercise. Change in the diagnostic criteria, again you have the systolic dysfunction, any one of the following: LVEF less than 55%, E by A less than 1, and prolonged QTC interval. And in cirrhotic cardiomyopathy, consortium criteria LVEF less than 50% and septal E velocity less than 7 centimeter per second. The clinical relevance, not much. Then you have the diagnostic algorithm. All these is connected with the therapeutic role. You have the beta blockers, you have the ivabradine. Beta blockers are diuretics, aldosterone antagonists, and FXR modulation. Management of cirrhotic cardiomyopathy is often, actually CCM is often asymptomatic and goes undiagnosed till it presents later with signs of heart failure and acute decompensated cirrhosis or after TIPS placement. There is no specific treatment, and due to the marked peripheral vasodilatation and resultant hypotension associated with cirrhosis, vasodilators that are used in non-cirrhotic heart failure are unsuitable for the treatment of CCM. For example, ACE inhibitors or ARBs are contraindicated in patients with decompensated cirrhosis because of the risk of hypertension and hepatorenal syndrome. These are the therapeutic targets. Then you have the various studies in which showing the beta blockers, propranolol, metoprolol, exercise, role of albumin, then taurine, spermidine, galectin-3 inhibitors, statins. This is another area which improves the cirrhotic cardiomyopathy, elevates oxidative stress in hepatic cells, improves liver fibrosis, exhibit anti-inflammatory and anti-fibrotic effects, and this is spermidine is antioxidant, and albumin has anti-inflammatory and anti-oxidative effects. Bile acids, taurine, they help. Galectin-3 inhibitor also improves left ventricular function, reduces cardiac fibrosis and inflammation, and reduces risk of heart failure. Management concentrates, you have the oxygen therapy, you have the sodium restriction, you have the diuretics, beta blockers, which reduce risk of bleeding and esophageal varices, alleviate systemic inflammation by reducing portal pressure, and they shorten the QTC interval found in CCM. However, there are currently no proven specific benefit treatments for cirrhotic cardiomyopathy. This is effects of beta blockers in the various studies. Liver transplantation remains the definitive cure for cardiovascular abnormalities of cirrhosis. These are the various considered dependent on the phase of care. Management of pre-transplant, pre-operative phase, intraoperative, post-operative phase. And this is the CCM treatment. Heart failure treatment is the main, and ultimately liver transplantation. You have the MRAs, you have the ACE, and you have the beta blockers. And future direction studies are going on for mortality, renal dysfunction, bleeding, decompensation risk, and other things. Future directions for CCM. Now, the key takeaways are cirrhotic cardiomyopathy is a complication of portal hypertension and cirrhosis, potentially leading to further morbidity and mortality. Up to 68% of patients with cirrhosis experience cirrhotic cardiomyopathy. Only definitive cure to CCM is liver transplantation, and various potential therapeutic targets have been identified and therapy are in the pipeline, and there is a need for further research on diagnosis, treatment and development of guidelines for cirrhotic cardiomyopathy. Thank you very much for a nice hearing.
Thank you, Dr. Singhal, for very brilliant presentation, and you have completed the paper in time also. Please take your seat. The next paper is by Dr. Soumya. It doesn't need any introduction. He is well known to all of us. He is a very good colleague of me. He is going to present managing Charcot foot in diabetic patients, walking a fine line. Dr. Soumya, please.
Very good morning. First of all, thank you, the organizing committee, for giving me this opportunity. Thank you, Chairperson, for your kind words. So, my topic is managing Charcot foot in diabetic patients. Though it's a very big subject, I will try, in a nutshell, the brief salient points. The Charcot foot has been first described in 1868 by Jean-Martin Charcot. Neuropathic osteoarthropathy is a non-infective destructive lesion of a bone and joint resulting from a fracture or dislocation or both in a patient who has diabetic peripheral neuropathy. A chronic and progressive joint disease following loss of protective sensation and leads to destruction of joints and surrounding bony structures. Without early diagnosis and intervention, Charcot foot can lead to deformity, ulceration, and in severe cases, amputation and, of course, systemic sepsis. Now about the prevalence. Diabetic Charcot arthropathy usually underdiagnosed many a times. Progressive destruction of foot and ankle joint with a reported prevalence ranging approximately from 0.08% to 13% in a diabetic population. In a study, in about 1475 type 2 diabetic patient, the prevalence was found to be 9.8% with male predominance. Now the risk factor: diabetic peripheral neuropathy, spinal cord injury, syphilis, syringomyelia, chronic alcoholism, poliomyelitis, leprosy, traumatic nerve injury, congenital insensitivity to pain. A pathophysiology a bit complicated. I will try to explain in brief. There are some theories: neurotraumatic theory, neuropathy, then after repeated microtrauma leads to joint destruction. Neurovascular theory: increased blood flow leads to osteolysis and bone demineralization. Molecular biology: inflammatory cytokines may cause destruction of interleukin 1, TNF alpha, which leads to increased production of transcription factor kappa beta. Basically, pathogenesis is multifactorial. There is a central role of inflammation and receptor activator of rank and osteoprotegerine pathway in acute phase of the disease, resulting in serum overexpression of the RANKL, which leads to increased osteoclastic activity, osteolysis and bone destruction. Major cause is peripheral and autonomic neuropathy, loss of protective sensation, thereafter repeated unnoticed microtrauma, continued weight bearing because patient cannot feel it because of neuropathy, local inflammation. Autonomic neuropathy leads to increased blood flow, bone resorption. Excess inflammatory cytokines leads to increased osteoclastic activity, thereby rapid bone destruction. Reduced CGRP from damaged nerve further worsens the bone loss. This all results in fracture, joint instability, midfoot collapse and deformity. Now about the diagnosis. Charcot is misdiagnosed in about 25% of cases, leading to delays up to 7 months in correct diagnosis. This is a fallacy. Like cellulitis, septic arthritis, foot ankle sprain, gout, foot ankle fracture, pseudogout, deep vein thrombosis, osteomyelitis. Basically, this with osteomyelitis and Charcot foot are very commonly misdiagnosed. The salient, the features are here. We can see the ulcer in osteomyelitis, majority, but in Charcot usually no, but warmth will be there. The involvement, metatarsophalangeal joint, interphalangeal joint and hindfoot like calcaneus are involved in case of osteomyelitis, but basically it is a midfoot, subarticular. X-ray may be normal in the first few weeks. MRI marrow edema in the forefoot and handfoot in case of osteomyelitis, but here in the midfoot we can see the marrow edema. Now about the clinical presentation. Acute Charcot, swelling of the foot and ankle, pain sometimes be present in about 50% of cases, loss of function, warmth 3.3 degrees Celsius more and erythema. Chronic Charcot structurally deformed foot because there is already bone destruction has been established. Rocker bottom deformity, that is a typical appearance of late foot Charcot. Collapsed medial arch. Clinical assessment, compare affected limb with the contralateral foot. Assess for swelling, erythema, increased skin temperature and foot deformities. Pain is often minimal or absent due to neuropathy. Temperature difference is more than 2 degrees Celsius measured on the dorsum suggestive active Charcot. This is a very important point. So, home skin temperature monitoring with patient diary is strongly recommended. Lab assessment, inflammatory marker like CRP, ESR may assist in excluding infection, but they have limited sensitivity and specificity. Emerging biomarkers like interleukin 6 is strongly associated with early Charcot. If it is more than 6.6, which demonstrates good diagnostic performance. Now, imaging, plain X-ray, basic and very important, may show osteolysis, bone fragmentation and joint collapse. Useful for identifying established structural deformity, but they have limitations like sensitivity in the early stage of disease. It may be normal. About nuclear medicine, 3-phase bone scintigraphy with SPECT-CT scan is the alternative diagnostic method. Leukocyte level scans aids in differentiating infection. Technetium bone scan may be positive in both infection as well as Charcot conditions. 111 indium WBC scan negative in Charcot but positive in osteomyelitis. About MRI, detects bone marrow edema and early inflammatory changes, help to differentiate osteomyelitis with Charcot. Now, imaging, which is very important. Weight bearing bilateral radiograph is a must. The patient should weight bear, patient should be standing. We use dorsoplantar view, lateral view, pronated oblique view, which can be normal in early stages. Remember, in case of acute Charcot, flattening of the metatarsal heads is the first sign, as you see in the radiograph. Also, early finding is a focal demineralization. Strong indicators are absence of soft tissue involvement. Polyarticular distribution, mainly midfoot, subcondylar or periarticular changes in the midfoot, involvement of the interphalangeal joints and the ankle joints are very less common. In chronic Charcot, remember the rule of 6 Ds: distension of joint, destruction, dislocation, disorganization, debris and density, which is sclerosis. The hallmark, midfoot or tarsometatarsal, that is a least frank typically affected. Collapse of the longitudinal arch, as you can see, plantar subluxation of the hindfoot, dorsal subluxation of the metatarsal bases, increased loads on the cuboid causing a rockered bottom deformity. That is a typical appearance of the chronic Charcot. But remember, there are some, of course, limitations. Subtle changes such as occult fracture, bone marrow edema not detected. Low sensitivity and specificity rate in the detection of the early Charcot. Now, do all patients require MRI scan? If plain X-ray is normal and there is a strong suspicion, then go for it. Overlying ulcer for a better soft tissue details, to differentiate diabetic foot osteomyelitis with the Charcot, and for the follow-up for remission. When do we need nuclear scans? Which is not usually found in the rural areas. It is found in the higher centers. Not required routinely. Follow-up for quiescence for active Charcot. When skin is ulcerated as a result of Charcot deformity, when secondary osteomyelitis is a possible complication. About classification, Eichenholz classification, this is basically according to the stages of the progression. Stage 0, here radiographs are negative. Stage 1, radiographs show osseous fragmentation with joint dislocation. Stage 2, that is the coalescence phase. Radiographs show coalescence of fragment and absorption of fine bone debris. And lastly, reconstruction, the radiographs show consolidation and remodeling of fracture fragments. Sanders and Friedberg's classification according to the anatomical location, where the pattern 2, there is 5 patterns. The pattern 2 is the tarsometatarsal joints are most commonly found, that is about 45%. Brodsky's classification is another classification. I am not going in detail. This is a very important slide. Look carefully. When you have a clinical suspicion of Charcot foot, do X-ray first. That is a mandatory. Then, if it is positive, straight away offloading. Question doesn't arise. And if it is effective, After consolidation, prescribing footwear for the follow-up. If it is ineffective, then comes the surgical management. And here also, after consolidation, offloading and close follow-up. And when the X-ray is negative, then comes MRI and nuclear imaging. If it is positive for osteomyelitis, then treat the osteomyelitis first. If it is negative, then Charcot is very unlikely. And if it's positive, the same treatment modality. Now about offloading. This is a cornerstone of the management in the acute stage of the disease to arrest progression and prevent deformity. Frequent cast changes are required to prevent pistoning, that is due to volume reduction, as when the limbs get immobilized, the edema decreases so that the fit of the cast get loosened. Initial cast replacement, as I told you, 3 days, then weekly review and recasting as edema rapidly subsides. Irremovable total contact cast is the gold standard, and that is the mostly preferred modality. Encourage strict non-bearing using crutches or wheelchair whenever possible. Continue offloading until you see the resolution of the swelling as well as the edema. Temperature difference is very important. That should be less than 2 degrees Celsius when you compare with the contralateral foot. Clinical monitoring, edema, erythema, temperature assessment and radiographic evidence. Basic. But after resolution, transition should be prescriptive soft footwear, custom boots or weight bearing braces. But requires frequent follow-up and long-term monitoring to reduce the recurrence, which is very common. Anti-resorptive therapy, the treatment rationale is active Charcot involves increased bone turnover like biphosphonate, maybe oral or IV, studied in some clinical trials. IV, pamidronate or zoledronic acid may be used if oral agent is not tolerated. Safety-wise, single IV dose usually does not require, but when you need the more doses, then there should be caution in case of renal impairment or compromised kidney. Intranasal calcitonin reduces bone turnover and may be safer in renal dysfunction. About bone growth stimulation, but they have got very limited evidence. Ultrasonic bone stimulation, direct current electrical bone growth stimulator, but they are currently used mainly as an adjunctive therapy in the post-surgical setting, not as a standard care of conservative management. Alternative to total contact casting, like irremovable knee-high walker, Charcot restrained orthotic walker, patellar tendon bearing cast, custom therapeutic footwear, depending upon the patient's condition, the progression of the disease, as well how the adherence of the patient to the treatment. Now about the surgical management, the goals of the surgery is achievable a stable plantigrade foot resistant to ulceration, to prevent amputation and improve quality of life. Indication: when there is a severe instability of foot or ankle, varus or valgus deformity, patient may fall down, acute dislocation of foot or ankle, infected long-standing refractory ulcers, and lastly failure of conservative management. Internal fixation, I am not going in details about the surgical procedure, and of course external fixation, sometimes both are recommended, internal as well as external. Now the complications: flat foot, rocker bottom foot, hammer toes, ankle equinus contracture, ulceration, bony prominences, infection, amputation, but most importantly recurrence of Charcot joint. Now prevention: educate patient on proper fitted footwear, light weight footwear, feet abnormalities. Prognosis mainly depends on the treatment adherence, which is very important, timely immobilization, glycemic control. And non-adherence worsens the outcome, that is delayed healing, increased deformity, high risk of ulceration and amputation. Some guidelines: RSSDI guidelines, primary approach for the conservative management, offloading with the total contact cast, non-weight bearing, continued until the acute phase of inflammation subsides, may take weeks to months. Alternative is Charcot restrained orthotic walker. Duration: reduction of edema, and the skin temperature again is very important, should be less than 2 degrees Celsius when we compare with the contralateral foot. Late stage management is reconstructive surgery. If there is a significant deformity, the goal is to achieve plantigrade foot. And prevention of recurrence, therapeutic footwear is very important, providing 30% of pressure offloading, which reduces the risk of recurrence and ulceration. Conclusion, TCC is the gold standard. Biphosphonate increases BMD, but effect on clinical resolution are doubtful. Denosumab is another option for acute Charcot. Teriparatide may be useful for chronic Charcot. These are all human monoclonal antibody injection treat osteoporosis by inhibiting rank L protein. And chronic Charcot patient need close follow-up and to prevent higher mortality. To summarize, Charcot 4 is a limb-threatening complication of a diabetic neuropathy requiring early recognition and prompt intervention. Accurate diagnosis through clinical assessment, staging and appropriate imaging prevent delay in the treatment and inappropriate management. Immediate offloading and immobilization are the cornerstone of the management and prevent progression of the deformity, and long-term prevention relies on the patient education, protective footwear, regular follow-up and strict treatment adherence. Managing Charcot is not a science, it's an art. Thank you for your patient hearing.
Thank you, Dr. Soumya Sen Gupta, for your very nice presentation. Please take your seat. The question and answer part will be dealt in the last. The next speaker is Dr. Anish Chaudhary, who is going to present on radiology and its implication in diabetic complication. How helpful can it be? Dr. Anish Chaudhary.
Good morning. Good morning, everybody. I'm here to present. The detection and management of diabetic complications. How a radiologist can help the physicians. Diabetes is a chronic metabolic disease characterized by insufficient utilization and deficiency of insulin, leading to hyperglycemia. Long-term uncontrolled diabetes causes organ damage, and radiological investigations guide early detection and monitoring of complications for better prognosis. There is increased risk of CVD, myocardial infarction and stroke and heart failure. These are the stats of IDF, and radiological investigations help to guide early detection and proper screening to avoid complications. India being the diabetic hot seat, this is the projected stats that there will be a 73% increase in the number of cases by 2050. There are basically 5 types of diabetes, and type 2 being the most prevalent one, in which it is mostly lifestyle related. Complications of diabetes can be grouped into microvascular and macrovascular, in which microvascular consists of retinopathy, nephropathy, neuropathy. Macrovascular causes are coronary artery disease, stroke, peripheral vascular disease. In investigating cardiovascular complications, basically CT coronary angiography these days are being used for calcium scoring, which detects atherosclerosis, vascular narrowing and calcifications. These are the 2 images in which this is the normal image showing no calcification of a normal patient, and this is the patient with calcium score of 1200 and more, in which the coronary arteries are having calcifications. It is done by a Agatston score system, in which the density of the calcification with and the area which it is occluding is further categorized, and then it is interpreted, 0 being the normal or no calcified plaque, and more than 1000 being massive calcification and having a high risk of having cardiovascular complications. Stroke is in diabetes. There is increased cerebral small vessel disease, including lacunar infarct, white matter lesion, microbleed, and it is often detected by a neuroimaging, which consists of CT and MRI. And in the CT, we can detect the infarct, which is, and it is also in very early stages can be detected by MRI, diffusion weighted imaging. Carotid Doppler also helps to assess the stenosis at real time level, and it can be categorized to avoid any catastrophic events. Carotid Doppler in a diabetic patient can be done. There is a increased chances of increased intima medial thickness. It is the thickness of the lining of the vessel, and more than 0.7 mm often lead to some atherosclerotic events, according to the many publications. This is an image showing a normal patient at the level of the carotid bulb, and this is an abnormal blood flow in which this is the plaque. It is causing the constriction of the lumen, and you can see there is aliasing, the mixing of the color, and post-stenotic increase in the velocity. 44% of the diabetic patient may show carotid artery disease with a high risk of simultaneous plaque formation in both carotid and peripheral arteries, and it can be on real-time basis evaluated by the Doppler investigations. And there is, as I have said earlier, there is strong correlation between increased intima media thickness and peripheral vascular disease. Diabetic nephropathy can also be in a very early stage depicted by the ultrasound investigations. CKD is normally defined as GFR less than 60 milliliter per minute for more than or 3 consecutive months with or without kidney damage. And ultrasound helps depict the kidney size, cortical echogenicity, and corticomedullary differentiation. And it is normally graded into 3 types: grade 1, grade 2, grade 3. Grade 1 being the mild parenchymal disease in which the kidney sizes are normal, and grade 3 being the severe parenchymal disease in which there is reduced kidney size, echogenic parenchyma, loss of corticomedullary differentiation, and when with or without presence of irregular cortical margins and cysts. In renovascular cases of hypertension, renal artery stenosis can also be depicted by Doppler. So here in this image, the arrowhead is showing the renal artery stenosis, and this arrow is showing the increased blood gust post-stenotic dilatation. And when velocity was measured, it was more than 300. The normal velocity is around 100 up to 100 centimeter per second. In cases of renal artery stenosis, when measured, it goes more than 150, and which is a characteristic for considering it as renal artery stenosis. This is a renal angio 3D formatted image in which we can see the normal renal artery on the left side and renal artery stenosis being depicted here. So it is easily depicted on CT renal angio, and it is common in patients with diabetes with a prevalence of 30 to 40% with coexisting hypertension and renal inefficiency. So we should also look for this CT renal angio when in refractile cases of hypertension. Diabetic neuropathy. MRI and CT helps to exclude structural causes, and radiology plays a main role in detecting secondary changes, nerve abnormalities, complications such as Charcot arthropathy and diabetic foot, which was very depicted by my previous speaker, Dr. Soumya Sen Gupta. So here, these are the MRI, high resolution MRI images in which we can see there is muscular atrophy, there is perineural edema, and also there is edema in the neural linings. So it is very well depicted. So MRI is forms the one of the mainstay for diabetic for detecting diabetic neuropathy. So this is a classification, this is a depiction for to differentiate osteomyelitis versus active Charcot, which was there is presence of ulcers and the involvement of the calcaneum. In active Charcot, the midfoot is mainly involved, and in early stages, X-ray is not that much diagnosing, and if suspected, we can go for a MRI scan in which we can see there is soft tissue edema and the bony edema in the midfoot region. Fatty liver in diabetes is a menace, and it is easily depicted when gone for ultrasound and CT. So this is the classification showing normal liver and a grade 3 classification severe, in which we compare the shades with the respective spleen, and accordingly with the difference of the Hounsfield unit HU values, we can grade it as mild, moderate, and severe. These days, liver elastography is having increased role, in which active color-coded grading can be done, and accordingly the patient can be diagnosed. Bone health index, as it detects osteoporosis and fracture risk, so it is also very helpful in seeing the vertebral fractures and micro architectures. So the importance of radiology helps early detection of complications, monitoring disease progression, guiding treatment planning, and improving your patient outcomes. Thank you.
Thank you, Dr. Chaudhary, for your excellent deliberation. And for the last topic of this session, I would like to invite Dr. Otri Gangopadhyay. He is a renowned pulmonologist from Ranchi. Now he will be enlightening on us on the topic of significance of pulmonary function testing in diabetes, what every physician should know. Over to you, Dr. Otri.
Thank you, respected chairpersons. Thank you, everyone in the audience. And I'm thankful to CCDSI Bihar and Jharkhand for inviting me, especially Dr. Gagan Gunjan. He is a very dear friend. मैं डायबिटीज़ का प्रैक्टिस नहीं करता हूँ, मैं पल्मोनोलॉजिस्ट हूँ, लेकिन हमारा देश वर्ल्ड का डायबिटीज़ कैपिटल है, और जितना तेज़ी से आईटी इंडस्ट्री ग्रो कर रहा है, डायबिटीज़ उससे तेज़ी से ग्रो कर रहा है, तो मुझे भी थोड़ा थोड़ा लिटिल डायबिटीज़ भी जानना पड़ता है, तो मैं आप सबके बीच में हूँ. Significance of pulmonary function testing in diabetes, what every physician should know. I did not use any artificial intelligence to make this lecture, और क्योंकि मैं डायबिटीज़ फील्ड से नहीं हूँ, तो मैं यहाँ बाहर किसी भी ब्रांड को एंडोर्स नहीं कर रहा हूँ, कोई कन्फ्लिक्ट ऑफ इंटरेस्ट नहीं है. स्पायरोमेट्री, पल्मोनरी फंक्शन टेस्टिंग बहुत तरह के हो सकते हैं, जिसमें से सबसे कॉमन, सबसे रेडीली अवेलेबल है स्पायरोमेट्री. स्पायरोमेट्री नॉन इन्वेजिव होती है, रेडिएशन फ्री होती है, कोई नीडल प्रिक नहीं होता है, एंड पेशेंट बढ़िया से बैठा हुआ रहता है, सिटिंग कंफर्टेबली, इस कार्टून की तरह. हु नीड्स अ स्पायरोमेट्री? किसको स्पायरोमेट्री की ज़रूरत है? जिनको भी सांसों की ज़रूरत है। हम लोग जितने लोग इस कमरे में बैठे हुए हैं, हम सब सांस ले रहे हैं, लेकिन हमें पता नहीं चल रहा है कि हम सांस ले रहे हैं। तो अगर किसी मरीज को पता चल रहा है कि वो सांस ले रहा है, अगर उनको अपनी सांसों की ज़रूरत है, मतलब उनको स्पायरोमेट्री की ज़रूरत है। सो नेक्स्ट टाइम इन योर क्लिनिक व्हेन समवन वॉक्स इन and you realize that that person is breathing, maybe that person needs a spirometry. Why may a diabetic need a spirometry? किन किन सिनारियोज में? इंडिपेंडेंट डिजीज, डायबिटीज के अलावा उनको लंग्स डिजीज है जिसका डायबिटीज से कोई लेना देना नहीं है, डायबिटीज रिलेटेड लंग्स डिजीज, ड्यू टू ट्रीटमेंट ऑफ डायबिटीज. लेट्स कम वन बाय वन. जिस तरह हर चमकता हुई चीज सोना नहीं होता, जिस तरह हर ग्राउंड ग्लास कोरोना नहीं होता, उस तरह हर फूलता हुआ सांस पल्मोनरी इडीमा नहीं होता. मेरे पहले भी एक कार्डियोलॉजिस्ट थे और मेरे बगल में भी एक कार्डियोलॉजिस्ट बैठे हुए थे. हमारे देश में सांस फूलने का सबसे कॉमन कारण पल्मोनरी इडीमा है, लेकिन कभी कभी पल्मोनरी इडीमा नहीं होता. 27% COPD हैज डायबिटीज. COPD हम पल्मोलॉजिस्ट की सबसे कॉमन बीमारी है. हमारे देश में क्रॉनिक पल्मोनरी डिजीज में सबसे कॉमन COPD है. 27% COPD और डायबिटीज, और ये एक इंडियन स्टडी है पब्लिश 2023. डायबिटीज हैज 23% इंक्रीज इन मोर्टेलिटी विद COPD. COPD अपने आप में भी बहुत अच्छी बीमारी नहीं है, और जहां COPD के साथ डायबिटीज जुड़ जाए तो मोर्टेलिटी करीब 23% बढ़ जाता है. सो व्हाट आर द वेरियस लंग डिजीज इन डायबिटीज? नंबर 1 एनी डे COPD, लंग फाइब्रोसिस, लंग इन्फेक्शंस, स्मॉल एयरवे डिजीज. ये थोड़ा सा नया कॉन्सेप्ट है, उसके बारे में भी मैं बताऊंगा. What if my cardiology is normal but I am having symptom? युवराज सिंह अभी हाल में इंडिया ने फिर से वर्ल्ड कप जीता, हम सब बहुत खुश हुए. 2011 में जब इंडिया ने वर्ल्ड कप जीता था, मेरा पैदा होने के बाद पहली बार, मैं 86 में पैदा हुआ था, तो मैं पहला जो वर्ल्ड कप इंडिया का देखा था 2011. वर्ल्ड कप के बाद पता चला कि युवराज सिंह जो मैन ऑफ द टूर्नामेंट है, उसको लंग्स में ट्यूमर है, लेकिन वो मैच कैसे खेल रहा था? यानी मैच से पहले उनके टेस्टिंग भी हो रहा था, कार्डियोलॉजी नॉर्मल था, उसको सिम्टम था, वर्ल्ड कप जिता दिया, फिर पता चला ही हैड ए ट्यूमर इन द लंग्स. सो स्पायरोमेट्री, हाउ कैन इट हेल्प्स? स्पायरोमेट्री में सबसे अच्छी बात है, यू डोंट नीड टू मेमोराइज द नंबर्स, जस्ट बाय लुकिंग एट द ग्राफ यू कैन गिव अ डायग्नोसिस. तो ये जो ग्राफ दिखा रहा है, नॉर्मल ग्राफ होना चाहिए उस ट्रायंगल की तरह, लेकिन जहां उस ट्रायंगल के जहां एक सीसॉ या स्लाइड बन जाती है, तो समझिए यहां श्वास के रास्ते में ऑब्स्ट्रक्शन है, और इस तरह की स्लाइड COPD में होती है. अगर एक रिपोर्ट दिया जाए जिसमें इतने सारे पैरामीटर्स हैं, तो आप कंफ्यूज हो जाएंगे. हम लोगों को इतना सारा पैरामीटर्स जानना ही नहीं है, हम लोगों को गिन के 2 पैरामीटर जानना है. एक का नाम है FEV1, फोर्स्ड एक्सपायरेटरी वॉल्यूम इन 1 सेकेंड. दूसरा है FVC, फोर्स्ड वाइटल कैपेसिटी, और तीसरा है इन दोनों का रेशियो. बाकी कितने भी पैरामीटर्स रिपोर्ट दे, अल्टीमेटली आपको यही 2 पैरामीटर ही जानने हैं जो एक स्पायरोमेट्री से आपको डायग्नोसिस करवा सके. ये कर्व दिखा रहा है कि हम टोटल जितना सांस को जोर से छोड़ सकते हैं, दैट इज FVC, और टॉप ऑफ द कर्व जो वहां पर है, और पहला सेकंड में हम जितना जोर से छोड़ सकते हैं, दैट इज FEV1. जहां भी ऑब्स्ट्रक्शन होती है, यानी श्वास नली में सिकुड़न होती है, तो FVC अनचेंज रहता है, FEV1 कम हो जाता है, गिरते जाता है, तो जिसके कारण FEV1 बाई FVC का रेशियो कम होते जाता है. किताबें बोलती है जहां FEV1 बाई FVC रेशियो 70% से कम है, दैट इज अ परमानेंट और फिक्स्ड ऑब्स्ट्रक्शन नोन एज COPD. तो ये छोटा सा रिपोर्ट से आप बता सकते हैं मरीज को COPD है या नहीं, और कुछ चीजें बता सकते हैं. FEV1 बाई FVC रेशियो लेस देन 70%, यानी फिक्स्ड ऑब्स्ट्रक्शन, यानी ये रास्ता चौड़ा नहीं हो सकता है। प्रोग्नोसिस, FEV1 अकेले आपको प्रोग्नोसिस बताती है, बहुत सिंपल याद रखना है, 30, 50, 80। जहां पर 30 से नीचे है दैट इज वेरी सीवियर, 30 से 50 है सीवियर, 50 से 80 है मॉडरेट, 80 से ऊपर है माइल्ड। तो आपको कोई वैल्यूज रटने का जरूरत नहीं है, जस्ट ये कुछ परसेंटेज समझने से आप बता सकेंगे मरीज का प्रोग्नोसिस कैसा है। नाउ ये डायबिटीज मरीज ना आपका परिवार बन जाता है, जिस दिन से उसका डायग्नोज होता है उस दिन से मरीज आपके साथ है। तो आपने एक स्पायरोमेट्री किया और रिपोर्ट गड़बड़ आया, क्या आप मरीज को किसी और के पास जाने देंगे? नहीं, मरीज को अपने ही पास रखना है। कैसे? एनी डायबिटिक विथ FEV1 लेस देन 50% आपको क्या करना है? प्लीज लुक फॉर बेटर डायबिटिक कंट्रोल। सबसे पहले शुगर कंट्रोल करो भैया। प्लीज लुक फॉर अदर कॉम्प्लिकेशंस and closer follow up and prognosticate this patient. FVC, this can give you clue beyond the lungs also. यहां पर एक शब्द है restrictive pattern, मतलब लंग्स फूलना चाहता है, श्वास नली या रोड्स बढ़िया है, लेकिन राज्य का बॉर्डर फिक्स्ड है, राज्य का बॉर्डर बढ़ने नहीं देता है। तो ये कर्व हम देख सकते हैं, नॉर्मल कर्व कुछ इस तरह, जहां पर एक सीसॉ बनता है या स्लाइड बनता है ऑब्स्ट्रक्शन, और ये नॉर्मल कर्व का बौना पैटर्न, ये है आपका रेस्ट्रिक्शन, जहां FVC 80% से नीचे गिर जाती है। यानी अगर नॉर्मल कर्व ऐसा है तो ऐसा इंसान का बौना को हम लोग रेस्ट्रिक्शन मान सकते हैं कि लंग्स एक लेवल से ज्यादा बढ़ नहीं पाते हैं। सो व्हाट इज इम्प्लीकेशन ऑफ रेस्ट्रिक्शन इन डायबिटीज एज पर दैट स्पायरोमेट्री? Disease of the lungs which does not involve the airway like parenchyma, interstitium pleura, cardiac related weakness, DCMP आप लोग डेली देखते हैं लेफ्ट राइट एंड सेंटर, HFpEF आप लोग डेली देखते हैं लेफ्ट साइड एंड सेंटर, कार्डियक रिलेटेड वीकनेस, मसल रिलेटेड वीकनेस, नर्व रिलेटेड वीकनेस। नर्व वाले डॉक्टर साहब मेरे बाद बैठे हुए हैं, थोड़ा सा मैं आपका इंट्रो दे दिया। स्मॉल एयरवे डिजीज ये एक नया कॉन्सेप्ट है। माइक्रोवैस्कुलर कॉम्प्लिकेशंस हर ऑर्गन में होती है और ज़रूरी नहीं कि ये केवल ब्लड वेसल में हो। माइक्रोवैस्कुलर कॉम्प्लिकेशंस छोटे छोटे स्मॉल एयरवेज में भी होती है, क्योंकि लंग्स के स्मॉल एयरवेज में द कैपिलरी एंड द एयरवेज आर टुगेदर पार्ट ऑफ द सेम एनाटॉमी। इसको ब्रोंकियोलाइटिस बोलते हैं। It is very difficult to diagnose and suspect because it is never an isolated event. इसके साथ coronary artery disease बहुत कॉमन होता है, इसके साथ कार्डियक मायोपैथी बहुत कॉमन होता है। FEF 25 से 75 ये उस स्पायरोमेट्री में एक रिपोर्ट होता है जो हमें स्मॉल एयरवे डिजीज के बारे में बताता है, लेकिन ये बहुत एडवांस नहीं है। अभी कुछ नए नए टेस्ट भी आते हैं जो स्मॉल एयरवे डिजीज इन डायबिटीज के बारे में बताती है। नाउ आप क्लिनिक में बैठे हैं और एक मरीज आपके पास आया, तो इस मरीज में आप स्पायरोमेट्री रियल लाइफ में कैसे यूज करोगे? मिडिल एज पर्सन, डायबिटिक फॉर 10 इयर्स, रीसेंट ब्रेथलेसनेस, सबसे पहले आप जरूर कार्डियक देखना, लेकिन कार्डियोलॉजी इवैल्यूएशन नॉर्मल है। अब क्या करना है? मरीज को खांसी है, रेस्पिरेटरी सिस्टम देखिए, अगर स्पायरोमेट्री में ऑब्स्ट्रक्शन मिला तो कृपया आप ऑब्स्ट्रक्टिव एयरवे डिजीज, COPD या स्मॉल एयरवे डिजीज के बारे में सोचिए। अगर स्पायरोमेट्री नॉर्मल या रेस्ट्रिक्टिव है तो आप लंग पेरेन्काइमा, इंटरस्टिशियम प्लूरल के बारे में सोचिए। एक चेस्ट रेडियोलॉजी, एक्सरे या CT कराइए। प्लूरल इन्वॉल्वमेंट इन डायबिटीज कौन कौन सा होता है? टीबी प्लूरल इफ्यूजन हमारे देश में बहुत कॉमन है। हार्ट फेलियर से भी प्लूरल इफ्यूजन होता है। किडनी फेलियर, लिवर फेलियर, पैरानिमोनिक इफ्यूजन, कैंसर। पेरेन्काइमा इन्वॉल्वमेंट, निमोनिया, अनकंट्रोल डायबिटीज, कोई शादी पार्टी में गया और वहां पर थोड़ा कोल्ड ड्रिंक्स पी लिया बर्फ के साथ, निमोनिया होगा ही होगा। निमोनिया, टीबी, लंग ट्यूमर। इंटरस्टिशियम इन्वॉल्वमेंट, ILD एंड फाइब्रोसिस। अगर स्पायरोमेट्री रेस्ट्रिक्टिव एंड नॉर्मल है लेकिन चेस्ट रेडियोलॉजी भी नॉर्मल है, एक्सरे या CT नॉर्मल है, तो कार्डियोलॉजी के बारे में फिर से सोचिए। मसल और नर्व वीकनेस सोचिए। वॉल्यूम ओवरलोड लाइक CKD वाला सिचुएशन सोचिए। अगर खांसी नहीं है, ब्रेथलेसनेस है और खांसी नहीं है, तो जनरली ये लंग्स से होना बहुत बहुत मुश्किल है। प्लीज थिंक बियॉन्ड द लंग्स। Obstruction in the absence of cuff is very very rare and spirometry here normal या restrictive होती है। तो ये बहुत सिंपल 3 स्लाइड आप याद रखिएगा कि सांस फूलते हुए मरीज आपके पास आया, सबसे पहले पूछो खांसी है या नहीं, खांसी है तुरंत स्पायरोमेट्री करिए, ऑब्स्ट्रक्शन मिल गया इनहेलर वाले दवा दीजिए, रेस्ट्रिक्शन मिल गया तो एक एक्सरे या सीटी करने का सोचिए, खांसी नहीं है बियॉन्ड द लंग सोचिए। ये आप लोग डेली यूज पे कर सकते हैं। लिस्ट ऑफ डायबिटीज रिलेटेड मेडिसिन दैट कॉज पोटेंशियल लंग फाइब्रोसिस। लंग फाइब्रोसिस कोविड के बाद इसकी बहुत अवेयरनेस बढ़ी है और इसके भी कुछ कुछ अच्छे मेडिसिन आ रहे हैं। एंटी माइक्रोबियल, यूटीआई में आप लोग वेरी रेगुलरली नाइट्रोफुरेंटॉइन यूज करती है, इट कैन कॉज लंग फाइब्रोसिस। एंटी इन्फ्लेमेटरी, एस्पिरिन, मिथोट्रेक्साइड, एनएसआईडी। कार्डियोवास्कुलर एजेंट, एंटी एरिथमिक, अमायोडारोन इज अ वेरी नोन कॉज फॉर लंग फाइब्रोसिस। फॉर्चुनेटली जितने हार्डकोर एंटी डायबिटिक ओरल या इंसुलिन है अभी तक इनका लंग फाइब्रोसिस में रोल नहीं मिला है, तो बाहर हमारे जितने स्पॉन्सर है वो खुश रह सकते हैं, आपका एक भी दवा अभी तक लंग फाइब्रोसिस नहीं करा रहा है। लेकिन किसी किसी का पोटेंशियल इफेक्ट ऑन एनिमल है। मेटफॉर्मिन, GLP-1 रिसेप्टर एंटागोनिस्ट, पीपार गामा एगोनिस्ट, इनका पोटेंशियल एंटी फाइब्रोटिक इफेक्ट ऑन एनिमल दिखना चालू हुआ है। सो शुड अ डायबिटिकोलॉजिस्ट कीप अ स्पायरोमेट्री? आप लोगों को स्पायरोमेट्री रखना चाहिए या नहीं रखना चाहिए? क्यों रखना चाहिए? बहुत आसान है सीखना। डेफिनेटली नॉट कॉस्टली मशीन, बहुत सस्ता मशीन है। ये एक आईफोन उससे ज़्यादा महंगा होता है, आईफोन से सस्ता होता है एक स्पायरोमेट्री मशीन। कंफर्टेबल फॉर द पेशेंट, 1 मिनट लेंगे बस, और एंड नो लीगल रिक्वायरमेंट। एक इको रख के देखिए तो कितना परेशान करेगा सरकार आपको एक इको रखने के लिए, जबकि वो इको मरीजों का जान बचाता है, लेकिन उस इको के लिए सरकार आपको कितना परेशान करेगा PCPNDT से। बायोमेडिकल वेस्ट का झंझट नहीं है, रेडियोलॉजी का झंझट नहीं है, सो नो लीगल रिक्वायरमेंट। और टेक्नीशियन का लाइसेंसिंग का भी टेंशन नहीं है, एनी ऑफ योर स्टाफ कैन बी ट्रेन्ड। फ्रीक्वेंसी ऑफ टेस्टिंग डेली तो नहीं करना है, हर डायबिटिक को नहीं करना है। 40 साल के ऊपर एक बेसलाइन स्पायरोमेट्री करिए, बहुत अच्छा है। ब्रेथलेसनेस में पहले जरूर आप कार्डियक सोचिए, आपका कार्डियक ओके आ रहा है, एक स्पायरोमेट्री जरूर करिए। जिसका एबनॉर्मल स्पायरोमेट्री आता है आप 6 महीना से 12 महीना में उसको रिपीट करिए देखने के लिए कि वैल्यू गिर रहा है कि नहीं। और अगर पेशेंट का सिम्टम बिगड़ता है देन डेफिनेटली टेक द हेल्प ऑफ अ पल्मोनोलॉजिस्ट ऑल्सो। तो बेसिकली जो मरीज की सांसों की ज़रूरत पड़ रही थी, एक स्पायरोमेट्री के द्वारा सांसें देकर अपनी संगीत अमर कर दो, आप उस मरीज का संगीत को अमर कर सकते हैं। सो इफ आई वांट टू कंक्लूड, spirometry is a very easily available and accessible test. I have discussed in detail डायबिटीज़ में कहाँ कहाँ इसकी रोल है। डायग्नोसिस एंड फॉलोअप में ये बहुत आसान एक मशीन है, बहुत लो कॉस्ट मशीन है जो आप यूज़ कर सकते हैं। तो बेसिकली फिर भी अगर हम समझाना चाहे किस किस मरीज को ज़रूरत है, जो मरीज बोल रहा है कि वो ऐसा खांस रहा है कि जुदा होके भी तू मुझ में कहीं बाकी है, जिस मरीज को स्लीप सिम्टम्स है, सुबह होने न दे, शाम होने न दे, हम सोने न दे, एंड जिसको करंट मेडिसिन से फायदा नहीं हो रहा है, चूड़ी मजा न देगी, कंगन मजा न देगा, आपने एंटीबायोटिक ट्राई किया, कफ सिरप ट्राई किया, फायदा नहीं हुआ, एक स्पायरोमेट्री जरूर करिए। द इंडियन थ्योरी ऑफ रिलेटिविटी, एल्बर्ट आइंस्टाइन ने थियोरी ऑफ रिलेटिविटी बोला था कि इन नेचर एवरीथिंग इज रिलेटेड। The Indian theory of relativity was given by few Indian politicians कि relative is everything. Einstein बोला था everything is related, Indian politicians बोले no, relative is everything. तो बगल वाले फोटो में भागवत गीता में भगवान श्री कृष्ण अर्जुन को बोल रहे हैं, देखो बेटा, कल जो मरीज डॉक्टर अरिजीत का था, आज वो मरीज डॉक्टर अरविंद का है और कल वो मरीज डॉक्टर विरमानी का होगा। तो इसीलिए रिलेटिव इज एवरीथिंग। तो दैट्स वाई इट इज़ वेरी इंपॉर्टेंट टू हैव दिस कॉन्फ्रेंसेज रेगुलरली, ताकि हर बार हम लोग को एवर चेंजिंग मेडिकल साइंस पता चले। जैसे इस बार मैं स्पायरोमेट्री पे बोल रहा हूँ, अगर फिर भी आप लोग नेक्स्ट ईयर मुझे बुलाता है शायद मैं कुछ और चीज़ पे बात करूँगा। सो आई एम वेरी ग्रेटफुल टू एवरीवन ओवर हियर इन द ऑडियंस। ये मेरा छोटा सा सेंटर है रांची में, कभी भी रांची आइए, प्लीज़ गिव मी अ चांस फॉर योर हॉस्पिटैलिटी। सो थैंक यू एवरीवन फॉर द काइंड हियरिंग। थैंक यू।
Thank you, Dr. Atri, for your wonderful talk with full of humors and scientific contents. So, by this we conclude the session as we are running short of time. So our co-chairpersons and speakers are requested to gather at the selfie point. Over to Dr. Gagan. Okay. Dr. Injrit asked, okay. Actually, he is asking about the time frame for nitrofurantoin.
तगड़ा वाला होएगा, अमायोडायरोन का डोज डिपेंडेंट होता है कि अमायोडायरोन इतने समय के बाद होगा. नाइट्रोफुरेंटोन के इज अनप्रेडिक्टेबल कि जिसको होएगा तगड़ा वाला होएगा, जिसको नहीं होगा नहीं होएगा.
Dr. Andrijit,
Cough and
we will
breathlessness
discuss
बढ़
at
जाएगा.
selfie point with Dr. Atri. Thank you.
Thank you for this wonderful session to start with today's scientific meeting. In the next series of this session, we have our next speaker, Dr. Ujjwal Roy. The chairpersons to this speaker would be Dr. Pankaj Hans, Dr. Gauri Sankar, and Dr. Vikas Singh. I request all the speakers and chairpersons to come forward, please.
Good morning, everyone. Now we are going to start this session. The speaker is Dr. Ujjwal Roy, and he will be deliberating upon role of neuromuscular ultrasound as an extension of electrophysiology in identification of diabetic neuropathy and its mimics. Dr. Ujjwal, please.
Thank you, sir. Thank you for that kind introduction. And after two very enlightening talks by my colleagues, Dr. Atri, who is a great friend, and Dr. Anish also. And before, at the onset, I'd like to thank the organizers of this conference, the CCDSICON, and with permission of the chair, I would like to. So my topic is a bit, maybe for the physicians, it's out of the maybe not true context because this is more specialized. But what I'd like to highlight here is that diabetic neuropathy, as we all know, it's a common complication. Someone asked me the other day that diabetic neuropathy में आप बोल रहे हैं diabetic neuropathy का कोई treatment है क्या? The question is not about the treatment, but about the early detection. अगर आप किसी को ये बताएं कि आपको डायबिटीज़ हो गया और आपको न्यूरोपैथी होगी, उसके बाद आप चल नहीं पाएंगे, आपको दिक्कतें होने लगेंगी, गिरने लगेंगे, आपको जो है रात में उठ के जाने में दिक्कत हो जाएगी, आप गिर सकते हैं, आपको वीकनेस आ सकती है, ये सारी समस्याएं, तो यू कैन डिटेक्ट दैट अर्ली. नंबर वन. नंबर टू, समटाइम्स देर आर मिमिक्स कि वो डायबिटीज न्यूरोपैथी है, आप समझ रहे हैं, जस्ट यू आर टेस्टिंग सम मे बी स्मॉल फाइबर विद दैट मोनोफिलामेंट और थिंग्स लाइक दैट, एंड यू आर थिंकिंग दैट इज जस्ट डायबिटिक न्यूरोपैथी, बट यू आर नॉट कंसल्टिंग समवन हु इज एक्सपर्ट. So you may sometimes miss things. Now this concept is a bit relatively new for the neurologists also, because this is actually a talk for the neurologists basically. But then I'd like to give make this talk interesting for the physicians also. So I will what I'll do is that I'll show you some cases. So as Dr. Atri, so I have learned from him only to give some lines from the, because when I was typing this, just thing is. So like Tare hain barati, Chandni hai ye barat. So like Diya and Bati. So it's not, ultrasound is not that ultrasound that we are sending to someone else, some radiologist sitting. And we do not have good friends like Dr. Anish, I think. We do not have always friends like him, whom we can interact just like left to right. So sometimes we do not have this. And that's where I felt that this technique should also be learned as a POCUS, as a point of care ultrasound. As we all know, point of care ultrasound has been a boom in clinical medicine from last around maybe 5, 6, 7 years. When we were, when I was doing my MD medicine in Delhi, I did not, believe me, apart from the echocardiography, I did not touch any probe. But nowadays, I see in those hospitals only, Maulana Azad Medical College, UCMS, they do have a point of care ultrasound in the department itself. In the same way, in the neurology also, the ultrasound has come up as a point of care ultrasound. So, as we all know, seeing is believing. So, when we have these kind of, if you send a patient to me and I give an NCV report, it's just like Urdu and Farsi for you, some amplitude, something like that. But if you see something directly and then correlate it with clinical and electrophysiology, it's always interesting. So, this case was a 52-year-old female, non-diabetic for last 7 years, with numbness and paresthesias in all 4 limbs, and it was asymmetric to start with. Now, the antenna should. So diabetic neuropathy, as we all know, it's more of a symmetric disease, slowly progressive, gloves and stocking pattern, things like that. But if it is asymmetric, we need to really understand what it is. Jerks were also absent in this patient, and clinically it was mononeuritis multiplex. The display is not, because it's more of the videos actually, so it's very difficult. We do not have any display. Okay. So again, I'd like to emphasize here is that as we all know, diabetes is a old like known disease since yeah. So it has come. Yeah. So it's like 52-year-old female asymmetric neuropathy with jerks absent, and clinical and nerve conduction wise is mononeuritis multiplex. As we all know, mononeuritis multiplex is a very common presentation in diabetes mellitus. So, as you can see here, this is the median nerve near the wrist. You can see this enlargement. Now, what I would like to highlight that this enlargement is near the pronator quadratus muscle. It's just proximal to the carpal tunnel, not in the carpal tunnel. So, when we have enlargement of these nerves in, say, carpal tunnel syndrome or diabetic neuropathy per se also, so we have enlargement at entrapment sites. Not at this site where the pronator quadratus is like proximal enlargement. So this has to be something else. Now you see this is the radial nerve. So I start in the arm and I go distally. This is the superficial radial nerve just beneath the brachioradialis. And as you can see, as we go proximally, the nerve enlarges. So sometimes Hansen's disease, they do not have classical, so pure neurotic variant. So sometimes you can see that there is massive enlargement here near the, not massive, but yes, enlargement is there. You can see still it's enlarging here. This is not the girth of superficial radial nerve at this place. So it's definitely enlarged. As you can see, this is hypoechoic fascicles with enlargement here. So sometimes these patients of Hansen's, they do not have any skin lesions. They will not have typical findings. And asymmetric mononeuritis multiplex is a common presentation in these patients. So this thing I started there. This is actually a nerve FNAC. This is a new thing actually. So nerve biopsy we all know. In diabetes, in neuropathies, we do not understand what's the cause of neuropathy. We send for a nerve biopsy. Now this is the nerve FNAC. So in these hypoechoic fascicles, we go like that and try to extract. Believe me, I did this for around 52 patients, and I published this in Journal of Clinical Ultrasound by Willie. And so pure neurotic leprosy. So this was a case of pure neurotic leprosy, which was actually thought as mononeuritis multiplex due to diabetes. So now when we have the clinical thing with us, with the ultrasound and the nerve conduction, as I already said, Dr. Anish is also already here, and if we do have very good friends like him, we can always corroborate. But it's unfortunate that 90% we do not have. Like when you send to a radiologist, he will speak Urdu and Farsi for you, you will not agree, and then you will have a fight. So this is a common thing that happens with us. I am telling something in the nerve conduction, you are telling something else. So the point of care ultrasound is for that only. Now second case, diabetic polyneuropathy versus CIDP. This is sometimes a very, very important thing that we tend to miss actually. So patients who are diabetics for very long time, like 31 years, and they develop neuropathy for last 13 years, and then there is some, weakness in those patients. Now someone will argue that if the weakness is like very acute onset, sometimes the CIDP progresses very slow, maybe in months, years, something like that. And that's some place where you have nerve conduction, in nerve conduction you have zero amplitudes, like micro amplitudes. So you will think that yes, this patient is of diabetes and long standing. So it's due to that only. But then again the ultrasound, so blood sugar is controlled, so what next? So again we did focus in this patient, and these are actually, this is the neck ultrasound actually, the brachial plexus. As you can see, the root is coming out from, this is C5 root. You can see the root here. The root is enlarged. Again the C6, again you can see this enlargement, like balloon-like enlargement with hypoequivalent. So root enlarged, so CIDP should be thought of. Root enlargement. And for this patient, we gave IVIG. So electrodiagnostics and nerve biopsy says diabetes, suggests diabetes contributes to axonal damage with demyelination in CIDP. So these are difficulties actually. Overlap of clinical features, CSF protein are often elevated in diabetes mellitus. Electrodiagnostics may show demyelination also. So we give actually IVIG in this patient with remarkable improvement. Now again, this is a very challenging thing. Carpal tunnel syndrome in patients of diabetes. So we have some ginger heart in bilateral, some bilateral CTS is very common, more than unilateral CTS. So we sometimes think that it's just maybe due to diabetes. Sometimes the progression may not be exactly the glove and stocking pattern. Actually, sometimes this also happens that we think that it's carpal tunnel syndrome, but it's just diabetic neuropathy. So electrophysiology, definitely it's there. But then sometimes, the ultrasound also helps. So this was a case actually. So this was a case where this, as you can, I've just annotated the median nerve actually. And you can see, as we go proximally, this is a hypervascular, increased power Doppler signal, where we have increased inflammation. As you can see, this is hypoechoic swelling here. So actually this patient did not have frank complaints of, joint pains and all, just mild joint pains, some occasional joint pains. The patient came into summer. So when we categorically asked that there's some joint swelling, joint pain in summers, so that patient actually accepted that yes. So actually this was a case of actually rheumatoid arthritis. So we treated as rheumatoid arthritis, patient was improved. So again we published this case. Now this is a very interesting case. This is again a diabetic patient with 10 days of acute onset of severe pain and paresthesias, right finger and palm which radiated up to neck, history of thumb, index and middle finger numbness. Now this patient actually was diagnosed as carpal tunnel by someone else and just sent for a nerve conduction to me. So I did we did the point of care ultrasound, and you can see this is a bifid median nerve with a persistent ulnar artery and thrombus in that actually. Now, as you can see in the proximally when we go, this thrombus is not evident as such. So what we did actually, we gave anticoagulation. Now carpal tunnel syndrome and anticoagulation, two different things actually. Never you can think that it can be like that. But we did anticoagulation, and this is after the anticoagulation after around 1 month. Patient got relief of symptoms. But now the thing is that no one will think that carpal tunnel syndrome neurologist ke paas bhejna hai, point of care ultrasound, electrophysiology. Now everything combined, clinical, electrophysiology, ultrasound, everything combined, we have the results. And we published, we also did the CT angio for this patient, the CT angio of the wrist, and that also showed. We published this in the Bible of Neuromuscular Medicine, that muscle and nerve. We also subsequently also published in Journal of Neuroimaging. That is also again the Bible of neuroimaging by Ville, a series of carpal tunnels. Now again this was a case of CIDP where the patient has paresthesia of glove and stocking pattern, 8-month history of insidious onset and gradually progressive weakness, proximal and distal musculature, slightly asymmetric, but involve both upper limb and lower limb. Now again the nerve conduction has absent sensory in lower limb, feature of demyelination in sensory as well as motor nerves in upper limb. Now we as a physicians, I also used to use that monofilament thing and all, that's totally fine. But even you have single slight test of doubt, I think it should be, categorically. I have seen dozens of cases where actually when we investigate the patient, sometimes the diagnosis is something else. Now, initial diagnosis of CIDP was made not only by the physician but also by the neurologist. But patient was given of 2 cycles of IVIG without signs of improvement. Rather, there was clinical deterioration actually in that patient, and patient became wheelchair bound. So we performed a nerve ultrasound, nerve and muscle ultrasound, without any evidence of thickening. But when we performed this muscle ultrasound, you can see this is a tongue ultrasound. You can see this nice fasciculations actually. These were, you can see this flickerings, nice fasciculations. This is a real time. This is the advantage of ultrasound. You can do it real time. If you do CT scans, MRIs, you cannot see this. For that, you have to need to have some next generation. I think our radiologists will, maybe they will devise something like that in near future. But ultrasound is something which is actually dynamic. Again, this was a case of ulnar neuropathy. The SOL was sitting here. That was again thought of, maybe some cervical radiculopathy. The initial diagnosis was that only. And when we did the nerve conduction study, so asymmetric neuropathy, so we did the ultrasound here. As you can see, this SOL here. Most likely infiltrating the nerves, so neurofibroma. We sent this patient for biopsy. So just I would like to take 1 minute more, not more than that. So what does the evidence say? So these are the secondary cases, like some other things that we think that, but is diabetic, is like this ultrasound also help in early diagnosis of the diabetic neuropathy? The answer is yes. So now the evidence says that high resolution ultrasound is in subclinical diabetic neuropathy. It's a potential screening tool. That's what the evidence says. And this was a nice paper by my friend Anupama. And so it can, subclinical neuropathy can be aided in triage and timely intervention and dedicated care. So as already I had mentioned in my initial phase, if you tell to a patient that you are going to develop this neuropathy tomorrow, and if you do not control your HbA1c, maybe you will be bed bound, you will be wheelchair bound, I think then he will understand. Otherwise, he will not come to you. If you tell them that yes, my neurologist has diagnosed diabetic neuropathy for you, and you are going to suffer from this, you are going to have problems like this. If you do not come to me in 3 months, then he will come to you. He need not come to me, but at least if I diagnose, then he can come. So common peroneal nerve cross-section area of 4.5 millimeter had the highest sensitivity in this study as compared to the non-diabetic polyneuropathy. And this again, this is a Bible of clinical neurophysiology. Just half minute I'll take. This is a Bible of clinical neurophysiology. Nowadays, when we have clinical neurophysiology conferences where we have nerve conduction study, EEG, things like that, we do have ultrasound also, point of care ultrasound also. So now it's coming up like anything. So we use this ultrasound now in bigger centers, and in my center also I have started, and like it's gonna popular in future days. And these are this was a case again of neuralgic amyotrophy. We again published this case. Autonomic dysfunction also, the vagus nerve cross-sectional area has been used extensively. Sometimes when these patients have like syncope and all, they have autonomic dysfunction, we do not have autonomic lab. So if we do vagus nerve cross-sectional area and that's increased, we have clinical corroboration with that, that can help actually in. So with that note, thank you very much. Just a take-home message: non-invasive ultrasound is a screening tool in suspected diabetes mellitus, and EMG is a measurement of function, and ultrasound is concerned with structure. So both actually complement each other. An application of dynamic muscle ultrasound can provide a bridge between study of muscle and structure and function. And alternative measure like texture analysis. Again, this is coming like anything: texture analysis, acoustic structural quantification, as we do in liver. So that scan again, those scans we can do here also, fibro scan, things like that. And best strategy is to again go back to the clinicals, number 1, the most important. Number 2, the electrodiagnosis, and third, the ultrasound with a clinical correlate, which can be best done in a POC setting. Thank you very much.
Thanks a lot to Dr. Ujjwal for introducing a new modality to evaluate neuropathy, which helps not only in diagnosing but to detect differential diagnosis as well as prognostic values also there. So thanks a lot. Now I would like to call upon Dr. Varun Kumar. Sir, please come. He will talk about asymptomatic CAD in type 2 diabetes mellitus, how much to investigate. Dr. Varun Kumar.
Good morning, everybody, and thank you to the CCDSI for inviting me, and especially Dr. Gagan Gunjan. And I also congratulate that this conference is being held in this ancient and historical city of Rajgir. So today I am going to discuss about a very important topic in diabetic patients, and perhaps we all must aware about this thing, because as we all know that diabetes is now becoming an epidemic, and in the recent last few decades the disease has increased exponentially, and prevalence of disease has increased exponentially, and as diabetes is a major cardiovascular risk factor, so the cardiovascular complications and prevalence of cardiovascular disease also increased exponentially in the recent decades. So it is very important that we intervene early in diabetic patients so that this cardiovascular complication can be mitigated in diabetic patients. So today my talk will be on the same thing, when we should intervene in these patients of diabetes and how much to investigate these patients. So before going into the today's talk, I will just put forward some facts about the cardiovascular disease in diabetes. So most of the patients of diabetes have asymptomatic coronary disease, and they present there is increased 2 to 4 times risk of cardiovascular disease in diabetic patients, and the disease occurs 2 to 3 decades earlier in diabetes than in the general population. There is 2 to 4 times higher risk of death in diabetic patients due to this CAD. And the biggest problem is that even patients who present with ACS, many a time these patients are without chest pain because of the autonomic neuropathy associated with the diabetes mellitus. And atherosclerosis of coronary, cerebral and peripheral arteries account for approximately 80% of death and 75% of hospitalization in persons of diabetes. This is why it is very important that we must evaluate our patients of diabetes for the cardiovascular diseases. So early diagnosis of coronary disease in patients of diabetes is remain of paramount importance, but the biggest issue remains with the silent progression of coronary disease, and all that because of the autonomic neuropathy associated with the patients of diabetes, which lead to the silent ischemia, and ultimately they are diagnosed when the patient presents with either MI or heart failure. Up to 50% of silent MI are not detected at the time of the onset, but are instead detected later during routine care when CV symptoms occur by cardiac imaging. So this is another big problem with the diabetic patient, because they don't have the symptoms. So many a time the ACS presentation goes undetected, and later this patient presents with ischemic cardiomyopathy and other complications of the disease. Apart from coronary disease, the patients of diabetes also are increased risk of brain strokes and peripheral disease, and there is twofold increase of stroke risk in diabetic patients, and there is a more adverse outcome in stroke patients with diabetes than in the general population. And similarly, the peripheral artery disease, if you see, almost 20 to 30% of diabetic patients have peripheral artery disease, and 50% of it accounts for about 50% of all lower limb extremity amputation. And most of the time what I see that these patients are not evaluated for peripheral artery disease. This patient goes undiagnosed. We keep treating for the diabetic foot, but these patients are usually not evaluated for peripheral artery disease. Apart from that, the prevalence of heart failure is also very high in diabetic patients across all the spectrum of heart failure, whether it is heart failure with reduced ejection fraction, or heart failure with mid-range ejection fraction, or heart failure with preserved ejection fraction. And the prevalence is 2 to 5-fold higher than in the general population. The reason for that is many it can be caused by ischemia, metabolic disturbances, and some functional myocardial perturbations. So, from this data, we can understand the magnitude of the problem associated with diabetic patients about the cardiovascular health. And definitely, if we want to intervene at the right time, these patients usually end up with either more complications in the form of either cardiac issues or peripheral disease issues or even with brain strokes. So these all cardiovascular issues has to be addressed, and the biggest challenge remains again that the patients of diabetes are mostly asymptomatic, and different studies have shown that the rate of asymptomatic CAD in diabetics ranges from 20% to 60% in different studies. So how to evaluate and when to evaluate these patients of coronary disease? Does every patient diabetes requires evaluation for a coronary disease, or there is certain subsection or subset of patients who actually require the evaluation? So there are both this is a screening procedure, and for screening is always that even with other diseases what we see, lots of controversy occurs with screening procedures because there is none of the screening procedure are 100% accurate. So similarly, same in the coronary disease evaluation in patient diabetes. So those who are proponents of the screening procedure in diabetic patients for coronary disease, they highlight that the relatively high incidence of inducible ischemia in a symptomatic type 2 diabetes mellitus patient propose that the detection will ensure the use of therapies that may reduce the incidence of myocardial infarctions or cardiac death. But those who are critics of the screening procedure, they actually counter with concerns that screening tests are not entirely accurate and have yet to conclusively identify those patients at high risk for cardiovascular events, and that will lead to unnecessary revascularization procedures. But we have to meddle a middle path, and definitely some guidelines, some algorithms has been proposed for those patients who have asymptomatic CAD in diabetes, and if we follow that guidelines, definitely we can manage our patient better. So what these screening procedures or modalities available? Definitely all these are non-invasive modalities available from the humble treadmill test, which can be easily performed anywhere in the small clinic setting, to more sophisticated SPECT or nuclear cardiac imaging, stress echocardiography, stress cardiac MRI, and coronary CT angiography and coronary calcium scoring. So all these modalities can be used for early diagnosis of coronary disease in diabetic patients. So exercise ECG or treadmill test is very easily available everywhere, even in small cities, can be done with ease. And but the biggest fallacy with this test is that there is a very low sensitivity and a low specificity. So false positive and false negative cases are very high with TMT. So this is a big fallacy with that. So next modality is stress echocardiography. Again, it can be performed in small cities with a simple echocardiography machine. And but the biggest issue again, the performer who is doing the this stress echocardiography, he must have a good experience in doing the stress echocardiography, because assessment of regional wall motion abnormality, what our teacher used to say, is the most difficult thing to look for in the echocardiography, because you must have the eye to look for that regional wall motion abnormality. If you won't have, you may miss because there are subtle changes in the myocardial movement. So you must have that eye that you can detect that subtle changes in the myocardium, and like thallium 201 and this sestamine tetraphosphine can be used as a stressor, and then the different perfusion defects what we see in the after doing this SPECT imaging, we can assess what is the degree of the coronary disease in this patient. So I'm not going to tell of that. Stress cardiac MRI is another very good modality for assessing the asymptomatic coronary disease in patient diabetes, and it carries very high sensitivity and specificity, and also has a very good negative and positive predictive value. And another, rather the most commonly applied screening test is the coronary calcium scoring. So it is very easily available it can be done with the MDCT and easily can be done at any place. And according to the calcium score, we can stratify the patients who have fall into which class of risk. So patients with a CAC score of less than 10 are very low risk, less than 100 are low risk, and those between 100 to 300 are moderate risk, and more than 300 are high risk patients. So in patients of diabetes who are asymptomatic, when you are assessing a patient of diabetes with asymptomatic CAD, the prevalence of this high risk score is more than 20%. So you can understand that the extent of the disease already these patients have, now the patient is asymptomatic. Coronary CT angiography these days has become a norm. Patients themselves come ask you to, sir, prescribe me coronary CT angiography without knowing the exact indication for the coronary CT angiography, because nowadays in the social media it is very much being circulated that it is a non-invasive test and can detect your blockages. But there are certain indications for coronary CT angiography, and particularly in patients with ACS it is not indicated, and those who are symptomatic and high-risk patient, coronary CT angiography is not indicated. There are certain indications for the coronary CT angiography, and I'm not going to detail of that. But this is a very important tool for the assessment of coronary blockage in these patients who are asymptomatic but have diabetes. So what I have already discussed about the different modalities available for assessment of the coronary artery disease in patients with diabetes. Now there is an algorithm which has been revised by the P-valency, which tells us about when these patients should be evaluated for the coronary disease, despite the patient being asymptomatic. So this algorithm suggests that he made two categories of the patient: those who are very high risk and those with high risk. So these patients who have diabetes in the age group of 35 to 75 years, in the very high risk group, if any one of these present, then these patients should be evaluated for the coronary artery disease. So these are the previous CV disease, including atrial fibrillation and heart failure, LDL cholesterol of more than 190, albuminuria more than 300, EGFR of less than 30, ECG showing abnormal Q waves, and echo showing abnormal LV function or hypertrophy, and peripheral erythrometas also more than 50%. If these are there, then this patient should go for the screening for the CAD. If this is not present, then he made another group with high risk, and any of two of present, that is categorized as high risk, and these are diabetes duration more than 10 years for type 2 diabetes and more than 20 years for type 1, premature CAD in first degree relative, persistently uncontrolled risk factors like high HbA1c, high LDLC, high non-HDLC, high blood pressure, smoking, confirmed albuminuria, severe retinopathy or autonomic neuropathy or erectile dysfunction, and low physical activity. If any two of these are present, then these patients are categorized as a high risk. Then these patients should go for the CAC scoring. And according to CAC score, they should be are stratified as a moderate risk, high risk, and very high risk. So those patients falling into very high risk, again they should go for the screening for coronary disease, and later if the screening test comes positive, they should go for the coronary angiography. So patients who are remained in these different categories, they have been also advised to go for appropriate therapeutic targets. So what are those appropriate therapeutic targets? So all these patients must have HbA1c level of less than 7, avoid hypoglycemia, use GLP-1 receptor agonist, use of SGLT2 inhibitors, LDL target according to the risk stratification, that is if moderate risk is 100, high risk less than 70, very high risk less than 55, and very high risk with suspected ischemic CAD should be less than 55. Similarly, non-HDLC, which is more important in Indian context where non-HDLC remains very high, the different categories, we should follow those cutoff levels. Smoking cessation, blood pressure target of less than 130/80 in all categories. Use of RAS inhibitors, aspirin in these patients are also advocated. Dietary control, and if patient falls into the high risk group, reassessment of CAC score should be done every 3 to 5 years. And for screening of the CAD in very high risk and very high risk with suspected ischemic CAD should be done every 3 to 5 years. So what the guidelines tell us? What the current guidelines actually recommend in such patients who are asymptomatic and are diabetic. So a risk stratification approach has been developed by the European Society of Cardiology in collaboration with European Association of the Study of Diabetes, EASD. And they suggest that a coronary artery calcium score and coronary computed CCTA can be proposed for a better assessment of severe risk. This ESC 2019 guideline, they have suggested that patients with peripheral artery disease, high CAC score, proteinuria, renal failure, LVH, retinopathy, and 3 of more of the major risk factors like age, hypertension, dyslipidemia, smoking, and obesity. These patients should go for the screening for the coronary disease in patients with asymptomatic CAD. And ADA 2020 guideline also suggested that patients with atypical cardiac symptoms like unexplained dyspnea, chest discomfort, and signs or symptoms associated with vascular disease like including carotid bruise, TIA, stroke, claudication, peripheral artery disease, and abnormal electrocardiogram, these patients should be evaluated for coronary disease. Apart from that, ADA 2024 guideline also recommended that patients with type B heart failure should go for echocardiography, and in asymptomatic individuals with diabetes and age more than 50 years, microvascular disease in any location or foot complication or any end organ damage from diabetes, this patient should be screened for peripheral artery disease with ankle brachial index testing.
Dr. Varun, if we can summarize.
Yeah, just it's finishing it. Okay, just last slide. This is this patient came to my clinic with just some chest discomfort 1 day ago, and his ECG is showing you can make out that this is absolutely normal ECG. There is nothing abnormal in this ECG, and echocardiography was also absolutely normal. But as the patient was symptomatic, he has some chest discomfort, long-lasting diabetic, so I asked him to go for the angiography, and what I got in the angiography, he has a totally occluded left circumflex in the proximal part and another 70 to 80% lesion in the mid RCA. So this is the problem with the patients of diabetes. They are actually remain asymptomatic and until you are not, and just on the ECG and echocardiography, don't rely on that, the patients are absolutely normal. So later on when the coronary reserve will decrease, this patient will actually develop the ischemic cardiomyopathy. So this is the importance of evaluating these patients of diabetes, because these patients are mostly remain asymptomatic. So we must not just on ECG and echocardiography, we must not make out, okay, patients are okay. So we need a proper evaluation of these patients at the right time so that we can decrease the complication rate and improve the outcome in these patients. Thank you.
Thank you, Dr. Varun. We all understand that when we are investigating a diabetic patient for CAD, and particularly if he's asymptomatic, the problems are twofold. You don't want to miss up on CAD patients. And number two, you don't want to unnecessarily work them up, because since they are asymptomatic, that won't go down well with them, why the doctor is investigating so much on me. So very nicely put up. And in the interest of time, we would be moving on to the next topic, that is by Dr. Sumit Verma. He'll be discussing about management of VT storm in ACS. Now, VT itself is a condition which is life-threatening, and when it is occurring in the context of acute coronary syndrome, and it is a VT storm, nothing worse than that. So how to approach these patients? Dr. Sumit, over to you.
Yes, pointed. Thank you. Good morning, everyone. I'm going to discuss a rare encounter, and I think it will push adrenaline in you, and believe me, it will test your nerve every time whenever you got this situation. So, I'm talking about management of VT storm in ACS, and yes, it is a challenge. Try to anticipate it and act accordingly. So starting with my case, a 53-year-old gentleman, known diabetic and hypertensive, came to my emergency with a complaint of chest pain and chest pain with perspiration for last 3 hours. His BP was 140 by 80 millimeter of mercury at presentation, and heart rate was 70 to 80 per minute on monitor. ECG showed ST elevation in lead 2-3 AVF and ST depression in 1 AVL with V2 to V6. This is the ECG. With this ECG, we can tell about the culprit vessel. The ST elevation in lead 3 is more than 2, so the culprit vessels was RCA. The echo was done and it shows RWMA in inferior territory with EF of 45%. So a diagnosis of inferior wall MI was made, and patient was loaded with antiplatelet and statin and was advised for the primary angioplasty. The consent was taken and patient was preparing for the angioplasty. In the meantime, just I went to the cath lab to change into my scrub. I got a call from the emergency that the patient is not responding. I immediately rushed. CPR was started. I was expecting Brady event because inferior LMI chances of complete heart block was is high, but as soon as I reached, I saw a techie events in the form of VT. Immediately DC shock of 200 joule was given, and the patient reverted to sinus rhythm. Again, within next 1 minute, patient again went in the same situation, and we reverted him by giving DC shock. From here, I am just sharing few slides regarding the management of VT storm in the setting of ACS, and after that, I will tell what I did in this patient. So, VT storm is occurrence of more than 3 VT episodes within 24 hours. Is VT storm, and it is very difficult to decide the incidence of VT storm in ACS because most of the patients do not reach alive to the hospital. But some trial retrospective analysis like GUSTO-2B and GUSTO-3 had shown the VT-VF events of 6% in ACS. The majority of VA events in STEMI occurs in first 48 hours, while in case of an STEMI, most of the event occur after 48 hours of its presentation. The increased prevalence of acute reperfusion strategy has definitely reduced VT storm in patients of ACS. Early use of drugs like AC inhibitor, ARB, beta blocker, and statin has reduced the incidence of VA in ACS. But in the current setting of CCU, patients with sustained ventricular arrhythmia associated with an ACS are usually characterized by severe or prolonged ischemia or arrhythmogenic substrate prior to acute event. Can we anticipate the ventricular events in ACS? Yes, we can anticipate it by looking if the patient presented with cardiogenic shock or large severe acute infarction in the term of occlusion of left main or ostial LAD. Patients with delayed reperfusion therapy, mostly due to delays between the first symptom until transfer to an acute cardiac setup, or patient with incomplete revascularization, patients with pre-existing reduced LV ejection fraction and having myocardial scar, and finally patients with inherited arrhythmogenic cardiomyopathy like long QT syndrome, short QT, Brugada, ARVC, hypertrophic cardiomyopathy, and other variants, etc. The main mechanism for VTs are intramural reentry in ischemic myocardium and triggered activity after establishing perfusion. If we talk about the specific treatment, and then if ACS is suspected to be responsible for VA events, then immediately reperfusion is of utmost importance in the background of ACLS. Electrical cardioversion or defibrillation is indicated if any VA persists and is essential if the patient is hemodynamically unstable. Sedation is required if the patient is still conscious. Electrical cardioversion is the best and safest method to terminate sustained VT in ACS. If the patient is hemodynamically stable during sustained VT, we can try the antiarrhythmic drug, but the conversion rates are low. Irrespective of the resultant rhythm, CPR is starting with the chest compression should resume immediately after each shock to minimize the no-flow time. In patients with cardiac arrest and in whom an adequate circulation cannot be recovered, we can use LV assist device or ECMO as a bridge to recovery. A drug that can be used for management of VA events are beta blocker, amiodarone, lidocaine, dofetilide, maxillatine, ranolazine, and nicorandil. We can try stellate ganglion block, renal sympathetic denervation therapy for a resistant case. Also, we can use VA ablation and ICD therapy for the long-term secondary prophylactic therapy. The advantage of ICD therapy has been well documented and associated with significant reduction in mortality among survivors of sustained VT compared with antiarrhythmic drugs, mainly amiodarone. With the exception of beta blockers, antiarrhythmic drugs have not shown to be effective as first-line management of patients who survived VA and should therefore not be used for secondary prevention of sudden cardiac death. And last, ICD therapy is recommended as secondary prevention therapy to reduce mortality irrespective of LV function in patients with hemodynamically unstable ventricular arrhythmia, which does not occur within the first 48 hours of MI. So from here now I'm coming back to my patient. After the second shock, we immediately shifted the patient to the cath lab, but we have to give 8 to 10 DC shock during transmission from my emergency to cath lab. In that meantime, I was thinking that this patient has developed that much VT. He must have involvement of left coronary system. So despite localizing the pathway during the initial ECG, I checked first the left coronary system, and it was completely patient. Patient was very unstabilized, so this video is also unstabilized. After doing left coronary angiogram, I checked the right one that shows 100% block from the osteoproximal part. I'm not going to discuss the whole procedure, but at the end result was patent RCA with good TME3 flow. But during this period of angioplasty of 30 to 45 minutes, we have to deliver 30 DC shocks of 200 joule to the patient, along with CPR. So all the things were going simultaneously, CPR, DC shock, and angioplasty. At the end of the procedure, I just thought if I could put a TPI to the patient so that if any tachy events occur further, I will do the anti-tachycardia pacing to the patient because I have achieved the reperfusion. But the second thing comes in my mind that the TPI itself is a pro-arrhythmic. So I discarded my first thought and shifted the patient to cardiac ICU. After shifting the patient started showing sign of improvement. He was responding to command and BP goes above 100 millimeter of mercury. Immediately after that, I loaded the patient with metoprolol 12.5 milligram orally. But at the end of 1 hour, this was VT events occurring during the cath lab procedure that we tackled. At the end of 1 hour, when patient shifted to cardiac ICU, again he developed VT. So we started CPR and cardioversion again, but along with this time we gave injection amiodarone. Along with that, we gave xylocaine and calcium gluconate, keeping in mind that prolonged CPR may have led to hyperkalemia. God knows what worked, whether reperfusion, CPR with defibrillation or antiarrhythmic drug. At the end of extensive effort of 45 minutes, we stabilized the patient and we gave 70 DC shocks of 200 joule to this patient. And at that time, I was exhausted. I thought that if any further events of VT, I will put a TPI to this patient and will do anti-tachycardia pacing because the condition of the chest wall was not very good. Very next day, I do the 2D echo that shows dilated RV with apical hypokinesia, and then his RVOT diameter in short axis view was 40 mm, and I just calculated the fractional area change of right ventricle that was less than 20%. It was a rough calculation, so I do not put that data here. All these suggest background presence of arrhythmogenic right ventricular cardiomyopathy. So this was a case of inferior wall MI with silent arrhythmogenic right ventricular cardiomyopathy. That should be confirmed next. So with this, this patient is, we saved this patient, and this patient is in my constant follow-up. He just gave a victorious sign 2 weeks back. He's in my follow-up for last 5 months. I have advised him cardiac MRI, and if the MRI confirmed ARVC, I will advise him for AICD for the secondary prevention. I'm just going to discuss the second case. A 70-year-old diabetic female presented with ghabrahat, shortness of breath and perspiration for last 4 to 5 days. Her BP was 90 by 60 millimeter of mercury, and heart rate was around 100 to 110 per minute. ECG shows feature of anterior wall MI, and the echo shows extensive hypokinesia in anterior territory with ejection fraction of 30%. Coronary angiogram was done, and it shows critical TVD. Patient was advised for CABG or a hybrid procedure, but the attendant were not ready. They need some time. So patient was shifted to cardiac ICU. I anticipated the chances of cardiac arrest because of this. This is a angiogram showing RCA 100% occlusion from mid, critical lesion in OM1, and LAD shows osteoproximal critical disease narrowing around 99% with distal flow, distal slow flow. And finally, you can see that the right coronary artery are filling retrogradely from the left system. That is, I think that this is right coronary artery filling retrogradely from the left system. So a lot of myocardium is geoparadized. The risk of ischemic burden are high. So I thought this patient may develop sudden cardiac arrest, and that occurs. In the next morning, patient developed VT. We started CPR. We were prepared for that and gave DC shock, 8 to 10 DC shock, and we revived her in next 15 minutes. And she was just discharged yesterday morning with advice of revascularization and AICD for the secondary prevention. So I am discussed here 2 cases. One case is of ACS in the background of silent ARVC, and another case of ACS that presented late and due to ischemic myocardium with reduced ejection fraction. They had event of VT storm. So I am concluding here with the take-home message. Always examine the patient of ACS bedside with chest lead connected to cardiac monitor, so that you can predict the, you can look about the whether the tachy events or brady, whatever going on. Keep preloaded syringe of life-saving drugs ready, so you can use it judiciously. Use cardiac defibrillator for any hemodynamically unstable tachy events. Ready with the TPI to handle the brady event like CHB, and try to shift the patient early to nearest cath equipped center with the help of ACLS. And always keep your nerves calm and sticks to the basics for any of further events. Thank you.
Excellent presentation, Dr. Sumit. And with this we conclude the session. And for any queries that should be clarified from Sumit and other 2 speakers during the lunch time. Thank you.
Any question?
Next, we move on to the next topic. This topic is a short workshop that we'll be having on obesity. This workshop will be basically conducted by Dr. Anand Dev, and we have a dietitian with him, Mr. Sudhakar Misra. And chairpersons for this session would be Dr. Afsar Ahmed, Dr. Sumit Verma, and Dr. K Singh. Please join us. We also have this body composition machine on left side of yours. You can use this for your body composition analysis right now.
Good morning, everybody. I am Dr. Anand Dev from IGMS Patna. Now we will conduct a workshop on obesity. Mr. Sudhakar Mishra is an expert in dietetics. Through his machine in body, he will demonstrate how to measure body fat percentage, skeletal muscle mass, visceral fat, and body water and metabolism. So over to you, Mr. Sudhakar. Please come.
Good morning, all of you. Myself, Sudhakar Mishra. पिछले पास्ट 14 ईयर से ओबेसिटी पे हमने काफ़ी काम किया जिम में, अपनी क्लिनिक पे, और लोगों को काफ़ी अवेयर भी किया. पर जहाँ तक देखा जाता है कि हम लोग ये लाइफ स्टाइल डिसऑर्डर है और आगे चल के ये हार्ट डिजीज़ और डायबिटीज़ को बढ़ाता है. और जैसा कि आज का ये कॉन्फ्रेंस है, ये हार्ट और डायबिटीज़ को फोकस करते हुए है. गगन सर से बात हुई, बोले कि एक वर्कशॉप होना चाहिए ओबेसिटी पे, जिससे हम लोग ये कोरिलेटेड है उससे और एक अच्छा मैसेज आएगा. सो फाइनली एक शॉर्ट पीपीटी बनाए हैं ओबेसिटी को लेके, ताकि अवेयरनेस आए और हम लोग डे टू डे लाइफ में और क्या क्या करेक्शन कर सकते हैं उस पर हम लोग डिस्कस करेंगे. सो ओबेसिटी is a medical condition in which excess body fat accumulates in the body and increase the risk of various diseases. Abnormal growth or excess fat accumulation of the adipose tissue due to enlargement of fat cell size or in fat cell number. बेसिकली जो अर्ली एज में ओबेसिटी होता है, जो जिसको कहते हैं एडल्टहुड से पहले चाइल्डहुड, वो उसमें हम लोग नंबर ऑफ फैट सेल बढ़ता है, और जैसे ही वो एडल्ट होते हैं उनका लाइफ स्टाइल चेंजेस आता है, बीएमआर स्लो होता है, तो वही फैट सेल नंबर जो उनके बॉडी में रहता है वो फैट सेल साइज में कन्वर्ट हो जाता है. क्योंकि फैट सेल किसी की बॉडी में अगर एक बार बन जाए तो वो लाइफ टाइम के लिए रहता है, कभी ख़त्म नहीं होता, वो बैलून की तरह छोटा और बड़ा होता है. Overweight is usually due to obesity but can arise from other causes such as abnormal muscle development or fluid retention. Overweight fluid retention की वजह से भी होता है. It is not just about body weight, it is related to metabolic health and lifestyle habits. So obesity is due to positive energy balance. The intake of calories is more than expenditure of energy. Then overweight, a person who's 10 to 20% of above the normal ideal weight for his sex, age and height. And obese, a person who is more than 20% of above the normal ideal weight for his sex, age and height. And underweight, a person who is 10% or more below the normal ideal weight for his sex, age and height. So increased weight as compared to the ideal weight for particular sex and height means 10% of ideal body weight is overweight and 20% of ideal body weight is obesity. So obesity management हम लोग कैसे करेंगे? सेल्फ मोटिवेशन बहुत ज़रूरी है, क्योंकि डिसिप्लिन लाइफ जब तक नहीं होगा, और जिसको करना है वेट लॉस फैट लॉस, उसके लिए पहले उनको खुद से प्लान करना होगा कि हम कर सकते हैं कि नहीं, क्योंकि ये एक दिन दो दिन की प्रोसेस नहीं है, 3 से 5 महीने कम से कम लगते हैं एक अच्छा वेट लॉस करने के लिए. देन डाइटरी चेंजेस, सिंप्लीफाई थोड़ा थोड़ा स्टेप बाय स्टेप हम लोग चेंजेस करेंगे. टोटल 100% डाइट ना चेंज करके 70% हम लोग डाइट चेंज करते हैं. बेसिकली कार्बोहाइड्रेट प्रोटीन डाइट कम लेके हम लोग प्रोटीन और इंक्रीज करते हैं. एक्सरसाइज एंड एक्टिविटी 1 आवर डेली करना है. गोल सेट करना है कि पर मंथ कम से कम 3 to 4 kg उनका वेट रिडक्शन हो. बिहेवियर चेंजेस, प्रिस्क्रिप्शन मेडिसिन, अगर कोई प्रिस्क्रिप्शन में ऐड किया हुआ मेडिसिन उसको ऐड करना है. वेट लॉस सर्जरी जस्ट लाइक बैरिएटिक या लाइपोसक्शन के थ्रू भी वेट लॉस होता है. So your diet and you, the food you eat shapes your body and its health. Your body is a mirror image of your diet. If you eat well balanced meal, you have a normal well proportioned body. So आज के वर्कशॉप में हम लोग फोकस कर रहे हैं बॉडी कंपोजिशन एनालिसिस. जनरली हम लोग क्या करते हैं, हाइट वेट BMI कैलकुलेट करते हैं और टोटल कैलोरी निकालते हैं. बट अभी हम लोग बहुत सारे केस स्टडी भी दिखाएंगे जिसमें देखेंगे BMI तो सही है बट उनका फैट परसेंटेज काफ़ी चेंजेस है. तो हम लोग 2025 2026 में आ गए हैं. अभी थोड़ा सा अपने आप को अपडेट करेंगे, देखेंगे बॉडी के अंदर क्या है, मीन्स मसल्स फैट, विसरल फैट, किस पोर्शन में कितना कितना फैट है, मेटाबॉलिक रेट क्या है, उन सब चीज़ों को जानेंगे. ये मशीन FDA से अप्रूव्ड है और ICMR से अप्रूव्ड है. 99.8% इसकी एक्यूरेसी है इस मशीन से. सिंपल 30 सेकेंड के अंदर ये मशीन से रिपोर्ट आ जाता है और आप अपनी बॉडी को समझ सकते हैं. So body composition analysis is a method of describing what the body is made of, differentiating between fat, protein, minerals and body water to give you a snapshot of what's inside which is a non-invasive. So classification, a healthy body composition is one that includes a lower percentage of body fat, a higher percentage of non-fat mass which includes muscles, bone and organs. तो जनरल फैट परसेंटेज फीमेल में 18 to 28% नॉर्मल रेंज होता है और मेल में 20 to 20%. आप किस स्पोर्ट्स पर्सन का फैट परसेंटेज का अलग कैटेगरी है. स्पोर्ट्स पर्सन अगर है फिटनेस में 21 to 24% एंड मेन में 14 to 17%. ओबीज अगर 32% से एवं फैट परसेंटेज आ रहा है तो उनको ओबीज कैटेगरी में किया जाएगा और मेल में अगर 25 से एबव है तो ओबीज कैटेगरी में आएगा. सो जनरल बॉडी फैट परसेंटेज कैटेगरी आप ग्रीन लीन बॉडी अगर है तो ब्लू लाइन है आइडियल, एवरेज एंड एबव एवरेज. ये अकॉर्डिंग टू एज और हाइट से ये शो कर रहा है कि आप किस एज में है और आपका फैट परसेंटेज कितना होना चाहिए. सो एक्सपीरियंस रिमूव शूज. सबसे पहले हम जो लोग रिपोर्ट निकालेंगे उससे इलेक्ट्रोड प्लेट लगा होता है नीचे जहाँ पे हम लोग पैर रखते हैं बेयर फुट और हाथ हमारा क्लीन होना चाहिए. जिसके बाद हमारा वो गुड कंडक्टर एंड बैड कंडक्टर कंसेप्ट पे ये काम करता है मशीन. स्टैंड ऑन द स्केल एंड अलाइन योर फीट विद द फुट इलेक्ट्रोड्स. इंटर यूनिक ID, एज, हाइट एंड जेंडर पुट करते हैं. देन ग्रैब द हैंड इलेक्ट्रोड, स्ट्रेंथ योर आर्म्स एंड मूव देम अवे फ्रॉम द बॉडी. सो 8 point tactile electrode system with thumb electrodes, multiple frequencies, direct segmental multi-frequency bioelectrical impedance analysis, no imperial estimations. So less invasive data collection. Within a couple of minutes you can give a numerical baselines, share important health risk information, add value and average the in body to maintain प्रिकॉशन क्या क्या रखना है इस मशीन से रिपोर्ट निकालने से समय. डू नॉट हैव हेवी मील्स फॉर एटलीस्ट 2 hours बिफोर इन बॉडी एनालिसिस. डू नॉट ड्रिंक वाटर एटलीस्ट 15 to 20 minutes बिफोर इन बॉडी एनालिसिस. यूज washroom before in body analysis. Enter your information accurate. Height is required for accurate result. Do not measure after exercise क्योंकि एक्सरसाइज का मेटाबॉलिक रेट बढ़ा रहता है तो ये रिपोर्ट सही नहीं आता है. Gently hold the hand electrodes. Do not press. Stay in a standing position for at least 5 minutes before in body analysis. Follow the voice guidance for correct posture. Elder patient with thick skin layer must be sanitizer to moisturize their feet, hand before doing the analysis. Not recommended for following condition: pregnant ladies, metallic implant, pacemaker and menstrual cycle. So जैसे जैसे हम लोग रिपोर्ट निकालते हैं डेट के अकॉर्डिंग एक ग्राफ प्लॉट होता है कि किस डेट को आपका वेट कितना था, मसल परसेंटेज, बॉडी फैट परसेंटेज एंड ECW रेशियो. सो इन बॉडी एप्लीकेशन फिटनेस एंड एथलेटिक मॉनिटर के लिए ज़रूरी है. फिटनेस टेस्टिंग, इंजरी ट्रैकिंग, मेडिकल एंड रिहेबिलिटेशन में प्री डाइटेटिव एनालिटिक, डायनामिक रिपोर्टिंग, इंटीग्रेटिव मेडिसिन, मेटाबॉलिक असेसमेंट हम लोग कर सकते हैं इससे. फ्लूइड बैलेंस स्क्रीनिंग, strength and conditioning training program calculation, custom assessment tool, communication, telemedicines and coaching purpose में भी हम लोग इस मशीन को यूज़ करते हैं. मैसेजिंग टूल, डेटा मैनेजमेंट, एक्सपोर्ट टू थर्ड पार्टी इंटीग्रेशन, मैट्रिक्स मैनेजमेंट. द वैल्यू proposition, less invasive data collection, quick and easy collection, offer staff time to be used efficiently, more professional than collecting data manually, no pinching or exposure to harmful experiences, improve quality engagement, designed customized programs for each member to improve outcome and view report. Combining the testing experience with a skillful data interpretation and consultation can be add value. So इस तरह का एक sheet निकलता है जिसमें हम लोग present body weight, skeletal muscle mass, fat percentage, segmental lean percentage, body composition history, visceral fat, water level and किस portion में कितना कितना fat है उसको भी count करते हैं. जनरली विसरल फैट बढ़ने से हम लोग का कार्डिक प्रॉब्लम भी बढ़ने का चांसेस है. और आज की डेट में डायबिटिक पेशेंट में सार्कोपीनिया बहुत कॉमन पाया गया है. मीन्स सार्कोपीनिया की वजह से भी बहुत सारा ग्लूकोज लेवल बहुत हाई हो रहा है. तो हम लोग कैसे मसल परसेंटेज को बढ़ा के सार्कोपीनिया भी सही कर सकते हैं, ग्लूकोज लेवल भी कंट्रोल कर सकते हैं, आगे हम लोग केस स्टडी में डिस्कस करेंगे. देन पहले हम लोग क्या करते थे, हाइट वेट और BMI निकालते थे और ये चेक करते थे कि ये फिट है या अनफिट है. बट देखेंगे इस रिपोर्ट में ये मसल्स काफ़ी कम है, इनका 26.2 है और BMI 22 है. मीन्स BMI 22 है, मीन्स आइडियल है BMI, बट फैट परसेंटेज एक्स्ट्रा है 25.2. तो वेट भी इनका परफेक्ट है. हाइट इनकी है 169.5 सेंटीमीटर, उसके अकॉर्डिंग आइडियल वेट होना चाहिए 63 kg, बिल्कुल परफेक्ट वेट है. बट मसल्स कम रहने से इनका मसल्स 6.4 kg कम है मसल्स. तो मसल कम रहने से इनके बॉडी में आप देख सकते हैं कि वाटर लेवल भी कम है. मीन्स कहते हैं ना कि हम लोग ज़्यादा पानी पियेंगे तो ऐसा नहीं कि बॉडी में ज़्यादा पानी रहेगा, वो मसल ही हमारे बॉडी में वाटर को होल्ड करता है. और जब मसल वह होल्ड करेगा तो साथ साथ विटामिन मिनरल्स जो हमारा वाटर सोल्यूबल विटामिन है वो भी हमारे बॉडी में स्टोर होता है. प्लस इसमें देखेंगे मेटाबॉलिक रेट भी स्लो है, 1391 है, जबकि इसका मेटाबॉलिक रेट 1500 से 1600 होना चाहिए. तो इस केस में हम लोग क्या होगा कि फैटी लीवर का केसेस जो देखते हैं ऐसे पेशेंट बहुत होता है. मीन्स इंसान दुबला पतला है बट बॉडी में फैट एकोमुलेशन ज़्यादा हो रहा है ड्यू टू उनका बॉडी स्टोर मीन्स यूटिलाइज नहीं कर रहा है. जो कैलोरी वो डेली इनटेक कर रहे हैं वो यूटिलाइज नहीं हो रहा है, वो फैट में कन्वर्ट ज़्यादा हो रहा है. तो इसके लिए हम लोग क्या करेंगे, प्रोटीन इंटेक बढ़ाते हैं. प्रोटीन इंटेक बढ़ाने से जैसे जैसे मसल्स बढ़ेगा, मसल्स बढ़ने से इनका मेटाबॉलिक रेट बढ़ेगा. मीन्स आज जो वो इंटेक कर रहे हैं, मीन्स 1600 कैलोरी इंटेक कर रहे हैं, कल के उनका हम लोग 1800 और 1900 कैलोरी भी इंटेक बढ़ाएंगे तो भी बॉडी उनका फैट कम बनाएगा, कम स्टोर होगा. और इस केस में क्या होता है कि शुगर का भी चांसेस बढ़ते चला जाता है. मीन्स मसल्स कम रहने से ग्लाइकोजन स्टोरिंग कैपेसिटी भी कम होती है और ब्लड शुगर भी बढ़ता है. मीन्स फैट और डायबिटीज दोनों को कंट्रोल करना है तो हमको मसल 100% पे रखना होगा. एक और केस स्टडी जिसमें वेट अंडर है, इनका 39.9 kg वेट है, फिर भी इनके बॉडी में फैट 31.2% है. मीन्स ऐसे लोग देखेंगे कि सार्कोपेनिक रहते हैं और हाथ पतला, पैर पतला, पेट निकला हुआ, मीन्स एब्डोमिनल फैट बढ़ते चला जाता है. इस टाइप की बॉडी है इनकी. इसमें भी करीब 6.6 kg इनका मसल्स बढ़ाना है और जितना मसल्स बढ़ेगा उतना ही उसी प्रोपोर्शन में वाटर भी बढ़ता है. मीन्स अगर 3 kg किसी का मसल्स गेन कर रहे हैं तो साथ साथ 3 kg बॉडी में वाटर भी गेन होता है. इसको हम लोग कहते हैं हेल्दी वेट गेन, साथ साथ फैट रिड्यूस होगा, तब जाके इनके प्रोपोर्शन में सही होगा. बट क्या होता है, लोग डाइटिंग पे चले जाते हैं, कम खाते हैं, प्रोटीन इंटेक कम करते हैं और उनका वेट तो घटता है बट साथ साथ उनका मसल वाटर लॉस होते चला जाता है, फैट लॉस नहीं होता है. So improve quality and engagement, discuss realistic goal and outline how to customize a program, increase membership conversion through initial assessment and consultation. तो हम लोग बात करें तो पहले C ग्राफ, जबकि D ग्राफ होना चाहिए. D ग्राफ अगर है तो उसमें हम लोग ये देख रहे हैं C ग्राफ बन रहा है, मीन्स वेट, मसल्स एंड फैट. ये C ग्राफ बनने की वजह से ये बॉडी बहुत डेंजर बॉडी होती है. मीन्स इस बॉडी में डायबिटीज़ की चांसेस और फैट परसेंटेज की चांसेस, हार्ट पेशेंट की चांसेस ज़्यादा होते हैं. इसको हम लोग स्पोर्ट्स पर्सन अगर रहेगा तो डी ग्राफ बनता है. अगर डी ग्राफ बनेगा तो फिर हमारा प्रोपोर्शन भी सही रहेगा, या तो आइडियल रहे, तीनों 100% पे रहे, या तो फिर डी ग्राफ बने. सी ग्राफ बहुत डेंजर है. सो हम लोग जनरली क्या करते हैं, वेट लॉस फोकस करते हैं. आज हम लोग देखेंगे फैट लॉस और वेट लॉस में क्या डिफरेंस है. फैट लॉस कर रहे हैं तो हमारा सिर्फ फैट जा रहा है, बट अगर वेट लॉस कर रहे हैं तो हमारा डिक्रीज फिटनेस, डिक्रीज स्ट्रेंथ, पुअर परफॉर्मेंस, अर्ली एजिंग, डिहाइड्रेशन, रिड्यूस मेटाबॉलिज्म, ऑर्गन सिंक. देखेंगे एक 80 kg का पर्सन है, दोनों सेम वेट है 80 kg, बट डिफरेंस क्या है कि इसमें फैट परसेंटेज 20 है और इसमें फैट परसेंटेज 35 है. हम लोग क्या करते हैं, BMI निकालते हैं, डाइट कैलकुलेट करते हैं जनरली, बट हमको फोकस करना है फैट परसेंटेज पे। मीन्स अगर बॉडी में फैट ज़्यादा है तो वो नुकसान कर रहा है, अगर मसल वाटर का वेट है तो कोई दिक्कत नहीं। अगर हम लोग सिर्फ फैट को टारगेट करेंगे तो हमारा इंप्रूव फिटनेस, रिड्यूस स्ट्रेस ऑन हार्ट, पीक परफॉर्मेंस, डिलेड एजिंग, रिड्यूस रिस्क फॉर डिजीजेज, फैट डिक्रीजेज एंड इंक्रीज मेटाबॉलिज्म। तो कुछ केस स्टडी जिसमें हम लोग फैट लॉस किए हैं और मसल्स भी गेन किए इस मशीन के थ्रू। पर मंथ हम लोग फॉलोअप के लिए बुलाते हैं पेशेंट को, 20-25 डेज फॉलोअप होता है, फिर डाइट रिवाइज करते हैं, फिर इसके अकॉर्डिंग डाइट हम लोग का कस्टमाइज डाइट होता है। कस्टमाइज डाइट मीन्स अकॉर्डिंग टू टेस्ट, टाइम और रूटीन के अकॉर्डिंग चार्ट होना चाहिए जो फॉलो हो। पेपर पे हम कितना भी अच्छा चार्ट बना देंगे, अगर वो पेशेंट के अकॉर्डिंग नहीं हो तो फिर वो डाइट फॉलो नहीं होता है। ये सारे फैट लॉस का काम। So changes in body composition to metabolic syndrome, sarcopenia and wasting, increase in body fat and visceral fat level in patient, fluid retention due to medication, health condition, and understand nutritional status. So sarcopenia and metabolic syndrome अगर हो रहा है तो क्या क्या होता है? Mass depletion, contractile insufficiency, metabolic implant, myokinin dysregulation. So visceral fat and metabolic syndrome, and newer explanation relies on the concept of lipotoxicity as stated by Harvard Medical School, auto-determinant segmentation of subcutaneous adipose tissue, intramuscular adipose tissue, and intramuscular adipose tissue.
Summarize.
So fluid retention and metabolic syndrome, muscle quality is depend on mass and volume of muscle without fluid retention. So thank you. बेसिकली इससे रिलेटेड कोई क्वेश्चन हो जिसमें बॉडी कंपोजिशन क्यों ज़रूरी है, फैट परसेंटेज हमारे लिए क्यों ज़रूरी है। आज की डेट में बहुत सारे स्केल भी आ गए हैं, बट ये हमारी इन बॉडी मशीन FDA और ICMR से अप्रूव्ड है तो थोड़ा सा ट्रस्टेड ज़्यादा है और इसको हम लोग डेली यूज प्रैक्टिस में वर्क कर सकते हैं। थैंक यू।
Thank you, Sudhakar Misra, for such nice presentations about obesity and workshop demonstrations. Now, if any questions from audience, otherwise with wasting time, we conclude these sessions. Thank you, sir.
Thank you, Dr. Anand and Mr. Sudhakar, for such a wonderful presentation on this obesity. And we have this machine which people are making use also, and we recommend for you to go for your body composition analysis if you wish for. Thank you, sir. We move, thanks to the chairpersons, and we conclude this session and we move on to the next session. Next session we have our speaker Dr. A.K. Veermani. Sir will be speaking on use of AI in patients with hypertension, wearables and other apps. We welcome Dr. A.K. Veermani, sir. We had yesterday Dr. A.K. Veermani oration. Sir was at Ayodhya delivering another talk, so sir could not come yesterday. He came yesterday night. We welcome him for this conference. And chairpersons to this session would be Dr. Dhanvantri Tiwari, Dr. N.C. Singhal, and Dr. A.K. Arya. Please, I welcome chairpersons.
Hello, it's Singhal sir, please join us. It's always a great honor for people of Jharkhand and Bihar and especially of Jamshedpur to chair a session of none other than Dr. Anil Veermani. I'm sure he doesn't need any introduction. He's an international speaker, one of the best orator we have known, and the beauty of Dr. Anil Veermani is this, that he can deliver a talk on any subject at a very short notice. I've seen him participating in debate at a notice of 10 minutes because the other speaker was not available. So Dr. Veermani sir, all yours.
Thank you. Good morning to all of you. Honorable Chairpersons, respected Professor A.R. Rai sir, and dear friends. The topic today is, that I will be talking about is the AI, the artificial intelligence revolution in hypertension. And in the next 15 minutes, I'm going to talk about how it predicts what are the variable monitoring instruments and how do we monitor cardiovascular risk, personalized risk stratification for prevention of non-communicable diseases, implementation and ethics. Now, we all know that hypertension affects more than 1 billion adults worldwide, but unfortunately more than 70 to 80% people are uncontrolled. The ICMR index study has shown a prevalence of almost 36% with a slight age of men more than women. It's a leading modifiable risk factor for cardiovascular disease, stroke, CKD, and multimorbidity. The digital management of blood pressure relies on the office blood pressure, group risk scores, and reactive care. Conventional detection is late and episodic, and we often miss nocturnal and mass hypertension. Strategies for preventing non-communicable diseases now emphasize early risk detection, population level screening, and precision public health. And AI with variables now enable continuous data streams with individualized risk prediction. The current hypertension scenario is delayed case detection, low screenage, poor longitudinal monitoring, medication non-adherence, therapeutic inertia, there is fragmentation of data, we don't have the data in sequence, access and workforce constraints, especially in the remote and rural areas. And despite so many guidelines that we have for hypertension, there is a lot of confusion and people slip through the cracks of guidelines and we are not able to give them the right treatment. So how AI can help in hypertension? Number one, blood pressure monitoring. It can improve the accuracy and accessibility, and we all know that the measurement of blood pressure is one of the most vital things when we are managing hypertension. Screening and risk stratification. In diagnosis and monitoring, we can identify the various subtypes of hypertension like MAS and other management and decision support, personalizing treatment and improving adherence, and prognosis, predicting cardiovascular events and outcome. If I can tell a patient of hypertension they are likely to suffer from an MI or stroke, and how do we go about preventing it, that would be a multi-billion-dollar achievement. Then, of course, research. Now, we have entered in the phenotyping and the digital twin development, and I'll talk about it a bit later. So, AI can help in hypertension by improving access to care. We can have cost-effective solutions of monitoring of BP, and now accessible treatment solutions. We have the smartphones and internet connections. We can accelerate diagnosis by the various pressure sensors, the beat map, the graphic tagging, etc. And we can improve treatment by automated personalized coaching and medication. We can reduce medication errors. We can titrate based on the personal risk. So what do I mean by AI in hypertension? Now, I'll show you this is the classical BP monitoring that we are using. If you just connect it to a machine learning computer and you can process it and you can get the pulse wave analysis and you will predict whether this patient is likely to have a stroke in future or not. Then we have oscillatory devices. The simple stethoscope is converted into what is known as the acquatation stethoscope, attached to the smartphone, and it can record and basically predict a lot of things in hypertension. And then we have variable devices and huge number of them. So the main thing is this technology improves precision, accuracy, and reproducibility while making measurements easier for patients. And this is, I won't go into details of this have, normally we are using traditional risk scores like Framingham-Pillai. They are not very accurate, and we have machine learning models now which can tell us improved prediction metrics, the area under the curve and calibration. So it can even detect certain electrocardiographic signatures predictive of future hypertension. You can tell an 18-year-old boy today that he is likely to develop hypertension by the age of 25 or 30 years. Now, these are basically for targeted screening, intensive lifestyle programs, early pharmacotherapy for high-risk patients. And then we have the importances, what do these models, prognostic models do? They more accurate predictions of the risk of mortality and hospitalization of patients with hypertension. And we have various powerful visual tools like the Shandilya diagram I show you one, where you can talk about which particular list is there, predict stroke risk in hypertension cohorts, and we can prioritize patients for intensive monitoring, combination therapy, and the use of cardiorenal protective drugs. Now, there are a lot of wearable devices, not going into details, and we have like, they use plethysmography, tonometry, state causes, etc. And the basic thing to realize here is they can detect circadian patterns, morning surges, and BP variability, and all of this is related to hypertension risk, and you're getting something in your fingertips. Then we have a lot of evidence today regarding these wearable devices. More frequent readings improve adherence. There are automated alerts. You will get alert of your Apple iPhone. It can give me alert when my blood pressure shoots up more than 190 or 180 by 100. Then lifestyle nudges. These are basically of behavioral modification and remote clinician review. And we have the latest Apple Watch that has been cleared by the FDA. But having said that, please remember, these instruments do not replace validated BP measurement, but prompt confirmatory of readings and physician consultation. So don't use it as a crutch. And the potential is for large-scale screening, asymptomatic individuals, especially younger, or those who are digitally engaged patients, digitally involved. And we have various remote cardiovascular monitoring platforms. They collect and analyze long-term data for reliable diagnosis. We can detect arrhythmias, ischemia, and BP trends much earlier. It can enable a triage of alerts for the patient, for the doctor, for the health team, support proactive titration of the various useful drugs like diuretics and last drops, etc. So there is a robust interdisciplinary research is needed to harness the full potential of AI to real-time cardiovascular health management using these wearable devices. And there is one area of research which I tell my juniors, okay, go ahead and do, take up a wearable, compare it with the gold standard ambulatory monitoring, and try to find out how it is predicting the risk. And Internet of Things, where a machine talks to a machine. And look at this. It is basically ambulatory enabled ambulatory BP system. They are sending regular data and detecting abnormal patterns to the algorithms. You can detect nocturnal hypertension, and so that you can trigger for self-alert. And this is chronic cardiac disease. It can improve the quality of life. And this is what is happening. Data acquisition, processing, transmission into the cloud, concentrator, analytic. Images are made and given to the doctor for ultimate analysis. So AI-based calibration models, they cluster patient into various phenotypes, and there is graded personalized prevention strategies. It enables living risk profiles because the data is dynamic. It's not something that you have captured and like a photographer kept it. This is like a video continuously running, and you are getting data day in, day out, every minute, every second. And then I talked about this special SHAP and ladder-based explanations, and they're like visualized charts. They can tell you in a particular
Thank you, Dr. Virmani, for your wonderful presentation about AI in hypertension. I think since it's a very interesting subject, we can allow one question.
Sir, I have one question, sir. Is there any app for implementation of AI in modern medicine practice? Any application for implementation of AI in clinical practice?
Can someone give him mic, please? Mic though, yeah?
Mic, please.
Yes.
How to select right AI-based apps, because sometimes it is not carrying machine, but it is carrying machine. But sometimes it is gives it.
If you want to get the right answer from the AI, there are two things you must remember. One, the answer is going to depend on how the model was trained. If the model was not trained according to expectations, then you will never get the right answer. And that is called hallucination, that the AI is hallucinating. Number two, your prompt. A prompt means the question that you are asking has to be proper. It has to be clear question. When I say clear, it stands for level of the context, level of evidence, expectation, assumptions, and values. So there are a lot of things you have to understand before giving the right prompt. For example, I'll give you a simple example. You ask ChatGPT, what are the complications of hypertension? Finished. Now it will give you some notes that will write down. It may not, you may not like it because it's not up to the standards of your standards or the medical standards. But if you ask the ChatGPT, in a patient of 21 years, asymptomatic, developed high blood pressure, on examination clearly no endowment damage, what complication is likely to develop? Then it will give you the right answer. So you have to know what to ask for. You have to feed earlier the data has to be trained. The algorithm has to be trained to the problem.
Thank you.
Welcome, Dr. Arvinda Jagdisha. He is MD, MRCP London, FRCP Edinburgh, FRCP London, FRCP Glasgow. He is National Vice President of RSSDI, and he doesn't need any introduction in the field of diabetes. His topic is frequently asked questions in cardiorenal metabolic care of diabetes, from guidelines to ground reality. Thank you, sir. It's now your turn.
Good morning, everybody. At the outset, I thank the CCSDSI for making me a part of this conference. So, my topic is on frequently asked questions in cardiorenal metabolic care of diabetes, from guidelines to ground reality. So, greetings to all of you from Bangalore. So, understanding CRM care in diabetes, that is cardio-renal metabolic care in diabetes. If you take the diabetes complication is a complex interplay of hyperglycemia, cardiometabolic risk factors such as elevated blood pressure and lipids, obesity, and an unhealthy lifestyle. On the right hand side, you can see when hyperglycemia plays a central role, so it can lead to retinopathy, neuropathy, MSLD, MASH, obesity is interlinked, then chronic kidney disease, cardiovascular disease, atherosclerosis, heart failure, stroke, and peripheral vascular disease. So in addition, some complication increases the risk of other complications, with CKD associated with an increased risk of all-cause and CVD mortality, CVD events, and hospitalization with heart failure. So there is an pathophysiological link, that is hyperglycemia and oxidative stress, neurohormonal and nutrient sensing dysregulation, insulin resistance and lipotoxicity, impaired repair and microvascular dysfunction. So this looks a busy slide, but you can see how the cardiac and the kidney, how they are interlinked, thus diabetes being the center. Always there is a link. If you are addressing one issue, there will be a simultaneous involvement of the other organ as well. So there is an interplay between. We need to address as a whole, the CRM has to be addressed so that in the long run you will be able to prevent the complications. You can see in this slide how the link is there and how the medicines have evolved, how the modern medicines have come into the picture which addresses this CRM activity. You can see when it comes to cardiovascular dysfunction, you have that SGLT2 inhibitor, GLP-1RA and Fineron. When it comes to pancreas, you can see where it improves the pancreatic functions and it reduces the insulin resistance. You can look for the SGLT2 inhibitors, GLP-1RA and tirzepatide. When it comes to renal aspect, you can once again see the drugs like SGLT2 inhibitors, GLP-1RA, tirzepatide and Fineron. So if you take the evolution of diabetes management paradigm, so past paradigm it was more of HbA1c centric. So in 1990s and early 2000, guidelines emphasized intensive glycemic control, HbA1c less than 7, based on the DCCT and UKPDS to reduce microvascular complications. Therapy focused on insulin, sulfonylureas and metformin with minimal attention to macrovascular risk at the time. Now you can see the modern diabetes management balances glycemic control with cardioprotective and nephroprotective goals. So therapy selection prioritizes agents with the CV and renal benefits in high-risk patients as per the ADA standards of care. So the drivers of change post-2008 FDA mandates for CV outcome trials. These studies showed good microvascular benefit but little impact on the macrovascular mortality despite the legacy effect. The guideline prioritization therapy choice follows patient-centered algorithm for established ASCVD, CVD risk, GLP-1RA or SGLT2 inhibitors or DPP4 inhibitors, adding on Fineron if persistent albuminuria on AC inhibitors and ARB. Comprehensive care includes sleep, DSMEs at 5 critical times and de-intensifications to avoid hypoglycemia. You can see the key guideline shifts. Now you can see the ADA, ESD, KDIGO, our own RSSDA. We have the shifting of the HbA1c independent treatment, prioritizing the earlier use of SGLT2 inhibitors and GLP-1RA based on the comorbidities like ASCVD, heart failure and CKD. So what are the key facts? Frequently asked question when there is an evidence-based CRM care. Is HbA1c alone enough to guide the therapy? Is inadequate for type 2 diabetes therapy decisions, as it reflects average glucose but not the CV risk, renal progression or hypoglycemia. Risk-based SGLT2 inhibitors and GLP-1RAs offers benefit beyond the glucose lowering. We all know the key limitations of HbA1cs. So CV risk, HbA1c predicts the microvascular but poorly reflects the macrovascular risk. When it comes to renal, the eGFR declines and albuminuria often progress independence of the HbA1c. When it comes to hypoglycemia, HbA1c misses glucose variability and hypoglycemia risk. So when should cardiorenal risk to be assessed? So you can see the timing of the assessment. So it has to be done at the time of diagnosis and annually thereafter. So the three things are the SGLT2 inhibitors are the foundational agents in modern diabetes care, providing cardiovascular renal protection beyond glucose lowering. The second one, they are approved for use in ASCVD, heart failure across LVEF classes and CKD more than 20 eGFR. They are recommended as an early first-line therapy in type 2 diabetes with established ASCVD, heart failure, CKD or high cardiovascular risk. So the key cardiorenal benefit we have discussing again and again since many years now. SGLT2 inhibitor lowers the cardiovascular mortality and heart failure hospitalization. In DECLARE-TIMI, we've seen the SGLT2 inhibitor 17% reduction in cardiovascular death and 27% reduction in heart failure hospitalization. Beyond cardiovascular benefit, SGLT2 inhibitors slow the kidney disease progression and reduces albuminuria and proteinuria in patients with impaired renal functions. So we know the mechanism like hemodynamic effects, metabolic effects, cellular and neurohumoral effects, structural and functional protection, vascular and regenerative effects. So safety concern is always there. So we should know the basic safety concerns. Overall, if you take the SGLT2 inhibitors are generally well tolerated with low rates of serious adverse event across clinical trials and real world use. So where do you use GLP-1RA? So the primary indication you can see, it fit prominently in modern type 2 diabetes management as first-line agents for patients with established ASCVD or high CV risk, complementing SGLT2 inhibitors in comprehensive CRM care as per ADA ESD 2025. So can we combine both these SGLT2 inhibitors and GLP-1RAs? Yes, definitely you can do, because they have the advantage of weight lowering agents and cardiometabolic effects, and many times is a preferred initial therapy which lowers glucose, body fat, blood pressure and cardiac risk. Potentially it decreases the cardiac events, mortality and slows renal decline. So what is the role of metformin in the modern CRM care? We always discuss the newer molecule. Does metformin have still the role? Yes, definitely. Metformin for patients with ASCVD, heart failure, CKD, lowers microvascular risk with low hypoglycemia, CV renal effect, neutral on MACE and CV deaths, no heart failure or eGFR benefits when compared to SGLT2 inhibitors and GLP-1RAs. Early combinations with SGLT2 inhibitors and GLP-1RAs are diagnosed within 3 to 6 months for CV risk, HbA1c reduction of 1 to 1.5%, and there is a weight loss benefit. When eGFR less than 30, we need to stop metformin. So when it comes to diabetes and heart failure, type 2 diabetes markedly increases the heart failure risk, and in high risk patients with organ damage may be treated as an CHD equivalent, supporting the early users of SGLT2 inhibitors. So the managing diabetes in CKD, annual screening of CKD in diabetes involves USAR and eGFR, albuminuria more than 30. So SGLT2 inhibitors are the first line for eGFR more than 20, reducing CKD progression by 30 to 40% regardless of albuminuria. So GLP-1RAs suit patients with obesity or ASCVD. Metformin continues up to eGFR 30 with dose adjustment, while finerenone benefits albuminuric CKD. RAS inhibitors remain foundational for BP controlling, targeting less than 130 by 80. So what are the glycemic targets in CRF? It's always an individualization. Target loosens to less than 8 in older patients, advanced CKD and high hypoglycemic risk. Less than 7 suits younger patients without comorbidities. CRM shifts focus from strict A1C to cardiorenal benefits using agents regardless of baseline glycemia. Monitoring recommendation, annual CGM expands to non-insulin type 2 diabetes for real-time adjustment hospitalized CRM patients. De-intensify sulfonylurea insulin towards GLP-1 RAs and SGLT2 inhibitors to reduce the hypoglycemic risk. Guidelines agreement alignment ESE reinforces CV risk for glycemic primacy with HbA1c less than 7% as baseline but secondary to the MACE reduction. So the blood pressure targets, yes. So AC inhibitors are the ARBs are the first line in diabetic CKD, reducing albuminuria and slowing EGFR decline by 20 to 30%. Target systolic blood pressure less than 120 if tolerated alongside lifestyle measures such as low sodium diet and regular exercise. On the right hand side you can see the dyslipidemia management. Statins, atorvastatin 20 to 40 milligrams, rosuvastatin 10 to 20 milligrams are recommended for all diabetic patients more than 40 years or with CKD, CVD targeting LDL less than 70. Ezetimibe or PCSK9 inhibitors add on if targets are met, monitor and LFTs and myalgias in CKD. The next question, frequently asked question, why is obesity a central target in type 2 diabetes? There is a pathophysiological link that excess adiposity increases the type 2 diabetes risk by impairing insulin signaling and beta cell function. Even the modest weight gain raises the incidence. Weight loss rapidly reduces the ectopic fat, improving insulin sensitivity and pancreatic function. Now we have the drugs like GLP-1 RA and dual GIP and GLP-1 receptor agonists like tirzepatide are prioritized in type 2 diabetes guidelines for their robust weight loss alongside glycemic benefit, addressing the obesity as a core driver of the disease. So what are the real world barriers to CRM implementations? One is the patient level barrier and the provider level barrier and the systemic barrier. So from guidelines to practice and future direction, you can see in this slide the screening and management of heart failure in patients with type 2 diabetes. This is a flow chart which will help us we keep in our clinic, which will help us in the management of heart failure. The same thing, the optimizing outcomes in diabetes with CKD, when this flow chart tells us when to use, you can see the lifestyle modification is the baseline, then the SGLT2 inhibitors, RAS inhibitor, and the use of non-steroidal MRA all been highlighted. So this is the slide showing the flow chart showing the management of dyslipidemia, targeting the LDL-C level as well as triglyceride, especially in our populations. So treatment algorithm for type 2 diabetes and cardiovascular disease, once again it has been well highlighted where to use SGLT2 inhibitors and GLP-1 RA. So the management of cardiorenal protection in type 2 diabetes, depending upon the economic conditions of the patient and where do we practice, affordability of the patient is also prime importance, where we can give the optimal care as well as the basic care. Our role as a physician is to give the basic care to all our patients to prevent the mortality. So the future direction, shift towards individualized care, precision medicine approaches, and as Dr. Virmani sir was telling, AI-driven prognostic models are available which helps in our management. So future direction and emerging therapies, there are novel biomarkers like soluble ST2 and GDF15 showing the prognostic value, circulating microRNAs linked to vascular injury and renal fibrosis, future therapies, anti-inflammatory strategies, and exploration of anti-fibrotic agents for early kidney disease. To summarize my talk, ladies and gentlemen, diabetes is a cardio-renal metabolic disease requiring a shift from HbA1c centric control to early risk-based organ protection targeting ASCVD, heart failure and CKD. Guidelines now prioritize the SGLT2 inhibitors and GLP-1 RA independent of the baseline HbA1c, driven by proven cardiovascular, renal and metabolic outcome benefits. Timely risk assessment, individual targets and appropriate drug selections are key to improving long-term outcomes while minimizing the harm. Bridging evidence to practice through simplified algorithms, multidisciplinary care, patient engagement and newer agents enables comprehensive feature ready CRM care. In this audience, we have got diabetologists, we have got cardiologists, we have got nephrologists, neurologists. That makes the conference more fruitful in learning and preventing and giving a better care for our patient. So cardiorenal metabolic syndrome management should be individualized and integrated, prioritizing therapies with proven cardiovascular renal benefits beyond glucose control, with emerging precision and AI-based tools shaping future care. Thank you for your opportunity.
Thank you, sir, for your excellent presentation. We won't allow questions, sorry. So we move on to the third speaker, and Dr. Pankaj Hans. His subject is Finerenone, a disease-modifying therapy for heart and kidney protection.
Honorable chairpersons, respected seniors and dear colleagues, the topic of my presentation is Finerenone, a disease-modifying therapy for heart and kidney protection, and I shall be limiting my talk to this kidney protection mostly. So I shall be discussing it under these headings. I am going fast because I have got a bit larger number of slides. So type 2 diabetes, that is a leading risk factor for onset and progression of cardiovascular and kidney diseases. These days we are just seeing a global epidemic of kidney diseases. Almost 650 million is the incidence of kidney diseases, its prevalence of kidney diseases. 37% having albuminuria, and there is 10 times higher prevalence of kidney failure in diabetic patients. In stage 4 and stage 5 CKD, almost 50% patients, they have got some form of cardiac disease, and that is the commonest cause of death in these patients. Now just see over here, as the albumin-creatinine ratio that goes on increasing, mortality increases. Similarly, as GFR goes on decreasing, mortality goes on increasing in these patients. Not at all levels of GFR, whether it is more than 90, 60 to 90 or below 60, higher proteinuria means higher mortality. That is the implication of this slide. So all international guidelines we have just listened to, they advocate for at least annual screening of these patients with diabetes to rule out kidney dysfunction. In high-risk patients, it should be 3 to 12 monthly depending upon the number of risk factors the patients are having. Definition of CKD, we all know that patient might be having some structural or functional abnormalities in the kidneys that have got an implication upon the health of the patient, and or the eGFR is less than 60 ml per minute. This slide is very important to understand. We always see creatinine. Creatinine is 2, so there is not much of problem. No, it is not like that. There is a heat map of K-DIGO, just to see over there. The patient, this patient, having a GFR of 62, just see the K-DIGO has made it green. But the same patient, at the same GFR, if the patient's proteinuria is 350, it is A3 category, it is now orange in color. So risk of development of kidney disease, risk of developing renal failure, and risk of going to ESRD and dying is more if proteinuria increases. So we should target not only GFR, we should target more this albuminuria, and lesser, this should be given more importance. So this CKD, diabetes and heart failure, they share common, there is a common overlap between them, and these are the common risk factors. We have already listened about them in the last 2 talks, so not going into details of this. Histopathologically, we get tubulointerstitial damage, glomerulosclerosis, mesangial expansion and glomerular hypertrophy in the kidneys because of the drivers of CKD and CVD due to hemodynamic and metabolic factors that we have been listening to for last 2 or 3 decades. But this inflammation and fibrosis in CKD is a new concept, and that is because of MR overactivation. And that can be counteracted by MR overactivation blockade, which will block the inflammation and fibrosis, leading to kidney and heart protection. So this is about just you do this, give losartan, then the residual risk remains as compared to this losartan alone. If you combine losartan with this combined ACE inhibitor or ARB with canagliflozin, relative risk is reduced, but still there is some form of relative risk. Similarly, with dapagliflozin and ACE inhibitor or ARB, there is again some residual risk. So what can tackle this residual risk? The answer is, unless you go and tackle this inflammation and fibrosis, this residual risk is going to be present. And that can be tackled by MR antagonists. And the best one is, best known available is Finrenone, which is a bulky, non-steroidal MR antagonist. It has got maximum potency and selectivity, minimal side effects, shorter half-life, and lesser risk of hyperkalemia because of no active metabolites. There is a famous 5F. We read 5F about the causes of abdominal fullness. Similar 5F is there for Finrenone also. Initiate treatment when serum creatinine is, or serum potassium is less than 5. Withhold treatment if serum potassium goes above 5.5. Initiate treatment when GFR is above 25. And Finrenone reduces ESRD by 1/5. And Finrenone reduced the risk of hypertensive heart failure by more than 1/5. So all Fs are there. That is 5F for Finrenone. There are two famous trials for. Trials are 4, but I am just limiting myself to the 2 trials. One is the Fidelity trial, which is a large pre-specified analysis of individual patient data obtained from Fidelio DKD and Figaro DKD trial, in which Finrenone 10 or 20 milligram was compared with placebo. The eligibility criteria was type 2 diabetes, CKD. The patient must be on a maximally tolerated dose of RAS inhibitor. Patient must not have hyperkalemia or symptomatic heart failure with reduced ejection fraction. And the composite outcomes were cardiovascular and more than 55% eGFR. And this is the patient selection about the median age, RAS inhibitors, HbA1c, the various GFRs of the patient, and albumin creatinine ratio. And with the use of Finrenone upon the optimized RAS inhibition, there has been 14% reduced risk of cardiovascular morbidity and mortality, and 23% reduced risk of CKD progression versus placebo. It also offers cardiovascular benefit. Sudden cardiac death is reduced. So in Fidelio DKD and Figaro DKD, we well know for last 7 or 8 years, but the recent one, Fidelity trial, has shown that it reduces the risk of cardiovascular mortality and mortality by 14% and CKD progression by 23%. For heart failure recommendation, the use of this Finrenone gives class 1A recommendation is there. So this is very important to understand that Finrenone reduces urinary albumin creatinine ratio by almost 32% between baseline and by the end of 4 months. And ADA recommends 30% reduction of UACR for offering kidney protection to these patients. So this is a very good drug for that. Regarding side effect profile, it is very much similar to placebo, not much of difference, with little higher incidence of hyperkalemia only. Again, it is not very high, slightly higher. So if you have to start Finrenone, the first thing that you should know is what is the GFR of the patient. If the GFR of the patient is more than 60, you will start with the full dose of 20 milligram. If it is below 60 but more than 25, you will start in the dose of 10 milligram. Below 25, don't start it. Then you monitor serum potassium at the end of 1 and 4 months and then at 4-hourly interval. If potassium is below 4.8 at the end of 1 month, you increase the dose to 10 milligram to 20 milligram. It was earlier 10 milligram. If potassium remains in the normal range, you continue with the same. And if it goes higher, more than 5.5, you temporarily withhold finerenone and restart once it goes below 5. The second trial was confidence trial. In this, a combination of finerenone and SGLT2 inhibitor was studied. It has been shown that it decreases albuminuria more than either treatment alone. This was about the inclusion criteria and exclusion criteria. The patients were stratified into 3 groups. In one group, the patient was given only empagliflozin. In the second group, the patient was given only finerenone. In the third group, the patient was given a combination of the two with similar number of patients in all the 3 ends. This was about the patient selection criteria, and the end points were that just at the end of 14 days, just see at the end of 14 days, there was almost 30% reduction of urinary albumin creatinine ratio. With use of only finerenone, it took 4 months. With this combination, it took only 14 days. And once you reduce the UACR by 30%, you are going to offer nephroprotection to your patients. So that is the beauty of using a combination of finerenone and a SGLT2 inhibitor. And this reduction of UACR, that will go on further improving. And by the end of 180 days, which was the end point of this study, the fall was by 52%. 70% patients achieved more than 30% reduction of UACR, and almost 55% patients, they achieved more than 50% reduction of albumin creatinine ratio. The incidence of hyperkalemia, this is very important to understand. With finerenone alone, the incidence of hyperkalemia is higher. If you combine finerenone with a SGLT2 inhibitor, the incidence of hyperkalemia is a bit less, because finerenone, the hyperkalemic effect is mitigated by SGLT2 inhibitor. Hyperkalemia incidence is more or less same. The mean change of systolic blood pressure, you expect there should be a higher fall of blood pressure with the use of this combination. Hypotension, not much higher. And the eGFR is expected to fall if you start the combination of the two, but it is largely reversible after discontinuation. There is no low incidence of AKI after simultaneous initiation. So the takeaway from the confidence trial is that simultaneous initiation of finerenone and SGLT2 inhibitor that provides early and additive effect on urinary albumin creatinine ratio reduction that are statistically and clinically significant, and the incidence of symptomatic hypotension, acute kidney injury, hyperkalemia leading to drug discontinuation are quite uncommon. The last part of my presentation is about the standard of care in type 2 diabetes and CKD, about the 4 pillars. That is the first pillar, the long-standing use of ACE inhibitor or ARB. The second pillar is SGLT2 inhibitor. The third pillar is non-steroidal MRAs. And the fourth one is GLP-1 receptor antagonists. Now, how to use them in a patient with renal insufficiency? There are 3 approaches. The first approach is the traditional or conservative approach, in which you start with one drug, that is ACE inhibitor or ARB. Titrate it to maximally possible dose. It might take 3 months. Then you add, if you don't get appropriate result, you add SGLT2 inhibitor to it. You just re-evaluate albuminuria, continue it for 6 months. If you don't get a satisfactory result, you add a non-steroidal MRA and go on continuing it another 6 months, and at the end of this, you may add GLP-1 receptor antagonist, and this is the traditional or conservative approach. But if a patient has got higher proteinuria, the patient has got multiple risk factors for cardiovascular disease or progression of kidney disease, then the accelerated approach or rapid sequence approach should be used. In the accelerated approach, for the first 3 months only, you use ACE inhibitor or ARB along with SGLT2 inhibitors. 2 drugs should be started simultaneously. And if you don't get appropriate reduction of urinary albumin excretion, then you add to it NS-MRAs and the non-steroidal MRAs and GLP-1 receptor antagonists. Next 4 months, you titrate the dose, control the risk factors, and you will get excellent results. And the latest one is the rapid sequence approach that advocates that all 4 drugs that should be started within 3 months. Which drug you will start, that is to be individualized. If the patient is a diabetic, they start with SGLT2 inhibitor. Patient is a hypertensive, we start with a ACE inhibitor or ARB. But you add all these 4 drugs in the next 3 months, that is over a duration of total 6 months. You titrate dose, reinforce adherence of all these 4 drugs, you control the risk factors, and definitely you will get a much better result if there are multiple risk factors in such cases. So the new recommendations, all these recommendations, whether it is ADA or KDIGO or ADA, KDIGO consensus guideline, AAC guidelines, just see the level of recommendation. It is 1A everywhere, that patient in which patient is having diabetes and hypertension and urinary albumin excretion rate is more than 10, Finerenone should be added to it. So the takeaway message is that guidelines recommend both eGFR and urinary albumin creatinine ratio should be tested at least annually for comprehensive CKD screening. Early stage CKD management is often frequently missed, so appropriate intervention should be done by early diagnosis and appropriate addition. Despite a standard RAS blockade and SGLT2 inhibition, patient remains at significant risk of CKD progression because of inflammation and fibrosis. MR overactivation that drives inflammation and fibrosis, representing a key therapeutic target for CKD progression, and Finerenone targets MR overactivation, and Finerenone demonstrates efficacy in slowing CKD progression and preventing cardiovascular events with good tolerability all across the CKD stages. Thank you very much for your patient listening.
Thank you, sir. It was an excellent deliberation, but due to the shortage of time, we will allow only one question. So the topic is open for discussion. If any query. Okay, so we move on to the next speaker. Thank you, sir. Thank you. May I now request Dr. Vikas Singh to kindly please join and deliver his talk. Dr. Vikas Singh is DM Cardio. Chala gaya. Anyway, all yours, Dr. Vikas, please.
Thank you so much for the introduction, sir. Very good afternoon, everyone. And let me thank the organizers for having me here. In continuation to where my previous speaker has just left, I'll be taking you to another area of uses of Finerenone. In heart failure with ejection fraction more than or equal to 40%. And I'll be particularly trying to demonstrate through the guidelines, through the data that is available, that probably not all MRAs are the same when we are dealing with this class of patients. So this is how the talk is supposed to go. When we talk about heart failure with preserved ejection fraction, HFpEF, or reduced ejection fraction, HFrEF, we know these are two distinct entities with totally different pathophysiologies. HFrEF is mostly systolic dysfunction, HFpEF is dealing with the diastolic dysfunction part. In HFrEF, you have LV dilatation, a volume overload, thin stretched walls, and reduced contractility. On the other hand, when you're talking about HFpEF, you know it's more about the concentric hypertrophy, where you're not dealing with any dilatation and you're mostly dealing with the pressure derangements that are occurring. If you look at the fibrosis, the bottom part, it's focal or replacement fibrosis, which is in HFrEF, whereas it is mostly interstitial and reactive fibrosis, which is occurring in HFpEF. So if you think the ejection fraction good means lower mortality or lower morbidity, it's not so. First, it's important to understand that HFpEF as an entity is rising, and to a large part the reason is because we are diagnosing more of HFpEF now because of more uses of echocardiography as well as a better understanding of the subject as well. It has a very high morbidity. It ranks #1 as cause of hospitalizations in subjects more than 65 years. And not only that, it has a very high mortality as well, with more than 50% of patients dying within 5 years of diagnosis, with the median life expectancies can be up to 15 years shorter compared to their controls. And the problem area just does not stop there. Despite current treatments, hospitalizations remain a threat to patients with ejection fraction more than or equal to 40%. 1 in 5 patients are rehospitalized within 30 days. More than 50% have a risk of being hospitalized within 1 year. And each episode of hospitalization not only increases the risk of poor outcomes, but also adds to economic burdens for the patients, their family, and the country as a whole. Now, if you look at the guidelines, you compare the ACCHA and the 2023 ESC guidelines, for HFrEF, you have very clear-cut class 1A recommendations. So if there is any patient of HFrEF, you got to use MRAs, beta blockers, RAS inhibitors, SGLT2 inhibitors. There is no doubt about it. But when you deal with HFpEF, you have very few modalities which are class 1. Yes, if your patient is fluid overloaded, you have to use diuretics. They are a class 1 recommendation. SGLT2 inhibitors have of late found a place. ESC guidelines gives it a class 1 recommendation. ACC gives it a class 2A recommendations. But apart from these, look at the other modalities that are available to us, MRAs or RAS inhibitors or beta blockers. They have a very lower level of recommendation, class 2B. Of course, you want to deal with the etiology, cardiovascular and non-cardiovascular comorbidities, which is a class 1 recommendation in dealing with HFpEF patients. So this is what we just discussed, that in HFpEF, we still have a paucity of treatments which can have a good impact on mortality and morbidity outcomes. So despite the use of SGLT2 inhibitors as recommended in guidelines, the residual risk of adverse cardiovascular outcomes in patients with ejection fraction more than or equal to 40% remains high. And to give you an idea, you have data from Emperor Preserved as well as Deliver, and you can see that despite a good reduction, close to 1.8% absolute risk reduction, the residual risk remains very high. A primary outcome event occurred in 13.8% of patients receiving empagliflozin and close to 16% of patients who were receiving dapagliflozin in these trials. So when we talk about heart failure, we know there are many things going on side by side, and these are the different reasons why heart failure as a pathophysiology progresses. You have increased activation of the sympathetic nervous system, hypertrophy, ventricular remodeling, endothelial dysfunction, everything going on side by side. But for patients with HFpEF, it's MR overactivation, which is fundamental pathophysiological mechanism and drives the heart failure progression. How it does it? By causing inflammation and fibrosis. So we have seen finerenone has distinct effects compared with steroidal MRAs, and I'm not going to deal with it again here. A basic difference between finerenone as well as the previously available MRAs is, if you can just have a look at the bottom lines in these two, the MR-H12 helix conformation. With a bulky passive antagonist like finerenone, you have full MR antagonist activity, whereas when you are using spironolactone or eplerenone, there is not physically prevented from shifting back to an agonist conformation, this MR-H12 helix. And that is the reason you only get a partial MR agonist activity. So where do we stay at present? Finronone is recommended to reduce cardiovascular and kidney failure risk and the prevention of heart failure in patients with CKD and type 2 diabetes. So for this group of patients, we are very clear. Finronone as a molecule, class 1A. In phase 2 studies, Finronone was associated with smaller increase in serum potassium compared with other MRAs, and Pankaj sir discussed about it as well. It was well tolerated with fewer patients experiencing adverse events while maintaining benefit to NT-proBNP compared with spironolactone. So it is giving you the benefits which is equivalent to what you were getting with spironolactone, but with a much better safety profile, and that is what makes it better for your patients. Now moving to the fine arts heart failure trial, the trial that is going to frame the basis for the recommendation which is going to come up in times to come. Finronone trial to investigate efficacy and safety superior to placebo in patients with heart failure. So what they did here was they evaluated Finronone versus a matching placebo in patients of heart failure who had an ejection fraction more than 40%. The key inclusion criteria is just have a look at it so that you can be well versed with what patient population were chosen in this trial. Age more than or equal to 40 years, who had a heart failure diagnosis with NYHA class 2 to 4, with an LV ejection fraction of more than or equal to 40% measured within the last 12 months, structural heart abnormalities demonstrated within last 12 months, diuretics in 30 days prior to randomization, an NT-proBNP level of more than or equal to 300 or BNP more than or equal to 100 when the patient was in sinus rhythm, and the cutoffs were 3 times higher when the patient was in atrial fibrillation. Now there were certain exclusion criteria also. EGFR less than 25, plasma potassium more than 5, MI or any event that could have reduced the ejection fraction, acute inflammatory heart disease, and alternative causes of heart failure symptoms, or systolic blood pressure more than or equal to 160 millimeters of mercury. And the primary endpoint which this trial looked at it was number of cardiovascular events and total heart failure events first as well as recurrent, and there were several other secondary endpoints. So what is interesting to know here is fine arts heart failure patient population was largely consistent with other contemporary heart failure trials, but patients had more acute heart failure. So many of these patients were in a way more sicker patients because randomization timing relative to the most recent worsening heart failure events for around 20% of patients was less than 7 days. For around 34 patients, it was between 7 days to 3 months, and for around 45% patients, it was more than 3 months or no prior worsening of heart failure. So this was the basic distribution of the patients. Background medication use. So many of us would be interested to know what medications these patients were receiving. So a good number of them, close to 87% of them were receiving loop diuretics, 85% were on beta blockers. ACRBs and ARNIs, if you are going to combine, close to 80% of patients were receiving some form of RAS inhibitors. 33% patients were on calcium channel blockers. SGLT2 uses was a little low, close to 13%. GLP-1 agonist users was again low, 2.6, 2.9%, which is a reflection of what actually is the real life scenario as well. So the fine heart failure patient population was again continuing with the consistent patient population compared to other contemporary heart failure trials. The mean age was 72 years. Around half of them were females. BMI slightly on the higher side, close to 29.9. Mean EGFR of 61.9, ejection fraction close to 52%. AFib around 38% patients, and that is expected also when you are dealing with HFpEF patients. Median NT-proBNP of over 1000 picogram per ml. Prior hospitalization for heart failure close to 60% of these patients. So what came out of this trial? Finronone demonstrated a clinically meaningful 16% relative risk reduction in the composite of heart failure events as well as cardiovascular deaths. And the reductions were sustained over 3 years. Not only that, look at the initial part of the slide, the day 28 highlighted there. A statistically significant benefit was achieved by Finronone by day 28 only. So it's not taking a long time before its effects are coming up for your patients, and the effects are going to be long lasting. Finronone also demonstrated significant benefits in the secondary efficacy endpoints of total heart failure events and patient-reported health status. Whether your patient has an ejection fraction less than 60 or more than 60, you had a benefit demonstrated by Finronone in both these classes. If you think the benefit was only with the SGLT2 arm, no, it was not so. Whether or not your patient was receiving SGLT2 inhibitor, you had benefit over and above by using Finronone in both these patient population. And overall incidence of serious adverse events was similar between Finronone and placebo groups, which is again something which will make you more comfortable. Finronone increased the risk of manageable hyperkalemia, and the incidence of hypokalemia was numerically lower, which is expected as well. So the total incidence of hyperkalemia was high, but the hyperkalemia which could lead to hospitalization, it was numerically equal. So it shows benefit in all 17 assessed subgroups, whether or not your patient was of any age group, any gender, any BMI, race, across systolic blood pressure spectrum, any NYHA class, irrespective of ejection fraction or index heart failure event. So across all these subgroups, the rate ratios were in favor of Finronone, and also irrespective of what background medication your patient was receiving. So it has now a stronger recommendation for the treatment of heart failure with mildly reduced as well as a heart failure with preserved ejection fraction than the conventional MRAs in recent heart failure guidelines. And in particular, you can have a look at these two guidelines, the 2025 iCardio, which has given it a stronger recommendation compared to spironolactone, as well as the Japanese heart failure guidelines, which has again given it a class 2A recommendation in this subgroup of patients and a class 2B to the conventional spironolactone that we have been using. So again, highlighting the day 28 because of the time period, the short time period that it is taking before its effects are apparent. So to summarize, probably what are we looking at towards future? For ejection fraction less than 40%, we have the standard, the very well established 4 pillars of heart failure therapy. For ejection fraction more than or equal to 40%, you had a pillar in form of SGLT2 inhibitors. Now probably we are looking at the second pillar, which has a proven cardiovascular outcome benefit, and it's probably the time that we are going to hear more about this pillar in patients of heart failure with preserved ejection fraction. Having said that, there are many number of trials which are ongoing and which would test the efficacy of this molecule in different patient population and different heart failure subsets. So to summarize for you, there is persistent residual cardiovascular risk in heart failure with preserved ejection fraction, and proven treatment options are limited. MR overactivation is a key mechanism in heart failure. Fine arts heart failure, Finronone achieved a clinically meaningful 16% relative risk reduction in cardiovascular death and total heart failure events. It was well tolerated. It is the first and only MRA to demonstrate definite cardiovascular benefits in a broad spectrum of heart failure with mildly reduced as well as heart failure with preserved ejection fraction population, and now has FDA approval for these patients. Recent Japanese and iCardio guidelines have recommended this molecule and has given it a class 2A recommendation. Thank you so much.
Thank you, Dr. Vikas. I'm sure all of you would agree that it was a very exclusive, yes, I know, deliberation. Before we close the session, I think there is a question from Dr. K Singh. Mike. दोबारा बोलिएगा.
Really, it was a nice talk.
Yes.
Just I wanted to know one thing. Suppose if someone is having heart failure with reduced ejection fraction, less than 20, and is on eplerenone, along with all the 4 pillars, he is taking SGLT2 beta blocker, along with sacubitril and eplerenone. Should we change those patients, even though they are stabilized, having no problem, no complaint, should we change those patients on the eplerenone from the eplerenone?
No, sir, not at all, sir.
Is there any benefit?
For heart failure with reduced ejection fraction, we are very well with what we are doing. So we are talking about a patient with ejection fraction less than 20%, sir. Yeah. We are very well with eplerenone, nothing needs to be done. We are talking about patients who have heart failure with ejection fraction more than 40%. It is in those class of patients only this drug has now an edge over conventional MRAs. For ejection fraction less than 40%, we are still very well with spironolactone and eplerenone. This drug is yet to come out for this class of patients.
If someone is having above 40%, we can change. Or we should change.
Yes.
That's your message.
Yes, absolutely.
Thank you.
Thank you. Dr. Vikas deserves a loud round of applause. And in fact, all the speakers of this session. So with this, with the permission of the organizers, can we close this session? Thank you.
Coming to the next session, we have got Residency oration, that is Chairperson's oration, for which I would like to call upon the Chairpersons, Dr. K Singh sir, Dr. Abhishek, and Dr. Shaibal Guha sir. And the speaker would be Gagan Gunjan, Dr. Gagan Gunjan. Please. Thank you.
Good afternoon to all of you. Now, this is the time of Chairman's oration. I request all dignitaries to have a good round of applause to our new chairman, Dr. Gagan Gunjan. Dr. Gagan Gunjan is currently working as Associate Professor, Department of Medicine in Rajendra Institute of Medical Sciences, Ranchi. And he completed his 3-year senior residency in internal medicine from AIIMS Patna, and thereafter serving as a consultant to Department of General Medicine, RIMS Ranchi. He has been associated with various national cardio-diabetic society at national and international platform like CCDSI, RSSDI, API, IMA, actively for last many years and contributed to the organization in imparting clinical knowledge and update on diabetes, hypertension, obesity, and metabolic disease through various platforms, through regular CME health awareness camp, and as faculty to several state and national conference. He has also received several awards and appreciation certificate for his contribution to such academic activity at several occasions, and he has been actively involved undergraduate, postgraduate, and research course, and has several national and international publications to his credit. He has been authored several chapters in textbook and journal, and has won various prizes at different academic platforms. He also has a membership to various professional organizations like API, CCDSI, RSSDI, ISCCM, SEMI, GAPIOE, SNSE, and several organizations. And is an active faculty participating in various academic activities, not only in the state but all over the country. He acknowledged the mission of CCDSI to provide a unique platform for the clinician, diabetologist, endocrinologist, and cardiologist to come together and share their clinical experience and knowledge for the benefit of patient and society at large. And he has excellently formulated the scientific session of this particular CCDSI, and I congratulate Dr. Gagan Gunjan for his bright future, and Dr. Gagan always kept this objective to the forefront in all his best capacity and effort. With these words, I again welcome Dr. Gagan Gunjan, and I request our co-chairperson to felicitate Dr. Gagan Gunjan. Please, Gagan Gunjan, come on the stage.
Very good afternoon to all of you. Thanks to the chairpersons for such kind words, and I also feel privileged to have this diaspora today. As a scientific chairman, it was very difficult for me to assign the topics, and then it was very difficult for me to assign a topic for myself also, because all the good topics that came to my mind, I offered to someone else. And at last moment, I thought that in spite of attending so many conferences and doing so many organizations and CMEs and seminars, we are still telling that India is going to be the next diabetes capital of the world. Then what were we talking of? Why are we holding these conferences? Where are we failing? Let's have an insight into what we are doing and how we can improve our prescription so that what we are discussing in this hall goes to the community. If you look at this CCDSI 10th poster or flyer, then the theme is very much well known: prevention, precision, and personalization. And that's what made me to think of translating diabetic science into daily clinical wisdom, how we can improve ourselves further and how we can do better in treating the patients that matters to us. So to come to this presentation, in the next 15 minutes, I will take you through epidemiology and burden. This would be the flow of my talk: mechanistic insights, translational science and research, therapeutic algorithms, and what the future holds for us. If you look at this data, then it says that almost we are expecting 45% increase in diabetes patients from 2024 to 2050. If it is so much of prevalence with 11.1% and 589 million people are currently living with diabetes as per data of 2024, and 40% cases are still undiagnosed, then what is the problem? Despite major scientific discoveries, many findings fail to reach routine clinical practice. And this is the idea what came to my mind of discussing translational medicine and research, which is aimed to convert research discoveries into healthcare solutions. And bridging this gap can definitely improve the patient outcome. If we look at this Indian crisis, then it is says 101 million, which is the second largest global burden, and the prevalence is rising rapidly. Then what we are doing? The problem is that we have been treating so far in the last decade the diabetic patients with the numbers. We forgot the group that we also have a pre-diabetic group which is sitting below the diabetic group and ready to explode any time. And this is just what is bridging, what is failing our mechanisms and resources, and we fail to provide adequate resources what is needed in today's time. There's a glycemic gap, and definitely economic burden is there. Then we have this urban-rural gap. Initially this gap was narrow, but this gap has widened. Widening of this gap signifies that there is increase in the rural prevalence. And if you look at this, this is reflecting a growing burden in rural populations driven by lifestyle changes. And the primary drivers of this rural surge is because of the transition to processed high caloric diets, increased sedentary lifestyles, and limited access to screening and delayed care in taking the therapeutic regimen. Then we have this young onset type 2 diabetes mellitus, and both the talks of this conference, organizing secretary and organizing chairperson, gave their talks on young adolescent diabetes and how we can prevent them. And this was the idea of keeping this in the scientific program. We need to have an intrauterine programming, because if you can have this fetus control, the adverse conditions that fetus has during the intrauterine life can definitely prone them to more diabetic and retarded growth. So we need to have this intrauterine programming for better child and obesity, adolescent obesity control. Then we have genetic and phenotypic drivers. And then what is more important is young onset patients experience 3 to 4 times more clinical aggressive disease progression and earlier microvascular complications. If an older patient develops diabetes, then chances of developing complications are only 9% as compared to younger patients developing diabetes have a chances of developing complications of almost 27 to 28%, which is 3 to 5 times. So we need to have earlier aggressive control on young and adolescent diabetes. Definitely economic crisis is always there. Indian data and healthcare fundings are very low, still low, and they are not adequate to target all the rural populations and urban populations and the need of the diabetic care patients. Then on the patient part, we also have higher non-adherence, delayed intensification of the treatment, and then secondary complications like nephropathy, retinopathy, which are catastrophic. They are in the form of economic burden. So financial burden is disproportionately higher in rural settings where undiagnosed rates and lack of structured care lead to acute presentations and costly emergency interventions, and we definitely need to think on this. All those in the data making or policy making, government policies need to reconsider their decisions of expenditure on healthcare system. Coming to the typical pathophysiology, we have the core pathogenic triad like insulin resistance, beta cell failure, chronic inflammation that we have been discussing since last decade, but now we need to target beyond this. Beyond this ominous octet, we need to look into the incretin defect, like impaired GLP-1 secretion, and target these receptors directly. We need to defer the beta cell function. We need to consider the Indian population, that is South Asian thin fat phenotypic population that is prevalent in our subcontinent. Then we need to have a multi-organ approach. If we are targeting cardiorenal approach, then we need to target the cardiorenal axis instead of targeting only heart or kidney. There are certain drugs that are not just lowering the numbers, but benefiting the cardiac and kidney outcomes also, and that's what we have heard in previous session, last 2-3 sessions. Then this adipose axis definitely needs and consideration, because there are inflammatory markers impairing insulin signaling, and these insulin receptors can be targeted directly with insulin regimen instead of going for the old method approach of OHA then insulin. This is what I mean by thin fat Indian phenotype. That's what body composition, and we had a wonderful this session this morning on obesity, and we also have this body mass index composition machine right to you, left to you. Why we need to this? Because we need to thin fat Indian phenotype in what matter? It is because of even at normal BMI, there is increased ectopic fat in liver and muscle. And this is the burning topic right now of diabetes and obesity, with so many drugs coming up like tirzepatide, which led to with such of marketing and wonderful drug that is being claimed for patients, diabetic patients with obesity. So clinical implications, what we need to do in this is early detection strategies like screen the patient early, use WHR ratio before prescribing and thinking of the drug that you are prescribing, and then early intervention with insulin sensitizers, and then target visceral adiposity reduction strategies. There have been several clinical trials that have established evidence-based diabetes treatments. These trials evaluate medications, lifestyle interventions, and prevention strategies. Findings guide and clinical guidelines and treatment protocols need to be individualized based on patient outcome that you are desiring, or the patient outcome that the patient reconsiders or patient prefers for himself or herself. Gut microbiota. This was the opening session of this conference. We had a wonderful talk on gut microbiota, and we need to discuss this now, because it is no longer a bystander, but a core metabolic organ, and targeted modulation offers a path toward precision medicine in both obesity, type 2 diabetes mellitus, as well as other metabolic complications. Then we have certain specialized categories like pregnancy and elderly, where we need to prescribe drugs, but then the safety comes first there. In both old age patients, geriatric patients, and female with birth pregnancy patients, or even fetus, intrauterine fetal, keeping in mind, we need to be careful when we are prescribing certain drugs to them. We should preserve the cognitive status, maintain functional status, and manage polypharmacy. That is the most preferred drug in geriatric consideration for any disease, that because they have problems with reminding themselves of so many individual drugs. So polypharmacy pill is the most considered regimen for them nowadays. Then pharmacotherapy selection has an important role in pregnant patients, and we should not forget this when we are prescribing a pregnant lady for the same. This is the CGM that we are talking of now with the latest technologies, because this is something that is beyond HbA1c. We have been so far dealing with HbA1c, but now we need to consider this in our routine practice. Because two patients with same HbA1c of 7% can have vastly different clinical outcomes based on their glycemic variability, and this is the best way how we can tackle this glycemic variability, by keeping a monitor on 24 hours glucose, just by placing a sensor on the subcutaneously on the patient's arm or skin, and we have the entire reading for 24 hours, which can help us in prescribing the basal bolus regimen and other insulin regimens. What are the limitations of HbA1c? It is identical. HbA1c levels can hide vastly different glycemic swings. It fails to identify hypoglycemia or immediate postprandial spikes, reflects a 3-month average, insensitive to rapid therapy adjustments. So in place of this, we can have a new tool now, that is time in range, which is very advantageous to us. Time in range is defined as anything that is ranges the portion of the time that we have normal blood glucose level that a patient maintains, and more than 70% is considered to be good. It can significantly lower retinopathy, nephrogenity risk, as well as it minimizes the glycemic variability. It has the advantage of real-time tracking of glycemic stability and daily patterns. TIR more than 70% is a superior predictor of microvascular risk. Immediate feedback on diet, exercise, and medications, and that is why TIR is recommended in place of HbA1c now. We have been talking about translational research. What does it mean? It refers to the process of converting scientific discoveries into practical medical applications. It ensures that lab findings that we are applying on the patient has an improvement in the patient care. The goal and idea is to move knowledge efficiently from research settings to clinical practice and community health. If we look at this part, then we have translational research mainly focuses on two phases, phase 1 and phase 2. Phase 1 focuses on moving discoveries from lab research to clinical care, and phase 2 focuses on implementing these clinical discoveries into community health care. In diabetes, translational research helps to integrate lab discoveries with clinical care, and it supports the development of improved diagnostic tools and therapies. Then this is diabetes, where we need to move from individual drugs to weight-centric diabetes management. This is the shift in the paradigm, and sustained weight loss of 10 to 15% should be the primary therapeutic patients or target in all obesity-related diabetes. It has got good metabolic effects, and then it also helps to personalize and individualize the drugs that can help in both diabetes control as well as can target the obesity control. Then we have been talking about the precision medicine in young onset diabetes like monogenic, autoimmune, and early onset. What is the wisdom point of here having this slide here? Because if we know that the patient is having monogenic or MODI, or if he is autoimmune, then early insulin initiation is mandatory to prevent all the complications and preserve beta cell function. On the other hand, if we are targeting early onset type 2 diabetic patients, then we need to have aggressive lifestyle modifications that will halt or decrease the rapid beta cell decline which is the core target, pathogenic target of patients of early onset in diabetic patients in young and adolescents. So moving from the regular and the normal algorithm for all, we need to individualize the glycemic targets. Individualize the targets or therapies based on patient characteristics and not just guidelines or textbooks, what we are dealing with so far. The key clinical factors should be incorporated like age and life expectancy, hypoglycemia risk, comorbidities that the patient or the individual is suffering from, and what should be your patient preference, what patient wants. Patient wants to initiate insulin or patient still wants to remain on OHA, we must consider this. Simply targeting the numbers like HbA1c less than 8.0, we will go with particular groups of drugs like triple therapy, 12 therapy. It should not be like that. We should consider all these key clinical factors when we are prescribing or targeting any drug therapy or pharmacological intervention with the patient. Then, what we used to do is start with one drug, then move on to 2 drugs and 3 drugs. It is no more recommended. If the patient needs dual therapy or triple therapy, straightway go for triple therapy or dual therapy instead of going for monotherapy. What are the clinical advantages of doing it early? It targets multiple defects simultaneously. It minimizes the therapeutic inertia. It rapidly achieves your target HbA1c or TIR, and it also enhances cardiorenal protection. Then, like tuberculosis, we have here diabetic phenotype-based therapy too. We need matching drug to the patient. Insulin resistance, you need to have different drugs. If it is beta cell failure, then straightway go for insulin and GLP-1 receptors instead of focusing on other drugs like metformin. And if you have mixed phenotype pattern, then you need to consider all the triple therapy and CGM, continuous glucose monitoring, that will reveal all the diabetic data or the blood glucose levels for your patient. So based on the drug, you should match to the patient, and that is what we should do before prescribing any particular drug. Then we have still hesitation in starting insulin to the patient. This is not anymore recommended. If your patient needs insulin, go for it. Early initiation in patients with HbA1c more than 9%, then we have safety considerations and patient partnership regarding patient education and empowerment. That is, reframe insulin as organ protection, demonstrate modern pen devices to them, provide structured injection training. This will definitely act on their mind, and patient will consider himself or herself offering insulin as the first line therapy. We have certain clinical gaps that needs to be addressed in India. What are these? These are the gap communication between clinicians and the patient. Clinician has the hesitation to start certain drugs, and that is the reason why uncontrolled diabetes is rising. And you will be surprised to know that only 30% of the diabetic patients have their target HbA1c less than 7%. So we need to consider these clinical factors and patient factors. We need to remove from their mind fear of hypoglycemia and other phobia that the patient has regarding any drug, particularly insulin. That is where we are failing in setting a controlled diabetes center for ourselves. So algorithm-driven pathways, standardize the protocols, CGM integration, use real-time glucose burden, and proactive education to overcome patient barriers can reduce the glycemic legacy risk. There are certain barriers that need to be addressed, like financial burden, treatment complexity, and social stigma, that we were talking about mental or psychosocial, psychomental challenges on the first day of this conference, that we have a brief panel, we had a very broad panel discussion on this diagnostic challenges and psychomental challenges, that the patient has the inhibition of exposing themselves or offering themselves for drug therapy or insulin therapy, or telling that I am diabetic and I shall have to take this drug for a long time. We need a proper counseling to all such patients. Medication reminders, teleconsultations, and patient education platforms can definitely improve this adherence as far as patient concern is, as far as we are concerned with the patient. Then we have healthcare delivery in resource limited settings. We can use our new technologies. This is an era of AI, artificial intelligence, mobile technology, CGM technology, all are in place. Just pressing one lead, and from a distance very far you can have all the readings, whether it is heart rate, blood pressure, even ECG. So better use these strategic solutions like digital health and telemedicine. Cost-effective drugs should be prioritized, and then we can enroll, or we can take the help of community health workers that the government has provided to all healthcare centers, including all those sitting in the PSC and additional PSCs. So to integrate this clinical algorithm, first line would be to phenotype stratification. Then we need to have the step 2, that is risk assessment, and step 3 is precision therapy, which is based on combination of both step 1 and step 2. Step 1 basically targets 3 type phenotypes, that is either the patient is insulin resistance, patient is having beta cell failure, or mixed phenotype. On this strategy, we can stratify a line of treatment for individualized patients. And if then patient has the second step, where we are talking about cardiorenal or organ protection, that needs to be dealt with, taken into account before coming to step 3, which is basically prescribing the drugs. Future directions, we have digital health ecosystem. We can take a help of closed loop systems, interconnected CGM, telemedicine. Then we have clinical NLP, like therapeutic optimization, genomic profiling, polygenic risk scores, biogenetic markers, by which we can target many of the drugs or many of the diseases nowadays. Then we have this regenerative medicine and metabolic organ repair, as we discussed all this in the previous slides. So to translate this science into wisdom, let's forget the conventional part and move on to the modern wisdom part. Initially, what it was, conventional focus was on glucose-centric model, but the modern wisdom says we should be organ protective and holistic approach. We should not treat the number, rather we should treat the patient. And for this, we should have multi-system perspective. Diabetes is just not hyperglycemia. It is a vascular and metabolic syndrome affecting heart, kidney, and brain. Management must be based on multi-organ model. Early organ protection should be the key. Instead of going on for the old drugs, we should consider new drugs like SGLT2 and GLP-1, which has shown cardiorenal benefits. Then precision phenotyping, move beyond one size that fits all algorithms. Rather, we should consider Indian subcontinent population into types phenotypic matching, and beta cell reserve and individual metabolic risk profiles should be considered before prescribing the drugs. And then we have CGM and time in range to overcome all this therapeutic inertia. Data provides the objective evidence needed for timely intensification. So understanding this, knowledge is not just science, but wisdom is the courage to act on it for the patient's future. And to conclude this, let's integrate mechanistic insights into real-world data, move beyond textbooks to provide compassionate, individualized, care-rooted pathophysiology. Lead the change, overcome therapeutic inertia, utilize data-driven decision-making to advocate for early evidence-based phenotype-driven interventions, advocate for equity like address the urban-rural healthcare division, work to reduce financial burdens and improve early screening in underserved and low-income settings, and transform diabetes from a chronic disease of complications into a manageable, preventive condition using AI and precision medicine. The journey from science to wisdom is ongoing. With clinical integrity and compassion, we can turn the tide and restore hope for millions. And that's all. Thank you. Thank you very much for.
Thank you, Dr. Gagan, for a wonderful talk on this interesting topic. Since this was an oration, we won't be having any questions. Thank you once again.
Thank you. Thanks to chairpersons. Thanks to the organizing committee. Thanks to our founder, President A.N. Rai sir, Dr. Gunjan sir, Dr. K Singh sir, Dr. Shaibal Guha sir, and all other seniors for having me this privilege today. Thank you. Thank you all.
And here's wishing you all the best for your stint in CCDSI as chairperson.
My best wishes to Dr. Gagan for steering the head state. In fact, it is a two state, Bihar and Jharkhand. So, best of luck.
एक गगन के लिए एक शेर सुना देते हैं। दिलों पे नक्श जहाँ पे छाप छोड़ जाते हो, दिलों पे नक्श जहाँ पे छाप छोड़ जाते हो, जहाँ से गुजरते हो वहाँ से पहचान छोड़ जाते हो।
Sir, thank you for your kind words again.
There's a slight change in our program. We'll be, after this chairman's oration, we will be having our quiz first for the PG candidates, and then we'll have the remaining talks. Over to Dr. Sudhir. कहाँ पे?
So now it's quiz time. I request all the postgraduate students who are participating in quiz kindly come forward.
Hello.
And सामने में दो करें।
Hello.
दो ऐसा करते हैं, दो ऊपर कर देते हैं, चार नीचे कर देते हैं।
Hello.
40 सेकंड का बजट वहाँ पर लेगा। 40 सेकंड 40 सेकंड एक क्वेश्चन। अब बार-बार फिर अगला जब मूव ऑन राउंड होगा तो उसमें फिर 40 सेकंड नंबर सही।
जब कोई लगता है चार्ज हो गया फुल बता खराब हो ऐसा लगा दो लोगों का
डॉक्टर दिनकर And now I request different teams. This is team A. Team A, kindly give your introduction. Team 1. Mike, please.
Hello.
पीछे मुड़ गए.
Myself Satyam Kumar, JR2 IGMS.
Good afternoon, everyone. I am Dr. Anvika Das, JR2 IGMS Patna.
Good afternoon, everyone. Myself Satyam Kumar, JR3 GLMCH Bhagalpur.
Good afternoon, everyone. Myself Dr. Shubham Saket, JR3 JLMCH Bhagalpur.
So you are team 2. Okay. Now next, team 3.
Good morning, everyone. I am Dr. Shomodip Rai, JLMCH Bhagalpur, JR2.
Good morning, everyone. I am Dr. Himanshu Rai, JR2, JLMCH Bhagalpur.
Next,
Good
team 4.
afternoon,
My name is Rishikesh Kharkale from NSMCH.
Good afternoon, everyone. Dr. Nishad Bakane, JR2 from NSMCH.
Good afternoon, everyone. Dr. Aman Kumar, JR1 from NSMCH Beta.
Good afternoon, everyone. Myself, Dr. Rajat Kumar Singh, JR2 from Netaji Subhash Medical College, Beta.
Good afternoon, everyone. I am Dr. Rishabh Kumar from IGMS Patna.
Good afternoon, everyone. Shweta Anand from IGMS Patna.
Okay. So the rule is there will be total 6 rounds. First 4 rounds will be a pass-on round, and it will carry negative mark also. 10 marks for the correct answer and -5 for incorrect answer. While last 2 rounds will be, there will be no pass-on and no negative marking, 0 marks for incorrect answer and 10 marks for the correct answer. So we will move and we will start from, yes.
So team 1 is Dr. Satyam, Dr. Anvika from IGMS. Team 2, what's your name? Dr. Satyam. And you? Dr. Subha. From JLNMCH. Team 3, Dr. Shaumadeep, Dr. Himanshu from the same college. Dr. Rishikesh, Dr. Nishad, and NMCH Beta. Team 4. Team 5, Dr. Aman and Dr. Rajat. Okay. Team 6 from IGMS, Rishabh and Shweta. Okay.
Okay. So now we will move. The first round is pictorial round. See the picture and name. First 4 round will be pass-on round. So name this personality. Who is he?
Team 1.
Team 1.
Sir, VC Roy.
Wrong. Wrong answer, -5.
Frederick Banting.
Correct. Is Dr. Banting, who won the Nobel Prize along with MacLeod for searching insulin in 1923. Next, second team. Who is he?
Pass.
Time.
Next. Pass. Next. Pass. Next. Pass.
Pass.
Next.
Team 1.
No. Okay. He is Dr. Frederick Sanger, and he won the Nobel Prize for determining the amino acid sequence of insulin. Next, team 3. Who is she? A famous personality in field of diabetes.
Pass.
Next. Next. Pass. So, she is Professor Dorothy Hodgkin, who won the Nobel Prize for describing the 3D structure of the insulin in 1969. So, 0 marks for all the team. Next one. Next team, who is he? Famous personality in field of cardiology.
Any team?
Next. No.
Everyone pass.
Anyone? No. Okay. He is Dr. Christian Barnard, who performed first human-to-human heart transplant. Next team.
Team which? Team 5.
Team 5.
Direct question for team 5.
Pass. Next. Next one.
Team 1.
Team 2.
2.
Everyone pass.
So he is Sir Alexander Fleming, who discovered the penicillin. Next one, team 6.
Direct question for team 6.
Team 6. Who is he? A pioneer in field of cardiology.
Pass.
Team 1.
First, he performed first cardiac catheterization. But
cardiac?
Catheterization.
Name the person. You are partially right, but here you have to name the person.
Time over.
Time over. Next. Next team pass. So he is Werner Forstmann. You correctly told that he was the first person who put himself under local anesthesia and inserted a catheter into a vein and safely passed to the catheter to his heart and he got the Nobel Prize in 1956. So after the completion of the first round, what's
The score is -5 for team 1 and +10 for team 2. Rest are 0.
Okay. So again round 2. Round 2 is also pass on round and carry the same rule. Team 1, how many amino acids are there in pre-pro insulin? Next, team 2.
Yeah. 64.
64.
Pass.
Wrong. -5. Team 3.
Sir, 86, sir. 86, sir.
86. Wrong. Next. Team 6.
Sir, 81.
81 is also wrong. The correct answer is 110 amino acids. So, -5 for team 2.
-5 for team 2, -5 for team 3, and -5 for team 6.
Team 6. Next question for team 2. HbA1c level 8% approximates mean plasma glucose value of. If you know the formula, then you can calculate it.
Pass. Pass.
Next team. Team 3, pass. Next team 4, team 5, team 6, team 1. And the formula is 35 into 0.6 into HbA1c minus 77.3. And the answer is 183 milligram per dl. So 0 marks for all the team. Next question, team 3. When we celebrate World Diabetes Day yearly? वर्ल्ड डायबिटीज डे हम लोग किस दिन सेलिब्रेट करते हैं? टीम 4 पास, टीम 5 14 मार्च, रॉन्ग आंसर फॉर टीम 5 -5
14 November.
Correct. 14th November is right answer. Team 6. Next question for team, and 14th November is the birthday of not only Jawaharlal Nehru, Dr. Banting. So 14th November is the correct answer. Team 4. The fructosamine assay reflect the glycemic status over the prior how many weeks? It is measured by fraction of glycated albumin. Pass. Team 5. Pass. Team 6. Team 1. Team 2.
2 weeks.
Correct answer. 2 weeks is correct answer. Next, team 5. Which cranial nerve involvement is most commonly seen in diabetic mononeuropathy? Seven. Wrong answer. Team 6. Team 1. Third cranial nerve. Correct. Third cranial nerve is correct answer. Team 6. Teplizumab is recently approved by US FDA for which purpose in diabetic mellitus? टेप्लिजुमैब का अभी हाल में यूएस एफडीए से अप्रूवल मिला है डायबिटीज मेलाइटिस के लिए.
टाइप 1 डायबिटीज मेलाइटिस.
टाइप 1 डायबिटीज में क्या है? पर्पस बताओ.
कॉम्प्लिकेशन लेट करने के लिए, डिले, कॉम्प्लिकेशन डिले करने के लिए.
डिले. जूरी बताइए.
Team 6 now.
Delay the onset of type 1 diabetes. There are many stages. It acts on stage 2. So now again round 3, and it is again pictorial ECG round. See the ECG and give your answer. Team 1. See the ECG and give the answer. What is the diagnosis? Diagnose it. There is one sign in the ECG. See the sign and give your diagnosis.
Sir, peak T waves in the chest leads, sir,
Yeah.
hyperkalemia. Sir, peak T waves suggestive hyperkalemia.
Speak on the mic.
Sir, pass.
Team 2. Next team. Team 3. Pass. Team 4. Pass. Team 5. Pass. Team 6.
Lead 2 is showing M pattern.
Name the sign and name the disease. Pass.
You want to give the answer or you want to pass?
So it is cross test sign. It's seen in ASD. And what is the sign? Sign here is the notching of the inferior leads, lead 2, 3 and AVF. Along with, you can get right bundle branch block also. But the classic sign is notching of the R wave in lead 2, 3 and AVF. Team 2. Team 2. Diagnose it. It's a congenital condition.
Sir, epsilon wave V1 V2.
Name the syndrome.
ARVD, adenogenic right ventricular dysplasia.
Wrong answer. -5.
Brugada syndrome, sir. Sir, Brugada.
Huh?
Brugada syndrome, sir.
No, you don't get a share.
Sir, sir, sir.
बोलने के बाद
Sir,
wrong बोलने के बाद
sir, ये तो sir.
नहीं wrong जब बोल दिए तो
Sir,
wrong
comment
बोलने के
नहीं
बाद
करो, sir,
second
उसके
attempt
बस.
चलो जीरो हम लोग कर सकते हैं मेरी मार्क्स नहीं मिलेगा
Sir.
Okay, you will.
सही बोलो इसलिए माइनस.
दो आंसर नहीं बोलना. 0 मार्क्स मिलेंगे आपको. -5 नहीं होगा.
Wrong बोलने के बाद.
And correct answer is yes, Brugada syndrome. And what is there in the Brugada syndrome? Tell me.
SCN5 defect, sir, sodium channels.
There is coving ST elevation in V1 and V2 followed by T wave inversion. Next, team 3. दो आंसर नहीं बोलना है ना, जो एक बोलना है पलक. Diagnose it.
Team 3. Please on the timer.
Pass. Team 4. Team 5. Which one?
ST depression in V6.
No. Diagnose the ECG. Team 6. Team 1. Team 2. So, here the answer is electrical alternance, and it is commonly seen in large pericardial effusion. You can see the rhythm strip, there is electrical alternance. So, next, team 4. Here is the ECG. What's your diagnosis? जो लोग सर का कल लेक्चर नहीं अटेंड किए थे तो नहीं पता.
Ventricular tachycardia.
Ventricular, no.
Ventricular fibrillation.
Huh?
V-fib.
Team 4 has given the wrong answer, no?
Wrong answer.
Ventricular fibrillation. Ventricular fibrillation.
No, wrong answer. Next. Next. Team 1. Team 2.
Supraventricular tachycardia. Sine wave pattern to hyperkalemia.
Sine wave of severe.
इनिशियली हाइपरकैलेमिया में टी वेव पिकिंग इनिशियली हाइपरकैलेमिया में टी वेव टॉल हो जाता है, टी वेव डिमिनिश हो जाता है, बाद में क्यूआरएस का मॉर्फोलॉजी से डिस्टॉर्ट हो जाता है.
Good. So next, team 5. Diagnose the ECG.
Team 5.
Team
T wave inversion in V1, V2, V3, V4, V5, V6.
Say the diagnosis. Otherwise, you will get the
MI, acute MI, acute MI.
Acute MI. Next. ST segment elevation is very minimal. Next. Diagnosis. Name the sign and diagnosis.
Valence type.
Valentine, very good. Very good. So, this is Valentine, indicator of
Proximal LED occlusion.
left.
Proximal LED occlusion.
Proximal LED obstruction, very good. For team 6, diagnose the ECG.
Right bundle branch block.
Question?
Right bundle branch block.
Right bundle branch block. Next, team 1. Wrong answer. Team 2.
ARVD.
Hmm?
ARVD.
Wrong answer, team 2. Team 3. Pass. Team 4. Pass. Team 5. Pass. Here you can see the classical S1, Q3 and T3.
आर ब्लॉक भी आर राइट बंडल ब्रांच ब्लॉक भी तो होगा ना सर उसमें तो
राइट बंडल ब्रांच ब्लॉक में S1 Q3 T3
नहीं मतलब पल्मनरी एम्बोलिज्म में
ना वो तो ठीक है पल्मनरी एम्बोलिज्म में मिल सकता है राइट बंडल ब्रांच ब्लॉक
एक्चुअली स्पेसिफिक आस्किंग ना S1 Q3 T3 in which condition
pulmonary embolism
yes that is single answer
so here we are at the end of round 3 what's the score
Team 1 has given the 2 negative answers and 1 positive answer. So 0 for team 1. Team 2 has given 4 positive answers and 2 negative answers. 30 marks. Team 3 has given 1 negative answers, so -5. Team 4 has given 1 negative answers, -5. Team 5 has given 4 negative answers, so -20. Team 6 have given 2 negative, 2 positive answers, so 10 plus 10.
So team 2 is leading. So next round, round 4. For team 1, Palmer crease xanthoma is classical sign of which hyperlipoproteinemia? Type 3. Correct answer. Correct answer. थोड़ा क्लैप भी कीजिए जो बच्चे करेक्ट आंसर दे रहे हैं. ठीक है, वेरी गुड. सो टाइप 3 हाइपरलिप, इसको क्या कहते हैं? दिस बीटा लिपोप्रोटीनेमिया. सेकेंड क्वेश्चन, ऑरेंज टॉन्सिल विथ लो HDL इज कैरेक्टरिस्टिक ऑफ विच डिजीज? वेरी गुड, करेक्ट आंसर, टेंजियर डिजीज. टीम 3, straight back syndrome is related with which valvular lesion? Team 3, straight back syndrome. Pass. Team 4, pass. Team 5, pass. Team 6, Team 1, Team 2. The correct answer is mitral valve prolapse. Next question for team 4. Galaverdin effect is associated with which valvular lesion?
Aortic regurgitation.
Wrong answer. Next.
Aortic stenosis.
Correct answer. Aortic stenosis is the correct answer. Next question for team 5. The Gatson score is related to? कहाँ पर ये स्कोरिंग हम लोग यूज करते हैं? Pass. Team 6. Pass. Team 1. Team 2. Very good. CT calcium scoring. Very good. Team 2 has given the correct answer. Team 6. Award sign is seen in which cardiac condition? A very useful sign. कार्डियक कंडीशन है, लेकिन ये साइन हम लोग पल्मोनरी एरिया में देखते हैं. आप बताइए.
See, pass.
Team 2. Team 3. Team 4. Team 5. Pass. The correct answer is पेरिकार्डियल इफ्यूजन. ठीक है, क्या होता है इसमें? पेरिकार्डियल इफ्यूजन अगर लार्ज रहेगा तो फिर वो इस साइन में जो लोअर पार्ट है लेफ्ट लंग का वो कंप्रेस हो जाता है, तो कंप्रेशन के कारण वहाँ पर कॉन्सोलिडेशन का जो साइन है वो मिलता है, उसको हम लोग इवार्ट साइन कहते हैं. सो आफ्टर द एंड ऑफ राउंड 4, कैन यू टेल मी द स्कोर? इसके बाद राउंड 5 और राउंड 6 जो है वो पास ऑन राउंड नहीं है और इसमें नेगेटिव मार्किंग भी नहीं है. आपको चॉइस भी मिलेगा, आपको आंसर देना है सही या गलत. ठीक है.
टीम 1 हैज स्कोर्ड +10, टीम 2 +45, टीम 3 -5, टीम 4 -10, टीम 5 -20 और टीम 6 +20.
So again, team 2 is leading. So in round 5, so next for team 1, norepinephrine activates which receptor in large artery leading to vasoconstriction? Alpha 1, correct answer. Team 2, in denervated hearts, the rate of intrinsic heart rate is approximately 60. Wrong.
-5.
ना हो गया एक बार एक आंसर उसमें 4 तो ऑप्शन ही है. So 0 marks for team 2. The correct answer is 110. Denervated heart leads to tachycardia, resting tachycardia. Team 3, ideally the width and the length of the blood pressure cuff bladder should be what percentage of the arm circumference respectively? Width कितना होना चाहिए arm circumference का और length कितना होना चाहिए?
मैं 40 110 40 110
40 110 no. Wrong answer, it is 40 and 80. 40 and 80. Okay. For team 4, which one of the following heart sound is of lower pitch? इन चारों हार्ट साउंड में कौन सा लोअर पिच का साउंड है?
Opening snap.
Wrong, it's tumor plop. For team 5, which one of the following is not a differential diagnosis of ST segment elevation? बताइए. सी, हाइपोथर्मिया. रॉन्ग एंड इस इज हाइपोकैल्सीमिया. हाइपोथर्मिया में जो ऑस्बॉर्न वेव बनता है उसमें एसटी एलिवेशन के साथ ही बनता है ना. जे पॉइंट जो है ऊपर के चला जाता है. सो लास्ट क्वेश्चन ऑफ राउंड 5. Omecamtiv mecarbil is a new drug for the heart failure management. What is the mode of action?
So B, myosin activation.
B, myosin activation. Correct answer. Myosin activation is correct answer. So after round 5, what's the score?
लेते हैं सर इसको.
ये और इसको जोड़ते जाओ.
तो इसको ऐसे करना पड़ेगा. So team 1 is on plus 20, team 2 plus 45, team 3 minus 5, team 4 minus 10, team 5 minus 20, and team 6 plus 30.
So next round.
Last round, no?
Last round. Raised blood glucose is feature of all except. कौन से कंडीशन में हाइपरग्लाइसीमिया नहीं मिल सकता है? कौन? रॉन्ग आंसर। कौन में हाइपरग्लाइसीमिया मिल सकता है, हाइपोथायराइडिज्म में जनरली नहीं मिलता। नेक्स्ट, एज पर एडीए, women who had GDM should be screened for type 2 diabetes mellitus development at least every how many years? किसी को GDM हुआ, ठीक है, तो फॉलो अप में कम से कम कितने साल में स्क्रीन करना चाहिए? टाइप 2 डायबिटीज डेवलप 3 years. Correct answer. 3 years is correct answer. Which one is the true statement about GCK Modi? Very high postprandial blood glucose may require treatment only during pregnancy. Microvascular complication occurs very fast, and autosomal recessive. See, microvascular complication occurs fast. Wrong answer. The correct answer is, it is a mild disease, autosomal dominant, and it requires treatment only sometimes during the pregnancy only. So, next team 4. True about acanthosis nigricans are all except
B. Thickening of subcutaneous tissue.
Very good. Correct answer. There is thickening of the skin, not subcutaneous tissue. Very good. Team 5. Whipple's triad is used for the diagnosis of very good, correct answer. And the last question for team 6. Which renal tubular acidosis is commonly associated with diabetic nephropathy? डायबिटिक नेफ्रोपैथी में कौन सा रीनल ट्यूबुलर एसिडोसिस कॉमनली मिलता है?
बी.
बी. बी. रॉन्ग आंसर. इट टाइप 4 RTA. Type 4 RTA. So that's the end. Now at the end of the all 6 round.
So the final score for team 1 is +20, team 2 clap, team 2 +55, team 3 -5, team 4 0, team 5 -10, and team 6 +30. Team 2, Dr. Satyam and Dr. Shubham from Bhagalpur. And second position from IGMS, Dr. Rishabh and Dr. Shweta with score +30. Third is team 1 with score +20, Dr. Satyam and Dr. Anvika Das from IGMS.
and there is prize money for the winners, and winners are requested to stay here till valedictory function along with the poster presentation. The winners, you will be felicitated.
Those who have participated, they will get the participation certificate. You are supposed to come with that fast. Come fast. And everyone will get the participation certificate. That we will announce at valedictory, so that all of them will stay. Otherwise, rest of them will. And the result announcement for poster presentation will be done during valedictory function. So all of you are supposed to stay.
To chair the next session, may I invite Dr. M. Hayat, Dr. A.K. Arya sir, Dr. K.K. Lohani sir, chair कर दें. ये कौन है? हाँ. I will invite Dr. A K Singh sir for Varanasi to present his talk, sir. So kindly come on the stage.
So, we all know Dr. A K Singh. He is very much part of our CCDSI team and belongs to UP and Ghazipur. He is in the medical college. So, without wasting time, I request Dr. Singh to go ahead with his deliberation.
Thank you, Chairperson, for your kind words, sir. At the outset, I am highly obliged to the organizers of this conference, especially Dr. Gagan, Gunjan, K Singh, for giving me the opportunity to be here and share my view with you all. My topic is diabetes in elderly, the key aspects of the management. The prevalence of diabetes, it is very high, around 25 to 30%. And according to the longitudinal aging study of India, it is around 20%. In elderly, diabetes is a major contributor of morbidity, functional decline, and mortality. Here, management differs because the different health status, comorbidities, altered pharmacodynamics, and increased risk of hypoglycemia and limited life expectancy in elderly. So, individualization of the glycemic targets, careful drug selection, and emphasis on functional outcomes are central to optimal care of diabetes mellitus in elderly. Management requires balancing glycemic control with safety, prioritizing quality of life, and prevention of complications rather than strict glycemic control. So, in elderly, it is distinct. The managing diabetes in elderly patient is not simply an extension of the standard adult care. It requires a fundamentally different approach. Why? because there is a different pathophysiology in elderly, like altered insulin sensitivity due to the increased visceral adiposity in them, reduced physical activity, and also the presence of sarcopenia. There is also beta cell dysfunction with increasing age. And there is also age-related metabolic shifts like increased hepatic glucose production and impaired postprandial glucose regulation in elderly. So all these require the tailored treatment strategy. Prevalence is high, I just have told it, and risk is elevated. In elderly, that is older adults, they face amplified risk of macrovascular complications, genetic syndromes, including falls, cognitive decline and frailty, an increased risk of the hypoglycemia, functional disability and polypharmacy in them. The clinical presentation, the typical clinical presentation are the polyuria, polydipsia, polyphagia and recurrent infections. But in elderly it is not true. There are atypical presentations like fatigue, weight loss, confusion and functional decline. So the many elderly diabetics who present first time in the elderly age group, so they present with complications rather than classical symptoms. There are unique challenges in elderly, heterogeneity of the health status like different categories, hence individualization of the treatment is needed. There is increased risk of hypoglycemia, which is due to the counter-regulatory response decrease in them, decreased awareness of the hypoglycemia and increased fall risk. This hypoglycemia lead to fall and fractures in them, cognitive decline and increased incidence of the cardiovascular events. Polypharmacy is very common in elderly, so it leads to the drug interactions, increased adverse effects and reduced adherence. And cognitive impairment is also there, which may be mild or it may be dementia in them. It complicates self-monitoring and adherence to the therapy. Types and risk factors, the type 2 diabetes, it predominates in the elderly, but type 1 also persists into old age. It also requires district management considerations. The key risk factors, they are obesity, physical inactivity, family history and ethnicity, especially our Asian populations. Prediabetes is also very high and often undetected. So early lifestyle interventions can delay or prevent progression. Screening and proactive risk stratification are essential in older adults. So the holistic evaluation framework, like medical conditions, here diabetes type, duration, existing complications and comorbidities, they guide the therapy selection and intensity of the therapy. Functional changes like frailty, mobility limitations and self-care ability, they determine which regimens are realistic and safe in them. Psychological, that is screening for cognitive impairment and depression is critical. Both significantly undermine the self-management capacity in them. And social factors like caregiver availability and living situation, they shape adherence, safety and long-term success. Screening for genetic syndromes, it is essential in elderly. So older adults with diabetes are at heightened risk of conditions that go beyond glycemic control and which profoundly affect treatment safety. So in everyone, we should screen for the falls, urinary incontinence and pain yearly. And we should also review the polypharmacy. If they are taking more than drugs, we should de-prescribe the drugs. And then we have to assess cognition and mood of them, and then we have to reassess and plan accordingly. Individualized glycemic targets, balancing risk and benefits. Overly aggressive glycemic control can be more harmful than beneficial in older adults. One size does not fit all. So targets must be calibrated to the patient's overall health status, functional capacity and life expectancy. As category 1, comparatively healthy elderly, here health is fair, functionally independent, life expectancy is more than 10 to 15 years, there are minimal complications and comorbidities and no cognitive impairment. In them, the target HbA1c, it should be 7 to 7.5%, fasting blood glucose 90 to 130 and bedtime is 90 to 150 mg per day. Category 2, it is complex or pre-fail. Here health is intermediate. They are functionally dependent on others. Life expectancy less than 10 years. Complications are present, they are moderate, and cognitive impairment is mild, but comorbidities are many there. Here target HbA1c it should be 7.5 to 8, and fasting blood glucose 90 to 150, and bedtime it should be 100 to 180. And category 3, that is frail or end of life. Here health is poor, they are functionally dependent, life expectancy less than 5 years, complications are too many, and there is severe cognitive impairment. Here target HbA1c, it should be 8 to 8.5 or no target. Fasting blood glucose should be 100 to 180, and bedtime 110 to 200. Here focus is main to avoid hypoglycemia and relief of the symptoms. That is more important here. The management algorithm. So in elderly, first we have to assess functional status, frailty, cognition and comorbidities. So individualized glycemic targets as per the health status of the elderly. Start lifestyle modifications including diet and physical activity. These are very important, diet and physical activity. Start metformin if renal functions permit. Add DPP-4 inhibitors or SGLT2 inhibitors if target not achieved. If cardiovascular disease are present, SGLT2 inhibitors or GLP-1 they are preferred. If oral therapy is inadequate, which we can start insulin, but simple basal insulin regimen is better than any other things. And regularly we have to reassess hypoglycemia risks, and we should try our level best to simplify therapy. The lifestyle, it is the cornerstone. Healthy diet, that is very important. So it is adequate protein. Protein should be more, not less in elderly. Adequate protein to prevent sarcopenia, and balanced carbohydrate intake, and avoidance of the overly restricted diets. Usually elderly have sweet tooth, so some sweet is allowed in them. And regular physical activity, that is 150 minutes per week moderate exercise. Here resistance training, it is really important in elderly because it improves their muscles and it will be better for the insulin resistance and diabetes. It provides better mobility, improves insulin sensitivity and reduces cardiovascular risk. So it has to be adapted to individual ability and mobility, and it remains the first line intervention. Weight reduction, it is also very good. It is effective, it improves glycemic control in obese elderly, but excessive reduction, it should be avoided. Smoking cessation, moderate alcohol intake and stress reduction, they lower overall cardiovascular risk, and social support and mental health care are critical drivers of the long-term adherence. Pharmacology therapy, drug therapy must consider renal function, hypoglycemia risk, drug interaction and functional status. Metformin, if it is effective drug, weight neutral and have low hypoglycemia risk, it has to be avoided if eGFR is less than 30 or in cases of malnutrition or if there are severe frailty. DPP-4 inhibitors, they are well tolerated, weight neutral, low hypoglycemia risk, and they are preferred even in frail elderly. In CKD, their dose adjustment is needed. SGLT2 inhibitors, they are good, weight reduction and cardiorenal protections are there. But in elderly, risk of dehydration because thirst sensation is reduced in elderly, so dehydration is a very important risk in them, or genital infections, especially in frail elderly. They should not be given. They should be avoided. And GLP-1 they also cause good weight reduction and severe benefits, but they have the injectable administration. So if we should avoid, especially in elderly. Sulfonylurea, they are of low cost, but they should be avoided because of the high hypoglycemia risk. Insulin, in cases of failure of the OHA or in severe hyperglycemia, the simple basal insulin regimen is preferred and complex regimen should be avoided. Here monitoring is needed. The prevention of hypoglycemia. First, we should identify high-risk individuals like persons having renal disease or cognitive decline. We have to prefer drugs with minimal hypoglycemia risk like DB4 inhibitors, avoid aggressive HbA1c targets in frail elderly, simplify insulin regimens, and educate patients and caregivers. It is really very important regarding symptoms and signs of the hypoglycemia and glucose monitoring. Common complications, cardiovascular disease, they are the most important. They are leading cause of the death in diabetic patients, then diabetes per se. Kidney disease, here regular monitoring is needed, and frailty and sarcopenia. The loss of muscle mass, it worsens metabolic control and outcomes. So, physical therapy integration is a key component of the management. For the prevention of sarcopenia, higher protein intake and regular muscle exercises, they are very important. Management of the comorbidities, where CV risk reduction should be done. BP targeted should be less than 140/90, not 130/80 as in younger age group. And LDL cholesterol, it should be less than 70 as usual. And antiplatelet therapy, we should give in established CVD cases. Geriatric syndrome, especially frailty, because it causes increased mortality, hospitalization and disability. So, it should be treated with the optimal nutrition. It is, again, it is very important. Increased protein. If sarcopenia is there, here the daily dose, it should be 1.2 to 1.5 mg per kg body weight, gram, not mg, sorry. So, and adequate carbohydrate should be there, and resistance exercise, it is needed in them. But avoidance of over treatment should be done. False depression, cognitive impairment and urinary incontinence, they should also be taken care of. And the coordinated care in long-term settings, the key principles are deprescribed when appropriate. So, we should take care of the polypharmacy, individualize glucose targets, prioritize oral agents over insulin, and engage family and care staff as partners. So, these are some emerging tools like continuous glucose monitoring, telemedicine and digital support, and personalized education programs. And now to conclude, a patient-centered approach saves life. Nuanced individualized care, diabetes in older adults, that demands recognition of each patient's unique medical, functional, psychological and social context. No single protocol fits all. Therapeutic decisions must consider life expectancy, comorbidities, functional status and risk of the hypoglycemia. Integrated management optimizes outcomes, combining lifestyle interventions, evidence-based pharmacotherapy and comprehensive genetic assessment delivers the best clinical results. Empower patient and caregivers. Educated, supported patients and caregivers are the most powerful tool for improving quality of life and preventing serious complications in them. Thank you very much, and the greetings from the holy city of Varanasi.
Thank you, Professor K Singh sir, for beautifully dealing with the diabetic treatment of diabetes in geriatric population. And sir is also associated with Geriatric Society of India, and he is past president of Geriatric Society of India. He had been president of Medicine India and Indian Society of Hematology. Sir, you have beautifully elaborated all the aspects of diabetes management, and we came to know that the main thing is to avoid complication, hypoglycemia, and rather than only focusing to HbA1c reduction. If any question is there, then the questions are welcome. Then next, our learned speaker is Dr. Abhishek Kumar. He is consultant physician, and his area of interest is diabetes and related disorders. He is National Secretary of CCDSI and Executive Member of RSSDI, API and Lipid Association of India. He is Associated Professor of Netaji Subhash Medical College at Bihar, Patna. Over to Dr. Abhishek Kumar.
Thank you, Chairperson. Respected Professor Rai sir, seniors and dear colleagues. I thank Dr. Gagan, Gunjan and team, Dr. BK sir, Dr. Shaibal sir for this opportunity. Rather, this talk was planned on 13th because you can say the topic is just like the introductory topic about the obesity. And since past 2 days, there has been many discussion about almost all components of the obesity in various lectures and even in the panel discussion. So my topic is just the summation or summary of the talks which were discussed in past 2 days. We all know that obesity is not just a cosmetic issue. Rather, it is a chronic, relapsing and multifactorial disease. Obesity is relapsing. आज ओबेज हैं, कल सही होंगे और परसों फिर से ओबेसिटी हो सकती है. So it is a relapsing disease. The prevalence has increased dramatically across both the developed and the developing nations. And currently 1 billion individuals are living with obesity, representing about 13% of the global population. And if we talk only about the developing nation, we are 70%. The 3 nations who have maximum obese people are China, India and USA. In many regions like the sub-African countries and the war-torn countries like Iraq, there is a double burden of malnutrition that is due to the obesity and undernutrition both. So many countries this is happening. This is due to 2 things. One is the genetic factor and the other is obesogenic environment. Our food, our habits, our changing lifestyles all leads to interaction between the genetic component or genetic predisposition of ourselves, and this environment gives the obesity. So almost 30 to 40% of all doctors are also comes in this category. We know that fat is not a neutral entity. It is an active endocrine organ producing adipokines, inflammatory mediators that disrupts the metabolic homeostasis, leading to insulin resistance, systemic inflammation, finally endothelial dysfunction and all the complications. So my topic was, what are the consequences of obesity? So let us see what happens if adipose tissue starts dysfunctioning. There is a balance between adiponectin and the leptins, and in adipose tissue dysfunction this balance becomes distorted, and that leads to the chronic low-grade inflammation, insulin resistance, ectopic fat distribution. जहाँ फैट नहीं होना चाहिए वहाँ भी फैट होगा, like the liver, muscles and all area. Finally endothelial dysfunction and even neurohormonal dysfunction also. So if we talk about the diseases, the well-known disease related to obesity, the first comes to our mind is the type 2 diabetes mellitus. It has been seen that obesity, even severe obesity, has a known risk factor, and practically we can say that this is modifiable risk factors. If it is not strongly genetically related, then we can modify this factor. The severe obesity can be modified. So it is a modifiable risk factor for type 2 diabetes mellitus. And in remission also, whether it is sustained or not sustained, that is another issue, but weight loss has significant effects. Like that, nothing much can be said about the metabolic syndrome. We know that central obesity remains one of the component of the metabolic syndrome, and this is central to all other manifestation of the obesity. In cardiovascular consequences, hypertension is strongly related. It has been seen that the weight reduction leads to the decrease in the blood pressure and thereby improvement in the cardiovascular outcome. Coronary artery disease, since the pathophysiology of dyslipidemia, inflammation, insulin resistance, and the endothelial dysfunctions are central to coronary artery disease. No doubt, obesity is causing or contributing to all of these. So, we can expect that the CAD increases in the obese patient, and this is the reality. Likewise, the heart failure, especially the heart failure with preserved ejection fraction. It is particularly associated with the obese people and, of course, the atrial fibrillation. We can see many patients of 45 to 55 years of age coming to our OPD. Obese patient usually hypertensive and comes with the atrial fibrillation. So atrial fibrillation has a definite relation with the obesity. In hepatic consequences, there was a panel discussion yesterday moderated by Professor Lohani sir. Everything has been discussed about the liver disorders, and of course obesity remains one of the component of all these manifestations of liver disorders. In the respiratory consequences, obstructive sleep apnea is well known, associated with the obesity at the neck thickness. Likewise, there is an entity obesity hypoventilation syndrome, in which the patient have chronic hypercapnia, hypoxemia, and finally develops the pulmonary hypertension. And these patients may turn into the right heart failure and the increased mortality. So this is also related with the obese people. The weight is associated with osteoarthritis because of the physical and inflammatory both regions, and gout is associated with obesity mainly because of the hyperuricemia in the obese people. In endocrine and reproductive consequences, PCOD, we know it is common in the obese female. In males also, the male hypogonadism due to the reduced testosterone is more common in obese as compared to the normal weighted people. In oncological consequences, obesity has been linked to many cancers, including the breast cancer, endometrial, colorectal, pancreatic, liver, even esophageal and the kidney cancers. And several mechanisms has been proposed, including the chronic inflammation and hyperinsulinemia in these patients. In kidney, there is a damage by the excess inflammation of the fat that leads to the obesity related glomerulopathy. Obese people are more prone to have respiratory infections, and we have seen in the COVID-19 waves that the mortality or the morbidity both were more in the obese as compared to the non-obese people. And overall, obesity related death has significant presence globally due to its cardiovascular cancer and the diabetic complications. And finally, the psychological and neurocognitive consequences of obesity is there. Apart from the social stigma, school bullying and all these things, psychological stress is there with the obese people, and sometimes उनको लगता है कि हम घूमने जाएंगे, लोग कहेगा कि मोटा आदमी देखो टहल रहा है, तो शायद वो घूमना भी नहीं चाहते हैं. So that leads to self isolation. या उन्हें ये लगेगा कि घूमने टहलने से मेरा वेट कम ही नहीं होता, पार्क में लोग मजाक अलग से उड़ाते हैं, तो क्यों जाए घूमने. तो this happens. So there is a significant mental stress of body shaming in these persons also. And finally, the economic burden. It has been calculated that by 2035, the global cost of obesity related treatment will be 4.32 trillion annually. So this is about 3% of the worldwide economy. So to summarize with what we eat, what we do, how we live, and how we behave, especially in the eating and the physical activity, or leads to this vicious cycle leading to obesity and various manifestations which we have discussed. Everything, think about any disease, you will find the obesity in the center. Now we are moving towards the proteomics, genomics, multimenomics, like that, and newer pathophysiology mechanisms and biomarkers are emerging. Like diabetes, we think about what is there in pre-diabetes stage, then the diabetic stage, then the complication. Obesity is also can be think like that in a healthy people, then pre-obese, then frank obesity. Finally, this disease progresses and obesity related complication comes. So at each and every level, there has been research, and definitely with the incoming of the AI, we can generate data on multiple things. It starts from the genomics, epigenomics, transcription factors, various protein and translational things associated with these metabolic disorders, and finally many other things like gut microbiome. There was a lecture on the day one in this conference on gut microbiome. So we are starting from just a fat tissue and going to the cause and try to assess what can be done to reduce this obesity epidemic. However, medical science has not elucidated till now. Obesity is saying, just recognize me whether I am cat or elephant. Sometimes we consider obesity as a cat, but in true sense, it may be elephant for a particular person. So clinical approach, ideally not in my talk, but just to conclude it, we have to do the risk assessment based upon my previous slides. What are the risk factor and what is the available resources with us in lab, in history and examination. We have to do the risk assessment, we have to assess the burden of disease and screen for the complication. And in management, the first management is change in the lifestyle. The second is also lifestyle. The third is also lifestyle. And finally comes the pharmacotherapy and even the surgery like the bariatric surgery. But of course we can do conferences on terzipeptide and Wegovy and all, but it is very difficult to change the lifestyle of the people or enter their needs. So we have to go inside the patient preference and try to do best among the available resources with us. So we can say that it is a chronic relapsing metabolic disorder rather than a lifestyle condition. The obesity, especially the visceral obesity, is very dangerous, but it is modifiable, and it is one of the strongest modifiable risk factor for all the metabolic disorders, especially the diabetes. And we have seen that weight loss has significant positive effects. We must screen the patient, especially at least for 5-6 diseases, including the NFLD, sleep apnea, diabetes, cardiovascular, and other system at the first encounter of these patients. Thank you.
Thank you, Dr. Abhishek, for a very wonderful presentation on a topic in your title you have written, is it the right time to ponder? As a chairperson, I can say this is not the right time to ponder. This is the right time to act.
Act, yes, sir. Time to ponder has already crossed.
If you remember, this year, World Obesity Day, the slogan given by WHO is 8 billion causes to act. 8 billion is the world population, and they have taken this figure 8 billion. So you can understand how much serious people are throughout the world, including our Prime Minister. So it was a very good talk, and house is open for queries. 1 or 2 questions we can take up. So no question. It's time to act, not to discuss. So thank you very much.
Sir.
And now I request the third speaker and the last third speaker of the session and the last speaker of today's conference, Dr. Sujit Kumar, isn't it? Yeah, Dr. Sujit Kumar is well known to all of us. He is one of the backbone of this conference at Rajgir. He is a Bihar Sharif based physician, and he will be discussing another very important topic, beta cell function in chronic pancreatitis.
Before Sujit starts, I would like to congratulate him. He is the de facto organizer of this conference, because all of us were non-residents and he handled everything staying here.
Thank you, Shaibal sir.
Thank you.
And not first time, almost every conference of physicians or IMA in this region, he has always been very, very important person.
Thank you, sir. Thank you, Chairperson and organizing committee, to giving me opportunity to stand in front of you. There is nothing new. The pancreatic, chronic pancreatitis, diabetes, pancreas, all are equally related. We are dealing with last 2 to 3 days about diabetes. The culprit organ is pancreas. So with some sort of underdiagnosed this thing, we are always talking about type 1, type 2, etc. But some view of this, the chronic pancreatitis is also a component, and thus finally lead to chronic pancreatitis and diabetes is the level of type 3 diabetes mellitus. So type 3 diabetes mellitus is a secondary form of diabetes associated with exocrine pancreatic disease, primarily chronic pancreatitis. Also, it's too many names, pancreatogenic, pancreatic, pancreatocryptic diabetes. But the disease is actually underdiagnosed. This syndrome is overlapped with type 2 diabetes mellitus especially. So secondary to chronic pancreatitis inflammation characterized by both endocrine and exocrine failure, and involves progressive loss of islet cell type. Official recognition by American Diabetes Association and the WHO classified as a diabetes secondary to exocrine pancreatic disease, formerly pancreatogenic or pancreatoprevic diabetes. The changes in nomenclature reflect a move towards the precision of defining etiological causes. Epidemiology very much high of type 3 diabetes mellitus due to rising rate of pancreatic disease and surgery. Type 3C diabetes is now more prevalent in adult than type 1 diabetes. Prevalence is often underestimated due to systemic diagnostic failure. Really, the surprising, the ratio is 5 to 10% of all diabetes cases. And one of the state like Kerala, all you know, chronic calcification in diet state due to some genetic or some topaya eating property, whatever, but the very common of pancreatic damage and then leading to diabetes mellitus. The 49% cases is always mixed diagnosed, especially with type 2 diabetes mellitus. The major study found that nearly half of the type 3C diabetes mellitus cases are incorrectly labeled as type 2 diabetes mellitus, most commonly, or very few with type 1, leads to inappropriate insulin delay, overlook exocrine insufficiency needs, and obscure the high risk of pancreatic cancer. Precise classification is the gateway to effective pancreatic enzyme therapy. At the spectrum of type 3 C diabetes mellitus, the chronic pancreatitis undoubtedly is the most common cause. It is around 79%. Second one is pancreatic cancer, hemochromatosis, cystic fibrosis, pancreatic surgery, and etc. Genetic drivers and risks are RSS1 gene variant cause hereditary pancreatitis and lead to an early median age of diabetes diagnosis, there's a 48% developed diabetes. A SPINK gene is a very common in, as we mentioned, in Kerala is chronic pancreatitis. This gene is responsible, undoubtedly. Family risk. Genetic screening is critical for families with recurrent pancreatitis to prevent sudden metabolic crisis. Beyond beta cell loss, global islets failure is the main cause. Unlike type 1 autoimmune destruction of beta cell or type 2 insulin resistance, type 3C involves total island destruction, including alpha cell, beta cell, PP cell, loss of polypeptides. An association of exocrine synergy is also important. Destruction of the exocrine tissue leads to nutrient malabsorption, further destabilization of endocrine function, and the never tissue failure exocrine drives the resistance tissue islets into dysfunction. The incretin response paradox, blunted type 3 response, the nutrient malabsorption lead to an impaired incretin response like GLP-1 and GIP, further diminishes the meal-stimulated insulin release. Hepatic insulin sensitivity paradox is like this. Peripheral usually exhibits high or normal sensitivity to insulin in the early stage of compared to type 2 diabetes. Hepatic is also responsible for significant reduction in sensitivity, leading to unsuppressed hepatic glucose production and finally result in morning hyperglycemia. That is down phenomena is often served due to uncontrolled liver glucose dumping. The unique diagnostic marker is pancreatic polypeptide. The pancreatic polypeptide level are statistically lower in absence in type 3C diabetes compared to type 1 and type 2. Polypeptide act as a modular or hepatic insulin receptor. Its absence explains the hepatic insulin resistance. Measuring fasting polypeptide level remain a specialized but powerful tool to differentiate. This is the differential clinical landscape. There's the exocrine function in type 3 diabetes, like that's also called pancreatic insufficiency, impaired. Type 1 is normal, type 2 is normal. Islets autoantibody absent in type 3C diabetes mellitus. In type 1 it is present and type 2 it is absent. Glucagon response is low or absent, impaired in type 1 and high in type 2. Ketosis risk factor is lower in type 3C diabetes. In type 1 it is very high and in type 2 it is low. Diagnostic criteria, measure. The exocrine pancreatic insufficiency confirmed by monoclonal fecal elastase 1 test or impaired secretin test. Pathological pancreatic images is essential. Evidence of calcification, ductal damage or atrophy via CT, MRI, USG. Absence of type 1 autoantibody negative for GAD65, AI2 and ZNT8 antibody. Diagnostic criteria, just a minor criteria like absent pancreatic polypeptide, blunted response to the meal or mixed nutrient, insulin sensitivity, normal peripheral sensitivity but high hepatic resistance often noted clinically, and also due to pancreatic insufficiency there is associated vitamin deficiency like low serum of fat soluble vitamins like A, D, E, K due to chronic malabsorption syndrome. Minor criteria help distinguish complex cases where imaging might be equivocal. The role of pancreatic imaging is very important in this type of diabetes. That's the CT scan, detect calcification and gross structural atrophy, MRI, MRCP, ultrasound. Imaging probes to structural cases of the functional diabetes defect. The synergy of lifestyle toxins like smoking and alcohol also act as a synergistic toxin that intensifies genetic risk for diabetes in chronic pancreatitis. It accelerates symptom onset by decade, directly inhibit islet cell regeneration and increase risk of transition to adenocarcinoma, and abstinence is the most powerful non-drug therapy available for this case. The brittle diabetes, metabolic fragility. The brittle diabetes in type 3C diabetes mellitus is defined by severe erratic swing from hypoglycemia to hyperglycemia driven by a total glucagon loss. Managing severe hypoglycemia, like no safety nets, glucagon deficiency impaired the liver's ability to activate glucogenesis. Pure glucose, treat with pure glucose only to avoid digestive delay from the fat and fiber, and the risk factor are alcohol use and poor estrogen intake further exacerbate the crash risk. Continuous glucose monitoring is the modern standard for the care. Is essential for detecting postprandial spikes and predicting imminent hypoglycemia. HbA1c often fails to reflect daily fluctuation. CGM provides the time in range metrics and immediate alert for nocturnal crashes. For brittle patient, CGM is a life-saving safety layer, not just a luxury. This is the nutritional foundation. This is the क्या खाना है नहीं खाना है, best food to eat, vegetable, fruits, whole grains, protein, healthy fats, eat in moderation, just white rice, potatoes, avoid क्या आपको avoid करना, all we know. And the pancreatic enzyme replacement therapy is mandatory for nutrient absorption. Enzyme improve the incretin response, help attenuate high postprandial blood sugar, requires multiple small frequent meal, and a small strategy snacks between meal prevent fasting hypoglycemia. What is our pharmacological strategy to treating such type of patient? The first drug starting with metformin, all we know, and this is the concern issue. First line of mild cases, metformin is recommended for the mild hyperglycemia. Let's say HbA1c less than 8 and suspect insulin resistance. Cancer protection may often protection against pancreatic cancer. Caution is gastrointestinal side effect like nausea, diarrhea can worsen existing symptom. Metformin ability to curb hepatic glucose output in patient with type 3 diabetes mellitus, C diabetes mellitus. Yearly insulin is indicated in and main strategy to treating such type of patient of pancreatic efficiency induced diabetes mellitus. The diagnosis is screening for exocrine loss. Oral therapy start with metformin. Basal only is preferred, morning dose, full dose bolus, tight meal timing. Basal is identified, administered in the morning to decrease the risk of severe nocturnal hypoglycemia. GLP-1 receptor antagonist is re-evaluated in such type of cases, and the recent large-scale meta-analysis do not support a class-wide risk for pancreatitis. Denying these therapeutic to patients with history of pancreatitis may be unwarranted. All we know, some cases are noted in GLP-1 receptor antagonists like complication like pancreatitis. This is the surgical intervention, islets isolation for patient on pancreas, portal infusion, infusion into portal vein to preserve function, metabolic stability, prevent the severe brittle state post, and 10 years success, long-term C-peptide release maintenance. Surgical solution, total pancreatectomy plus islets autotransplantation, a surgical option for intractable pain that raises non-surgical treatment. Islets are isolated from the patient to on pancreas, infused into the portal vein and prevent the brittle state of total pancreatectomy. Prevalence enough C-peptide to prevent severe complication for 10 years plus. Summary and core takeaways are early diagnosis via imaging and fecal test is mandatory. Management must prioritize to hypoglycemia safety over tight HbA1c control. exocrine and endocrine management must happen in synergy. Thank you.
Thank you, Dr. Sujit Kumar sir, for elaborately describing all the aspects of pancreatic diabetes, from its etiology, pathogenesis, differentiating from type 1 and type 2 diabetes, from type 3C diabetes. You have dealt in excellence up till pancreatic transplantation. If any question is from audience, that is most welcome. And I would like to, because he is senior among senior most physician of our town, Bihar Sharif, Sujit Bose had always been a source of inspiration for all the members of Indian Medical Association Bihar Sharif, and we are very happy to introduce him that he is Vice President of IMA Bihar chapter, and he had been Vice President of India IACM, and now he is working as Associate Professor of Bhagwan Mahavir Institute of Medical Sciences, and is successfully running Jeevan Jyoti Multi-Speciality Hospital, where right now cardiac catheterization, CABG, and all these things are going on.
Thank you, Hat. This is your kind words, and thank you. I am the last speaker, so thank to everybody who come to Rajgir and give me opportunity, including organizing committee, to serve you. Thank you.
Thank you. And now I hand over the stage to our organizing secretary, Dr. Shaibal Guha, for further program.
Thanks to all the speakers of this session. I would request the chairpersons and the speakers to go to the podium, and I'll request Dr. K Singh sir to give away the mementos. I'll hand over the mic to Dr. Sudhir to announce the names of the PG quiz winners and the PG poster session winners. Over to you, Dr. Sudhir.
So, sir, now it's time for prize distribution for the poster presentation winner and quiz winner. I request our Guru, Professor Dr. N. Rai sir, to kindly come over the dais and bless our PG students. Dr. Dinkar.
So I am announcing the winner of. I would like to request Dr. K Singh sir to come on the stage. Shaibal sir. please come. Dr. Gagan, please come. Mithunjay sir and Dr. Vijay sir. Dr. Sujit sir, Dr. Dharmendra. I am announcing the winner of poster presentation. The first position in the poster presentation goes to Dr. Nishad Bakne from NSMCH Beta.
Please come forward first. So our founder,
the prize money is
giving.
The prize money is 4,000 rupees
There is no need
in
to
cash.
announce that. There is no need to announce that. Big round of applause for the winner of quiz. आ जाओ दोनों दूसरा कहाँ है?
Second winner for poster presentation goes to Dr. Anvika Das from IGMS Patna.
Amount बोल दो.
The prize money is rupees 3,000 in cash.
So congratulations and big round of applause for the second winner.
Third position goes to two students.
So joint winner.
Joint winner. So I would like to invite Dr. Abdullah Khan from KMCH Katihar and Dr. Himanshu Raj from JLN MCH Bhagalpur.
So they will share the amount.
These two winners share the amount, as the amount was 3,000 rupees. So each one will get 1,500 rupees. Money is not very important. The zeal, enthusiasm and the participation is very, very important.
Sir, ये momento उसको हाँ.
And congratulations to all the participants. Participation is the main thing. You came here, gave your participation. This is the main thing. This is the zeal, enthusiasm, and we will see this in future also.
Now the quiz winners are
थर्ड पहले फिर सेकंड फिर फर्स्ट कर दीजिए. थर्ड पहले
the third winner is third position Dr. Satyam and Dr. Amika Das from IGIMS Patna. And the amount is rupees 5,000. Third prize. Oh, 3,000. 3,000. 3,000. Sorry. Memento है उधर उधर है.
ये यहाँ मोमेंटो यहाँ ये लीजिए मोमेंटो ले तुम ले लो
ना दे दीजिए दोनों को दे दीजिए. अच्छा उनको मिल गया. The second prize goes to Dr. Rishabh and Dr. Sweta from IGIMS. And the prize money is 5,000. Congratulations. Now, the first prize, it goes to Dr. Satyam and Dr. Subham from Jawaharlal Nehru Medical College, Bhagalpur. And the prize money is rupees 10,000. So congratulations to all the postgraduate participants and all the winners. And the prize money is sponsored by our patron, Professor Dr. Devi Ram sir. So a big hand for Dr. Devi Ram sir.
सबसे पहले तो मैं कहूँगा कि जोरदार तालियां बजाइए दो महारथी के लिए जिन्होंने पूरी कॉन्फ्रेंस में जान ला दी है। और ये दो महारथी हैं डॉक्टर सुजीत कुमार एंड डॉक्टर धर्मेंद्र। मैं रिक्वेस्ट करूँगा कि शॉल लाया जाए। शॉल उसमें है, शॉल लाइए। शॉल शॉल दो शॉल लाइए। सुजीत निकल गया? अच्छा, सुजीत का सवाल हम लोग धर्मेंद्र ही ले लेंगे। अरे लाइए भाई, कहाँ पे? वैलिडिटरी फंक्शन यूजुअली धन्यवाद देने के लिए होता है फ्रॉम द ऑर्गेनाइजिंग कमिटी टू द वो सर वो बाद में चला जाएगा सर। तो उस क्रम में मैं धर्मेंद्र जी से सहायता लूँगा। इस पूरे ब्यूटीफुल परिसर जिसमें ये कॉन्फ्रेंस हुआ और ये 7 दिन के अंदर सारे प्रोग्राम किए गए, तो सबसे पहले मैं रिक्वेस्ट करूँगा पंकज जी को, जो इंडो हॉकी होटल और दिस रॉयल रेसिडेंसी के तरफ से रिप्रेजेंट कर रहे हैं, तो मैं उन्हें आऊँगा और मैं सर से आग्रह करूँगा कि इन्हें मोमेंटो दे करके इनकी हौसला अफजाई की जाए। किसी तरह का प्रोग्राम कराने में हम लोग की सहयोग करें और इवेंटलेस माने कोई भी इस तरह की शिकायत होटल की तरफ से नहीं आई है। अरे बंद हो जा रहा है यार। दूसरे क्रम में मैं कैलाश जी को आमंत्रण दूंगा। तुम ये रहो, कैलाश जी को आमंत्रण दूंगा। रॉयल राजगीर रेजिडेंसी होटल बहुत ही अच्छी व्यवस्था उन्होंने की और वहाँ हम लोगों ने डिनर किया और रूम सर्विसेज भी काफ़ी अच्छे रहे। तो मैं कैलाश जी को एक मोमेंटो देकर सर से आग्रह करूँगा कि वो सम्मान दिया जाए। इसी क्रम में जो आपने देखा होगा ये पंडाल जो बनाया, जो इस स्टेज बनाई है और प्रोग्राम्स को अच्छी तरह से सुचारू करने में जो सहायता की है वो मिश्रा टेंट हाउस वाले गुड्डू मिश्रा जी से मैं आग्रह करूंगा कि वो आप आएँ और हम लोग के तरफ से एक टोकन ऑफ रेस्पेक्ट की तरह आप रिसीव करें। सर यही गुड्डू मिश्रा है जो पंडाल बनाने में पूरा साथ दिए हैं और 7 दिन के अंदर सारी कुछ इरेक्ट कर करके जो कहा गया इन्होंने सब किया है। सो गुड्डू मिश्रा जी आप आए। शशि भूषण जी कैलू कैटरर हैं हम लोग के, जो अपनी खाना बनाया इन्होंने 3 दिन तक लगातार। हमको लगता है 3 दिन ये सोए नहीं हैं और लगातार खाना बनाने में वही है। हो सकता है कि कुछ हल्की फुल्की त्रुटियां रही हो, लेकिन इन्होंने अपने तरफ से पूरा मेहनत किया और इनके लिए हफ्सा अफजाई के लिए मैं चाहूँगा कि मोमेंटो दे करके सर सम्मानित करें। मैं अमित जी से आग्रह करूंगा कि वो आए बायोबिट फार्मास्यूटिकल्स के। और आशीष जी कहाँ हैं? आशीष जी आए, ऑडियो विजुअल 3 डॉट्स के तरफ से है और इन्होंने ऑडियो विजुअल हर जगह जहाँ भी हम लोग जाते हैं संभवतः 3 डॉट के तरफ से ही करते हैं। तो जो भी 3 डॉट्स वाले हैं आप आ जाएं और आ करके पूरा टीम आ जाए और हम लोग के तरफ से एक रिसीव करें। वो क्या किया? छोड़ो हटा नहीं।
राजीव कुमार सर, ये सागर खन्ना और राजीव कुमार, और आप लोग करना चाह रहे हैं सर फार्मास्यूटिकल्स वालों को।
कौन है?
राजेश कुमार बायोबिट।
राजेश कुमार जी हैं बायोबिट के।
SBI।
सागर खन्ना एलिस फार्मा के। MAT फार्मा से नीरज जी या तरुण जी या हैं IM। पूरी ट्रांसपोर्ट व्यवस्था जो पिक एंड ड्रॉप थी इन्होंने इसमें पूरा योगदान दिया और लगे रहे सबको रिसीव करने में, एयरपोर्ट हो चाहे कहीं भी हो। तो मैं चाहूँ जल्दी आइए।
रजिस्ट्रेशन नोवेली से।
आ जाओ आगे जाओ। कौन बाबा है?
रजिस्ट्रेशन वाला
नोबेल नेल्सन। मैं नेल्सन फार्मास्यूटिकल से जो रजिस्ट्रेशन का चार्ट देख रहे थे, मैं आग्रह करूंगा कि वो आप स्टेज पर आएँ और मोमेंटो ग्रहण करें। आपने पहली बार कर रहे थे इसलिए कुछ न कुछ थोड़ी बहुत त्रुटियां रही है, लेकिन इनका मोटो ठीक था और इन्होंने बड़ी मेहनत की 2:30 बजे रात तक। लेकिन कोई बात नहीं है, होता रहता और ऐसे ही लोग सीखते हैं। तो रजिस्ट्रेशन की तरफ से अगला बार ठीक हो जाएंगे। और हमें तो लगता नहीं है कि और कोई। अभिषेक का मोमेंटो छूट गया था, तो मैं आग्रह करूंगा कि अभिषेक को मोमेंटो दिया जाए, क्योंकि आपने अपने जो डिलीवरेशन था उसके बाद आपने सेल्फी पॉइंट पर फ़ोटो नहीं खिंचाया। तो सर से आग्रह करूंगा कि यहीं पर खाना खाने चले गए थे तो यहीं पर इनका स्वागत किया जाए। हालांकि हम भी खाना नहीं खाए अभी, लेकिन पहले ही खा लिया हमने। अभिषेक कौन है? नीरज किसका है? हाँ, तो नीरज जी लेट आए तो छूट गए। फ़ोटो आके खिंचा सकते हैं आप, फ़ोटो आके खिंचा सकते हैं। तो इस तरह से ये वैलिडिटी फंक्शन का हम लोग शपामत की से भर रहे हैं। सभी लोगों का बहुत बहुत धन्यवाद कि आप लोगों ने हमें मौका दिया अपना सेवा करने का, अपने डिलीवरेशन सुना। जो भी त्रुटियां रही होगी उसके लिए रिस्पॉन्सिबिलिटी मैं लेता हूँ। जो भी त्रुटियां हैं उसकी रिस्पॉन्सिबिलिटी मैं लेता हूँ, और जो भी अच्छे हुए हैं उसको पूरी टीम को देता हूँ। तो पेपर वाले कोई मीडिया से हैं? उन लोग को सर हम लोग दिए हैं, बैग सब मोमेंटो दे दिए हैं। कल हम लोग मोमेंटो और बैग पेपर वाले को दे चुके हैं। नहीं वो कल दे दिए। हाँ हो गया कल शाम में दे दिए। और कोई बचे हुए हैं? कोई बचे हुए तो सर इसी के साथ हम लोग का ये समापन सत्र सर की छत्र छाया में डॉक्टर राय साहब नहीं सर, छत्र छाया आपका है, वर्कर हम लोग हैं और जितनी टीम। हाँ मैडम से आग्रह करूंगा कि सभी लोग आए। आप लोग आइए। हाँ ग्रुप फोटो आ जाएगा। अरे भाई फोटोग्राफर फोटो खींच रहे हो ना यार। मैं ना कोई बात नहीं है। पॉट लेते आओ गुड्डू, लाओ। तीन तो पॉट। हाँ झाड़ी वाला ही है बस। निकाल। पढ़ाई बस।
गए ना सामान अपना ये करने, तो लौट के आ रहे थे तो बोले हम खा अभी कहाँ जा रहे, खाइए जाइए, हम उसी में हमको दे रहे हैं। हम तो तुरंत हाथ मार देने से कि